the follow-up visits. And in Western Uganda, really, we have a very high incidence of, we have a very high burden of prostate cancer. And the problem here is that most of these patients present with advanced disease. And the advanced disease is anyone who has stage 3 or stage 4 of prostate cancer. And as of the data of 2023 and close to this financial year, really, we have close to most of the patients, about 90% present with advanced disease. And the issue is that amongst these patients who have prostate cancer, one of the biggest challenges is that they can end up developing chronic kidney disease. However, the data is not known in our setting, and even data on incidence is quite reduced. And one of the issues is that people who have prostate cancer, especially those who have stage 3 or stage 4 disease, are at a very high risk of developing CKD. And multiple mechanisms really are involved. For instance, certain therapies that we use to manage the advanced prostate cancer, such as zoledronate, and we have certain comorbidities that our patients have, things like diabetes, hypertension, as well as HIV. All these tend to accelerate the development of CKD, of chronic kidney disease. And so these are some of the mechanisms, really. The cancer itself can cause a secondary membranopathy. We have things from the obstructive uropathy, and we have both bone and renal metastasis. Now, the thing is that patients who have prostate cancer and chronic kidney disease, even in the best countries, these patients have very poor outcomes because it's quite difficult to treat them. And even the rates of renal transplant for some of them is quite low. So these patients have a higher mortality than other patients. And so we were really motivated to study the progression of chronic kidney disease in this patient population. And so we set out to determine both the incidence and predictors of chronic kidney disease amongst our patients at oncology unit. And so we did a retrospective study whereby we looked for patients that were admitted into care at oncology unit of Mbarara between the years 2019 to 2022, January to December. And we realized that we took anyone who actually didn't have kidney dysfunction, who did not have chronic kidney disease at baseline. Then we followed them up for a period of 2 years. And we excluded anyone who had more than 50% of their missing variables and those who contributed less than 3 months in the oncology unit, because for these patients, we could not be able to determine our outcome of interest. And so we extracted data from 212 files. In particular, we took the serial serum creatinine that was done at baseline and with each and every visit, and we calculated their estimated GFR. Our primary outcome was the incidence of chronic kidney disease. And we defined this as an eGFR less than 60 for at least 3 consecutive months. And so in our study flowchart, really, we identified 332 files between January 2019 to December 2022, of which we exclude 120 patients, whereby 48 of these people had baseline eGFR less than 60, and 72 were lost from the clinic before completing 4 months in our studies. We were left with only 212 patients, of whom we followed for 2 years and analyzed. And when you look at our baseline characteristics, most of our patients really were the elderly patients with a mean age of 73. One of the things that raised an alarm to us is that we have very many patients who are presenting late from the diagnosis of the prostate cancer and starting treatment. We had a great delay whereby we had some people coming up to after 3 years, some even after 5 years. And most of our patients, 90% of them had high-risk disease. We had a good deal of patients who had anemia at baseline and people who had obstructive hydronephrosis secondary to obstructive uropathy. And so what does this mean? We calculated the incidence, and we found that our 2-year cumulative incidence of chronic kidney disease in this population was 20.28%. And put it into context, that's actually quite high. And if we look at the incidence rate, it's about 1 per 1,000 years, and we are quite confident that, 95% confident that the incidence rate falls between 0.74 to 1.34. And when we did our Cox hazard proportions model, we found that if you look at stage 3 disease and stage 4 disease, in the bivariate analysis, they're actually they were quite significant, whereby with your stage 3 disease, you are 4.8 times more likely to develop chronic kidney disease, and together with stage 4 disease as well, whereby you are more at 5.7 times more likely. If you had hydronephrosis at baseline, at enrollment, at admission into the oncology clinic, you are 2.23 times more likely to develop chronic kidney disease. And if you had anemia, which is defined as an HB less than 13, you are 2.5 times more likely to develop chronic kidney disease. Hypertension and diabetes didn't seem to be didn't appear to be predictors. And when we adjusted for confounders, what we found is that stage 3 becomes even much more significant. It jumps from 4.8 times to 7.3 times more, making someone more likely to develop chronic kidney disease. And the same with stage 4 disease. And hydronephrosis and anemia are still quite significant. And if we look at the Kaplan-Meier analysis graph, really, we see that most of the people develop chronic kidney disease within the first 6 months. And by the end of 1 year into treatment, we see the risk reducing, the incidence of CKD reducing. And so what does this mean? In our study, we concluded that the 2-year cumulative incidence of chronic kidney disease is quite high in our setting, and most people develop it within the first 6 months. The things that we found the risk factors included advanced disease, that is stage 3 and stage 4, anemia, and presence of hydronephrosis. And so we do recommend that we have to intensely follow up these patients in the first 6 months, preferably in the first 1 year, really, because it's important for us to ensure a multidisciplinary approach, involve both the nephrologist, the oncologist, and as well as the urologist. I'm sure it's good to see Professor Simon here, and so he will help us in that department of getting rid of the difficult to manage hydronephrosis we get. And in addition, we also we strongly recommend that we do a prospective study of such a design and follow up patients prospectively. And it's important for us to understand why is it that our patients are coming in late after they have been diagnosed. And so I would like to appreciate my research team. I would also like to appreciate the Internal Medicine Research Fund and the study participants. Thank you.
Thank you, Dr. Frederick. I would now request our session panelists to take their seats upstairs.
Okay, thank you very much, Olive. I hope everyone is still okay. Are we still awake? Are we still attentive? Yes, we are. Okay. So we would really want to thank all the presenters for this first session, and I'm going to request that they take the seats on the platform, and I'm also going to request that it's at this point that you feel free to ask questions directed to the presenters, and we can remind you the presentations that we have had. But if you have the program outline, you should also be able to follow that. So we had a talk from Dr. Bagasha on hypertension in pregnancy, followed by Dr. Bate, who spoke to us about hypertension in children. We had the pleasure of listening to Ellison about intradialytic hypertension. Dr. Junju, CKD among patients with hepatitis B, chronic hepatitis B. And then Dr. Bongomin has taken us through CKD in patients with prostate cancer. So please feel free to raise your hand and we will find you with a microphone and you can fire any question.
Any questions? Please raise up your hand and I'll be there.
I would like to thank this morning's presenters, Dr. Sekasanv, my name's. I think I'll ask questions in order of how the presentations were done. I think for Ellison, I'll just make a comment. He presented a paper on intradialytic hypertension. And he mentioned several factors why we see it and ways of managing it. One thing we should note, we as people who use dialysis as a treatment modality, is that fluid overload generally manifests as increased blood pressures in our patients. So if you have your patients whose BP control is poor, or who develop new rises in their BP, you should take care of their fluid balance. And this is easily measured by looking at the intradialytic gain weight gain in your patients. And if your patients have got high intradialytic weight gain, chances are that your ultrafiltration rates are going to be high while you are trying to achieve the previous dialysis weight. So this should be a basic thing that you should observe in the dialysis units. However, one thing I want to ask you is, and others who do dialysis, is how frequently you use dry weight as your baseline measurement or target for managing your patients in your dialysis units. You can either answer directly or you can ask introspect. Because if you don't do that, then you are likely to face issues of intradialytic hypertension. Dr. Junju, you have a very nice study, but you said kidney disease, so I don't know which one, acute, chronic. Because I think NGAL is more specific in diagnosis of acute kidney injury. And you did not profile your patients to tell us if they had AKI, what was the real cause. Did some of them have hepatic syndromes like acute fulminant hepatitis or severe hepatitis and other associated comorbidities? And you also didn't tell us, your treatment rates were actually high. 40% of your patients were on treatment, and I was wondering what the indication was. But according to what you told us, they had TDF as one of the drugs in their treatment protocol. So I don't know how much of your kidney disease was associated with the TDF therapy. And if so, you have not told us whether these patients had change in their treatment protocol. Dr. Bongomin, I don't know whether you biopsied any of your patients to establish the exact cause of the kidney injury, that it was associated with the cancer or some other disease. I think I better stop here. I also wonder, Dr. Bongomin, as patients were progressing in their kidney, in their cancer, as well as initiation of treatment, you seem to have higher rates of kidney injury. So was that associated with other factors, patients vomiting while on chemo, fluid status, and so on?
Thank you, Dr. Sekasambu. I asked the people to take note of the questions. Let's take another question. Thompson.
Okay, thank you very much. My name is Thompson. My question is directed to Dr. Bagasha. You presented a very good work about hypertension in pregnancy. Now my question is, I'm challenged with a younger couple. They have just gotten married. These are younger people, but accidentally or The lady has gotten pregnant and is on dialysis. What is your take on that? Thank you.
Thank you, Masereka.
Yeah, my name is Baraba Now Francis. My concern is about a kidney patient in relation to the GFR. You mentioned that if one has got GFR of 60, between 60 and 90, and for 3 consecutive months, that person will be safe from kidney problem. Is that true? Now, if I test and I find that I'm 60, 62, 65, but I'm on drugs, and for 3 months, I am within 60, up to 70, 65, and all that, do I stop the drugs and say I'm cured? Do I keep on drugs forever? So to me, the 60 GFR seems to be low. And when you go, they say anybody who has got GFR less than 90 has got a kidney problem. But we have put it so low that someone less than 60 is the one who has a kidney problem. I see what I got you right. Me, I'm one of the patients, and this was my doctor. These are my doctors. So, so when you say that 60, I'm free, so I'm going to say I have no kidney problem. And that information can be misleading. So it needs to be put right. And for us kidney patients, we believe in GFR because we are amen. You say your GFR is this, I know I'm this. If you want to know the extent of damage of your kidney, you say, can you compute for me the GFR? I would know there I'm a bit comfortable. To me, GFR of 60 seems to be low, and it contravenes what we see in Google and what doctors tell us. But for you are saying that. So what is your take about that?
Thank you very much, sir, for such a wonderful question, and thank you for representing the others. I'll take one last question just before I allow the... Oh, okay.
Thank you to our presenters. I'm Dr. Judith. I'm Taira. I'm a physician. My question is to Dr. Junju, more in relation to what Dr. Sekasam has commented about your study on hepatitis B. I mean, these patients were on TDF. So we don't know if that CKD was really TDF or not. And maybe, in my thinking, it would have been very nice if you had looked out for biomarkers of TDF-related kidney injury in these patients, and maybe would say it's TDF or it's not TDF. And then to Edison, congratulations on completing your study in time for the MED program. I'm concerned about your use of the CKD EPI 2021 formula. Yeah, it's the newest kid on the block and all that. But studies, every study now shows us that in our adult population in sub-Saharan Africa, the CKD EPI 2021 is actually underdiagnosing CKD. So maybe your sensitivity analysis, well, if you still have time to do that, or if you're still going to defend, could look at the CKD EPI 2009 formula. And then to Dr. Bati, children with hypertension, well, it's unfortunate that we actually have children with hypertension. I've not thought about it. It's not something I've already thought about. That could be a problem, but I'm wondering what are the long-term outcomes of these children you'd find with hypertension, regardless, of the causes, or is there a way of actually prognosticating and you know what their outcomes are likely to be? Or any markers that can prognosticate them and you know their long-term outcomes? Thank you.
Thank you so much.
Thank you so much. Thank you. So my question, or maybe a comment, goes to Ellison. Thank you for the good work that you do. Really, to add on to what Dr. Sekasam was saying, this issue of using target weight, we struggle with children, and it's good there was also a talk on hypertension. It is really hard sometimes to get the hypertension under control, but let's try to use that target weight. Sometimes we try to set it for the few children that come there, but maybe to remember children are growing, so that it's supposed to be adjusted as the child grows. And I wanted to ask you whether you, because sometimes children come direct to your side, then we see them later when they come for review. How much, to what extent are you seeing intradialytic weight gain? Because children are really difficult to fluid restrict. They even steal water. And on this side, we are struggling to manage that hypertension even chronically. You're setting the target weight or the dry weight, keeping in mind that growing it, adjusting, but they also drink a lot of water. Thank you.
Yeah, thank you so much. Thank you, participants, and to our presenters. Allow me give them opportunity to answer our questions. Allow me start with Dr. Bate to answer the questions that have been directed to you.
Thank you, James. But you started with the one with the least questions. But anyway, yeah, so long-term issues or complications of hypertension in children. I think one of the problems we have, especially in our setting, is that first we don't have the studies to tell us how things turn out. When I was in Canada where we're doing nephrology, every time we were doing cardiac echoes to see their hypertrophy, we were doing so many investigations over time. And you would still see some children who are having cardiac remodeling, especially when the blood pressures are not controlled. Then we do the ambulatory blood pressure monitoring, even if the blood pressures seem to be normal in clinic, to just make sure we limit those complications. But at least what we know is that if we don't control the hypertension, we are at risk of these complications happening and cutting down on the life of the child. One of the things I think which Dr. Ujo is talking about is, I think when we are having a child who we are preparing for transplant, and they have AKI or CKD and they are on dialysis and blood pressures are not controlled, then they are getting into heart failure or the hearts are failing. There we are very concerned and we still see the effects. But what we do is to run as much as possible through the process to ensure that we do quick transplant and control the BPs. But probably, maybe as we do more studies and follow-up studies, we shall know how much is this affecting the clinical outcomes of our children as they grow older. I know some few post-transplant children, still the ones that we are managing, still have hypertension. And maybe those are some of those children that we shall be comparing because we have their echoes at baseline, and maybe years to come we shall see if they are still getting the same complications that we see in adults. Thank you. Mr. James, where do I hand the mic to?
Thank you so much for listening. The question that was asked to us, the dialysis team measure the nurses and the technician, how frequently we use our dry weight. Do we achieve dry weight for our? I would say this is a very big challenge in our setting, and it's mostly majorly because we cannot sometimes control the patient's intake. They tend to drink more, and every time they always have high weight because they have gained a lot. More so during the dry times. A patient will come when they have gained 7 kilograms, 6 kilograms. Literally, if you're to take off all the 7 liters, 6 liters, you're supposed to give them 6 hours. Or sometimes we encourage them to do at least 3 times a week dialysis so that we can try to achieve that. And again, the other challenge is the financial constraint. They cannot afford to do 3 times a week. Most of our patients do 2 times a week, and even some do once a week because of the financial constraint. And then in children, it is actually sometimes very hard to achieve the dry weight in children. As Dr. Batty and Dr. Karwa said, they tend to drink more, and sometimes they are with their mothers. They are very sympathetic to their babies, and they always give them whatever they ask. And the few babies that we have there in dialysis, they usually have very high weight. And you cannot take off too much because a child will come when they have gained 3 kilograms, 4 kilograms, and you cannot do a 4-hour dialysis. This is a child, you cause a disequilibrium syndrome, you give them 2 hours, the maximum you can take is 2 hours, 1 liter, 1.5. So it's actually a very big challenge to achieve dry weight in children. We need to look into that. It's a very sensitive area to look at. And then for the adults, it is us, the nurses team, together with our nephrologist, always counsel these patients when they come to see you in the clinics. Sometimes when the nurses tell them, they don't believe what we tell them. But when the nephrologist echoes what we tell them, then they will understand that we are all speaking in the same language. Thank you.
Thank you so much. I request Dr. Bongomin to answer the questions that have been directed to him.
All right, thank you once again. I really appreciate these excellent questions, and I believe from Dr. Judith it's more of a comment, and I really appreciate that. I'll take that into consideration. So in order of the questions that were asked, one of the biggest concerns is that the question was, did I do a kidney biopsy? No, I did not do a kidney biopsy for these patients because it was more of a retrospective study, and it was more of a chart review, and looking at the logistics and the capabilities, we cannot yet do kidney biopsy at a large scale, so we didn't do it to identify if it was actually the secondary membranous nephropathy due to the prostate cancer causing it, but this is actually the importance of this conference and presentation of my results. These are things someone else can explore, things we can explore in future studies. And then the other question was to do with vomiting, that could it have been a predictor for development of chronic kidney disease, especially chemotherapy agent-induced MSCs. Unfortunately, one of the limitations of our study is that it's still a retrospective study, and we did not pick information on vomiting, and even in the chart reviews, there were no documentations of this in the file. So still, it's a very clean field for prospective studies, really. And then the other question was if for patients who have an eGFR that is between 60 to 90, is it chronic kidney disease? Yes, it's chronic kidney disease and the early stages, but really in this case, it's if you have a structural disorder, really. Things like, let me say you had like a polycystic kidney disease, autosomal dominant polycystic kidney disease. But for our study, really, our definition of chronic kidney disease, we used the cutoff less than 60 because we were only using, we were only estimating renal, we were only calculating renal function using the serum creatinine, really. And so it makes, and looking at the K-Doggy definition, chronic kidney disease, if you are really going to use only the serum creatinine, to calculate the estimated glomerular filtration rate, your eGFR has to be less than 60 for at least 3 consecutive months. But for anyone who has a chronic kidney disease, but which was diagnosed, and their eGFR is more than 60, and the other parameters is evidence of kidney damage, which was based on maybe structural evidence, then you have to continue your drugs. You do not stop them because those medications are going to help you slow down the progression of the condition. This might not be part of my talk, but actually one of our studies that I did as my first year project, we looked at renal dysfunction really, and here in this particular group of patients, and we defined it as anyone who had an eGFR less than 90. And so that's where, hopefully we shall be able to share with you once we publish that information. And then the final comment which came from Dr. Judith was looking at the CKD EPI 2021. There are concerns about the sensitivity and the fact that it underestimates chronic kidney disease in African population. I will look into it, but at the time when we were coming up with this definition, we looked at and we saw all these other formulas from 2009, 2012, and actually whenever we were calculating EGFR according to using RAISE, they found that with Africans using these other older formulas, it's whereby there was an underestimation of the renal of the renal function, and so the Africans ended up, fewer Africans ended up on the transplant list, and so that's why they came for a more of a, I would say, ratio-free formula, and as of the recent updates, it's still the CKD EPI 2021 that is used. Thank you, but I still have the data and use this.
Thank you so much, Dr. Bongmin. Allow me to request Dr. Junju to answer the questions. I hope you will not throw the questions to Dr. Kansime as he stated earlier on.
Thank you. I think I had the most questions. It either means people understood what I studied or they got confused. From Dr. Sekasamvu, what kidney disease type did I study? From Kedaigo definition of kidney disease, anyone with any structural or functional abnormality of the kidney is described as to have kidney disease, and it can be classified according to duration, according to the cause, and other things. But your definition is based on, your question is based on the duration. Unfortunately, we were unable to clearly classify these patients either as having acute kidney injury, acute kidney disease, or chronic kidney disease, because this was a cross-sectional study. It was a one-time measurement, so you cannot be able to classify according to the three types. That's why we used the general term kidney disease. Indications for treatment of TDF. Unfortunately, I didn't put it in the slides, but we have a complete table 1, the basic characteristics of these patients. And one of the things we looked at are the indications. Majority of these patients, they had mainly 2 major indications for being put on TDF. That was fibrosis stroke cirrhosis and a high hepatitis B viral load of more than 20,000. However, I did not include it in the table which I've shown you. Profiling of these patients of chronic hepatitis B, yes, we did. Mainly we categorized them. We used the APRI score to categorize them as having no fibrosis, and cirrhosis. We did not go. We are mainly focusing on outpatient department. We did not include patients who were admitted from complications of liver cirrhosis. Those who would have got hepatorenal syndrome, we are unable to get that information because it was an outpatient survey. And I think the last question combines the one which you asked, and Dr. Judith. Dr. Judith was TDF the one responsible for the kidney disease. Yes, you cannot tell according to the study design which we used. It is a cross-sectional study, so you cannot be able to infer causation from a cross-sectional study unless if we did a cohort study. That's when we can be able to know what has caused this kidney disease, and we are able to comfortably say, yes, it's TDF, yes, it's from the virus itself, yes, it's from the HIV, hypertension, it is, but it's a one-time measurement. You cannot be able to infer causation with this kind of study design, so we are unable to know what was causing the kidney disease in these patients, and I think that brings up to another study which can be conducted and be able to know what exactly is causing kidney disease among these patients. Yes, and yes, we included the TDF, being on TDF medication as one of the factors which we are looking out to be associated with kidney disease. Unfortunately, it was not statistically significant both in includes odds ratio and adjusted odds ratio, but those patients who were on TDF medication had higher odds of developing kidney disease. Unfortunately, they are not statistically significant. They had a p-value which was more than 0.05. I think those are the questions which I had.
Thank you so much.
I don't. So we unfortunately we were not participating in the treatment of these patients. So we just gave back the feedback to the health workers who were manning the hepatitis clinic, and we advised them to change medication. But unfortunately, the other available antiviral agents in our setting, the Entecavir, the less nephrotoxic, tenofovir-TAF, are expensive to a common person, and I'm very sure in Mbalala they are not there. However, in Kampala, they are available in private pharmacies. So we advised the health workers who are handling these patients, to everyone for whom we found had kidney disease.
Thank you so much.
I had a question to Dr. Wate. Can I ask?
Actually, we are running out of time. We are already into the time of the next session. I think you will have a one-on-one discussion with him, I would advise.
Thank you so much for your question. I think the question was about a lady who is pregnant and she's newly started on dialysis. So the first thing you need to do is refer her as soon as possible for a nephrology consult. And this consult is going to involve, first of all, extensive counseling with the patient as well as the husband to determine if they want to keep the baby or not. They may decide that they don't want to keep the baby, in which case then you think about terminating the pregnancy. But if they do want to keep the pregnancy, then you move on to the next thing, which will be to optimize the physiology as much as possible. So optimizing the physiology means that you have to do extensive dialysis to make sure that she's physiologically fit and urea is below 20. You have to make sure her blood pressures are well controlled, because high blood pressures, as we have seen, will affect the pregnancy. And then you have to make sure that you have removed all medicines which might be teratogenic to the baby. And then the final thing you have to do is refer her for obstetric consultation, so that the multidisciplinary team looking after her ensures that the baby is delivered in a healthy manner. Thank you.
Thank you so much. We have come to the end of our sessions. I would advise that if there's any question, you approach these presenters, these panelists, and have a one-on-one discussion with them. Allow me and join me to thank them and ask them to take their seats. Can we thank them? Thank you so much, our presenters. You can take your seats. Secondly, we are into the time for break. This is a World Kidney Day, and we are commemorating the Kidney Day by having this conference. The theme is derived from the general theme that are your kidney okay? And we are doing the screening and other related assessments to ensure that we go to serve the patients. It is time for our break, and this is what is going to happen. We are going to have a working break, so we are going to take about 10 to 15 minutes to take the tea and whatever will accompany it. Then you come back and you'll be having your tea from here as the presentation is going on. I would love to request and welcome each and everyone who are here. We have the president of UKF who is in the house. We have the organizing committee, we have the invited guests, we have each and every one of you in your various capacity. You're warmly welcome. I would request my co-moderator to lead us into a brief word of prayer to bless the tea so that we can have it.
Thank you. Thank you very much, Nick. It's break time, and it's well earned. So I'm going to say a short prayer to bless our tea. It's closed, hands together. If you have children, you know what I'm talking about. Lord our Father, we want to thank you for this day. Thank you for this session that we have had. We want to thank you for everyone that is here with us. We ask, oh God, that as we go for our tea, that you will bless it, bless the hands that have prepared it, and may it nourish our bodies. In your name we have prayed. Amen.
We request we move out. We can move slowly from this side, and then we take the tea, we come back inside, and then we shall continue as we are having our breakfast. Thank you so much. We request that we do it a bit faster. If not, we shall postpone the tea. Yes, we can postpone the tea to tomorrow.
statistically significant because includes observations and resting observation, but those patients who are on TDF medication had higher odds of developing kidney disease. Unfortunately, we are not statistically significant, but the p-value which was more than 0.05. I think those are the questions which I have.
Thank you so much.
So we unfortunately we were not participating in the treatment of these patients. So we just gave back the feedback to the health workers who were manning the hepatitis clinic, and we advised them to check expensive the common person, and very sure in Malala they are not there. However, in Kampala they are available on private pharmacies. So we advised the health workers. I had a question, Dr. Wati. Yes.
Actually, we are running out of time. We are already into the time of the next session. I think you would have a one-on-one discussion with him, I would advise.
Thank you so much for your question. I think the question is about you have to make sure that you have removed all medicines which might be teratogenic to the baby. And then the final thing you have to do is refer her for observation that the baby is delivered in a healthy manner. Thank you.
We are into the time for break. This is the World Kidney Day, and we are
statistically significant because includes observations and resting observation, but those patients who are on TDF medication had higher odds of developing kidney disease. Unfortunately, we are not statistically significant, but the p-value which was more than 0.05. I think those are the questions which I have.
Thank you so much.
So we unfortunately we were not participating in the treatment of these patients. So we just gave back the feedback to the health workers who were manning the hepatitis clinic, and we advised them to check expensive the common person, and very sure in Malala they are not there. However, in Kampala they are available on private pharmacies. So we advised the health workers. I had a question, Dr. Wati. Yes.
Actually, we are running out of time. We are already into the time of the next session. I think you would have a one-on-one discussion with him, I would advise.
Thank you so much for your question. I think the question is about you have to make sure that you have removed all medicines which might be teratogenic to the baby. And then the final thing you have to do is refer her for observation that the baby is delivered in a healthy manner. Thank you.
We are into the time for break. This is the World Kidney Day, and we are statistically significant because
includes observations and resting observation, but those patients who are on TDF medication had higher odds of developing kidney disease. Unfortunately, we are not statistically significant, like the p-value which was more than 0.05. I think those are the questions which I have.
Thank you so much.
So we unfortunately we were not participating in the treatment of these patients. So we just gave back the feedback to the health workers who were manning the hepatitis clinic, and we advised them to check expensive to a common person, and very sure in Malala they are not there. However, in Kampala they are available on private pharmacies. So we advised the health workers. I had a question, Dr. Wati. Yes.
So we are running out of time. We are already into the time of the next session. I think you would have a one-on-one discussion with him, I would advise.
Thank you so much for your question. I think the question is about you have to make sure that you have removed all medicines which might be teratogenic to the baby. And then the final thing you have to do is refer her for observation that the baby is delivered in a healthy manner. Thank you.
We are into the time for break. This is the World Kidney Day, and we are
statistically significant portion includes observations and resting observation, but those patients who are on TDF medication had higher odds of developing kidney disease. Unfortunately, we are not statistically significant, like the p-value which was more than 0.05. I think those are the questions which I have.
Thank you so much.
So we unfortunately we were not participating in the treatment of these patients. So we just gave back the feedback to the health workers who were manning the hepatitis clinic, and we advised them to check expensive to a common person, and very sure in Malala they are not there. However, in Kampala they are available on private pharmacies. So we advised the health workers. I had a question, Dr. Wati. Yes.
So we are running out of time. We are already into the time of the next session. I think you would have a one-on-one discussion with him, I would advise.
Thank you so much for your question. I think the question is about you have to make sure that you have removed all medicines which might be teratogenic to the baby. And then the final thing you have to do is refer her for observation that the baby is delivered in a healthy manner. Thank you.
We are into the time for break. This is the World Kidney Day, and we are
statistically significant portion includes observations and resting observation, but our those patients who are on TDF medication had higher odds of developing kidney disease. Unfortunately, we are not statistically significant, but the p-value which was more than 0.05. I think those are the questions which I have.
Thank you so much.
So we unfortunately we were not participating in the treatment of these patients. So we just gave back the feedback to the health workers who were manning the hepatitis clinic, and we advised them to check expensive to a common person, and very sure in Kerala they are not there. However, in Kampala they are available on private pharmacies. So we advised the health workers. I had a question to Dr. about it. Yes.
Actually, we are running out of time. We are already into the time of the next session. I think you would have a one-on-one discussion with him, I would advise.
Thank you so much for your question. I think the question is about you have to make sure that you have removed all medicines which might be teratogenic to the baby. And then the final thing you have to do is refer her for observation that the baby is delivered in a healthy manner. Thank you.
We are into the time for break. This is the World Kidney Day, and we are
statistically significant because includes observations and aggressive observation, but those patients who are on TDF medication had higher odds of developing kidney disease. Unfortunately, we are not statistically significant, but the p-value which was more than 0.05. I think those are the questions which I have.
Thank you so much.
So we unfortunately we were not participating in the treatment of these patients. So we just gave back the feedback to the health workers who were manning the hepatitis clinic, and we advised them to check expensive to a common person, and very sure in Kerala they are not there. However, in Kampala they are available on private pharmacies. So we advised the health workers. I had a question to Dr. about it. Yes.
Actually, we are running out of time. We are already into the time of the next session. I think you would have a one-on-one discussion with him, I would advise.
Thank you so much for your question. I think the question is about you have to make sure that you have removed all medicines which might be teratogenic to the baby. And then the final thing you have to do is refer her for observation that the baby is delivered in a healthy manner. Thank you.
We are into the time for break. This is the World Kidney Day, and we are
statistically significant because includes observations and aggressive observation, but those patients who are on TDF medication had higher odds of developing kidney disease. Unfortunately, we are not statistically significant, but the p-value ratio was more than 0.05. I think those are the questions which I have.
Thank you so much.
So we unfortunately we were not participating in the treatment of these patients. So we just gave back the feedback to the health workers who were manning the hepatitis clinic, and we advised them to take expensive to a common person, and I'm very sure in Malala they are not there. However, in Kampala they are available on private pharmacies. So we advised the health workers. I had a question to Dr. Wati. Yes.
Actually, we are running out of time. We are already into the time of the next session. I think you would have a one-on-one discussion with him, I would advise.
Thank you so much for your question. I think the question is about you have to make sure that you have removed all medicines which might be teratogenic to the baby. And then the final thing you have to do is refer her for observation that the baby is delivered in a healthy manner. Thank you.
We are into the time for break. This is the World Kidney Day, and we are
statistically significant because includes odds ratio as an adjusted odds ratio, but those patients who are on TDF medication had higher odds of developing kidney disease. Unfortunately, we are not statistically significant, but the p-value ratio was more than 0.05. I think those are the questions which I have.
Thank you so much.
Welcome back. Those still taking tea, please let's come and we.
So we unfortunately we were not participating in the treatment of these patients. So we just gave back the feedback to the health workers who were manning the hepatitis clinic, and we advised them to take expensive to a common person, and I'm very sure in Malala they are not there. However, in Kampala they are available on private pharmacies. So we advised the health workers. I had a question to Dr. Wati. Yes.
Actually, we are running out of time. We are already into the time of the next session. I think you would have a one-on-one discussion with him, I would advise.
Thank you so much for your question. I think the question is about you have to make sure that you have removed all medicines which might be teratogenic to the baby. And then the final thing you have to do is refer her for observation that the baby is delivered in a healthy manner. Thank you.
We are into the time for break. This is the World Kidney Day, and we are
for advocacy. We want to advocate for more kidney care screening. We want to advocate for more kidney care physicians, more kidney care surgeons, more people involved in kidney care. And the very first speaker is Dr. Emmanuel Sekasamvu. For those of you who don't know Sekasamvu, he's number 2 in the line of nephrologists in Uganda. Therefore, he's highly, highly esteemed. He has mentored everyone who is a nephrologist in this room. He has mentored everyone who is a nephrology nurse in this room. He has mentored all the allied nephrology people as well. So we are really, really privileged to have Dr. Sekasamvu here, and we look forward to listening to you.
Thank you very much, Dr. Peace, for that kind introduction. I looked at the topic which I was to present, and it was such a huge topic, and I was at a loss, but let me try to, within a few slides, see whether we can do this. The theme for this World Kidney Day this year is, are your kidneys okay? So I want to begin in this room by asking all of you, is that, are your kidneys okay? And by that I mean, do you have 2 kidneys? Are they anatomically located properly? Are they draining properly? Is your renal function okay? Who has done an ultrasound? By show of hands, let me see. Who has done an ultrasound on yourselves? I think this doesn't even make 30%. Who has done renal function tests? Who has done a urinalysis? You see? So, after asking you, I was now tasked with asking Uganda whether Uganda's kidneys are okay. And according to my small survey I have done in this room, I think Uganda's kidneys are not okay. Because you are already aware of kidney disease and what to do about it, and you haven't done it. So it looks like we might be in trouble. In Uganda here, we are about 46 million people. And we are quite a young population. About 78% is 35 years and below. And about a range of about 5 to 7% is above 50 years. And definitely above 65 years, we are 2%. The prevalence of kidney disease has been estimated to be about 2 to 7%. This is not any different from our neighbors in East Africa. However, the incidence goes higher if you have comorbidities with the infections like HIV, if you have hypertension, diabetes, or other diseases. Now, this is a food for thought that we don't know the exact cause of CKD in Uganda. We don't have a systematic study that is telling us exactly how much glomerulonephritis we have, how much congenital kidney disease we have, how much nephrotoxins are causing disease. However, we know that the traditional risk factors to kidney disease are contributory. Your diabetes, your hypertension, your vascular disease, and others. And when we look at hypertension and kidney disease, it looks like hypertension is part of the symptom rather than a cause of this hypertension. So a lot of times we confuse between the chicken and the egg. And when you look at Uganda, the basic preventive measures for development of CKD and care are not widely practiced. How many of you do kidney biopsies in your centers? How many have you done this year? How many times do you properly do volume assessments on patients who present in the emergency room and be sure they are well hydrated? How many times do people take care while administering drugs like diclofenac and other nephrotoxins to prevent them from getting renal failure? Okay, let me ask like this. How many times have you seen patients come in with nephrotoxicity from gentamicin or other aminoglycoside antibiotics or diclofenac? Have you seen any this year? So that means that our sensitization program is not as good as we want it to be. And the fact that we don't have those basic preventive measures, that's why we have more than 50% of our initial renal visits of patients come in with uremic syndrome or uremic symptoms, and they require renal replacement therapy. We have very few nephrologists. I can say we have 15. Most of them, they are urban, and the reason is because the teaching centers are in the urban setting, and that's where they are. Dr. Simo, I don't know about the urologist. You will tell us. And that translates to 0.3 nephrologists per million population. But when you look at the global average median of nephrologists is about 9 nephrologists per million population. So in that aspect, Uganda's kidneys are not okay. We don't have a renal histopathologist dedicated, and I don't know whether there is good collaboration between histopathology department and our renal services and renal units. Do you have a specific histopathologist who does your histopathologies? Do you sit in a histopathology conference with them and discuss cases you have biopsied? So these are missing links. Dialysis, actually we had 2 trained renal histopathologists. One of them died at the beginning of last year. So we have one, and he's basically retired. I don't know whether there's anybody who has been stimulated to go into this area. And actually, if I ask, do we have any histopathologist in this room? We should invite them. Dialysis, you know what we have. I think with 3 districts, you can say Mbarara, Gulu, Kampala. Gulu does PD, Kampala does PD, but the PD we do is very scanty. And the reason why we do little PD is because it poses a lot of challenges. The knowledge, attitude, and practices of the community, the supplies, the inconvenience, the way our wards are set up, all pose a challenge. But I think we are the ones to correct this. If you look at those 46 million people whom I have talked about, I think we have less than 100 hemodialysis machines for these people. We have about 60 dialysis nurses in Uganda. When you go to our dialysis unit, the patient, the nurse-patient ratio is about 1 to 15 to 20. And the recommendation is that we should have no more than 1 to 4 ratio of a dialysis nurse to patient in the dialysis unit, because of what we all very well know. Acute coronary events, cardiac arrest, and all these other complications associated with treatment. We have about 10 dialysis technicians, and these are shared between units. And also our nurses are shared between units. We have poor patient selection for renal replacement. And this is because people who can pay are the ones that we put on dialysis. We have done 2 sets of transplant. The first one we did it in 2023, second one 2024. And here I'm presenting this pyramid, which represents the renal population and the care provision that is available for it. When you look here, the lower level of the pyramid, those are the patients that are taken care of by lower level healthcare workers, and these are the ones who mainly need acute preventive care. And we need to sensitize these people. The general doctors will see the middle tier, and these are very many patients. And the patients whom you people who are seated in this room see are actually in the upper tier of this pyramid, and those are very few. But even those people who are in the upper tier, a very small percentage of them come to you. And that's a missing link in how we take care of kidney patients in this country. We have struggled with the renal care for many years. Like I said, there's a lot to say. But we have achieved a few things. One, we now regularly do advocacy forums like this one, the World Kidney Day. Before, if you had one nephrologist, probably you couldn't do it. Now we have Ukipso. I haven't seen somebody from, is somebody from Ukipso here today? I haven't seen. We have patient advocacy groups. We need to advocate. We have done advocacy in the three arms of government. We went to Parliament, presented our case. We now have a Organ Transplant Act, which is in the legal part. And then we have NGOs that are working together with us. Unfortunately or unfortunately, we also have media which is working in our favor or against us, but in most cases are in our favor. You know, we have had negative publicity where people have talked of doctors stealing kidneys, and this has made big news. And sometimes we think it is bad, but it is good for us. Now people understand that kidneys are transplanted. They understand that there is specific kidney care. And I think that's good. We have some opportunities. We have some senior doctors now and nurses who can mentor others. I was asking my brother here, Professor Simwe, how many urology students he has brought into this conference. And apparently he hasn't succeeded in bringing one. Who are the postgraduate students here? Put your arms up. I hope you are interested in nephrology. So each of us should interest some people into nephrology. We now have International Society of Nephrology as a partner, and I think all of us somehow trained under International Society of Nephrology. They have a sister center program, which I think we haven't cultivated very well, but we also need to bring this on board. We have our farmer colleagues, and if they were there, definitely we wouldn't be seated here. They have done quite a lot. Then we have private investors in renal care, our renal histopathology, our immunotests. They are done in private labs. And we have had in-country training with workshops and so on. And then we have collaborators, academic institutions like Yale University, who collaborate with Makerere University, and they are very good in helping us. And then we have the East African community. We have the IAKI, East African Kidney Institute. And some of our nephrologists have trained there. There's a program at Muhimbili and another one in Nairobi. Missing links definitely are there. How many of you here have been funded directly by government to train as either renal nurses or as nephrologists? By show of hands. You. So whoever is representing government, that shows you that government is doing very badly in trying to promote renal care in this country. The government is interested in hiring these people, but I also understand that you don't have a specific position for nephrologists. You want to hire these doctors as, what do you call them, MOSG? Huh? Something like that. And that is not fair. So we need more funding in associated chronic disease that I have talked about, alluded to, that brings CKD, diabetes, hypertension. And I talked about primary renal care management. Of course, with the funding, we are still lobbying with the National Health Insurance Fund. We have private insurance, but they are not exactly interested in renal care because they consider it very expensive. And then we need to expand our renal care beyond urban centers and to streamline referral protocols so that the nephrologists are not overloaded with patients they shouldn't see. We need to up our diagnostics, have a specific immunology lab at our national referral hospital, and our nuclear medicine, you know, we do a lot of nuclear studies. Our unit is always down and we get issues. Our patients have to go to Nairobi and other places. And then we have to have an electron microscope. We had this sometime, maybe 50 years or more. And finally, I see us having a Uganda Kidney Institute. And Professor Simwe, you shouldn't fail this project. That's why I need to see you bring in those young Turks and proteges of yours. And with the Uganda Kidney Institute, we shall definitely lobby better, get funding, and probably we shall be more understood. I have run out of time. Thank you very much.
Thank you very much. Our most senior, Dr. Emmanuel Sekasamvu. We call him Jaja. We even don't fear to call him Bosco. Because he really is. So thank you very much, and we shall be glad to interact with you during the Q&A. I take this honor to welcome amidst us Dr. I take this opportunity to welcome amidst us Dr. Nathan Onyachi, and he has a very swaggerific name, Warid. I'm sure he got that name before we even knew that Warid existed. Dr. Onyachi has a lot of experience in managing public facilities. He's been executive director, most recently, of Masaka Regional Referral Hospital, and most recently, Lira. He was our host. He helped to establish dialysis at Lira Regional Referral Hospitals, and guess what? He was elevated to a member of the Health Service Committee, the people that talk to the big man direct. So I'm so comfortable that the things we are talking here are going direct into His Excellency's ear. Dr. Onyachi, we are glad to have you. Welcome. For long, we shamefully stood on podiums like this, promising Ugandans that one day we shall be able to do it. Yes? And lo and behold, sometime in December 2023, we eventually did it. And one of the pillars of this is a man who would talk to you about nothing but the transplant. I have the honor to introduce Professor, Surgeon, Mr. Dr. Frank Asimwe Rwabinda, Senior Lecturer, Professor, and Senior Urologist and Surgeon, to come and talk to us about a topic that is deep in his heart. Prof. Asimwe, I'm glad to have you here.
Thank you, Dr. Gavu. That introduction can make you want to run away instead. Dr. Gavu, the president of Uganda Kidney Foundation, organizers of this conference, colleagues, ladies and gentlemen. Disclaimer, I have no slides. will be the slide that will be showing throughout my presentation. So you have to listen to me very closely. Kidney transplant in Uganda, from paper to action. Like Dr. Ogavu has alluded, and like we live in the AD, after Christ, or after COVID, whichever you prefer to choose to say, we're at least living in the days after transplant has become a reality in Uganda. And for that, I want to thank everyone who has been involved. And as I will be making it clearer, it has been a huge concerted effort and will continue to be a concerted effort. Our mantra in the transplant program is kidney transplant for Ugandans, in Uganda, and by Ugandans. For sure, we've already achieved the first one. Kidney transplant has been taking place for Ugandans for quite a number of years. Now, kidney transplant is happening in Uganda. And the final stage is kidney transplant to be done purely by Ugandan teams. And I'm sure we'll get there. A round of applause would not be a big problem there. I'll talk about 3 or 4 subtopics on this subject. One, I want to talk about building on previous successes. 2, I want to talk about the collaborations which are required to get this off the ground and keep it going. And I will talk about the current challenges and how we move forward. We would not be able to do any transplant in Uganda if kidney care had not become a priority. And I want to applaud our judges and those who came before them. My mother was hypertensive very early in the 80s, and I remember she used to come from our village and look for a Dr. Chigonya. And those were the beginnings of isolated kidney care, focused kidney care by the physicians. And that set the ground. And of course, we moved from there to having renal replacement dialysis. Once we were able to do dialysis, which has now become routine, we want to expand it, then the ground was even firmer. But going forward, when the conversation for doing transplant became more serious and institutions began preparing infrastructures, like Mlago built a kidney transplant unit, I know Rubaga has put up one, and other hospitals, Nakasero is saying something, I think, and a few others, now moved to the infrastructure. The next step was to train transplant teams. And indeed, these are teams from the nephrologists to the surgeons, to the transplant nurses, the intensive care nurses, the laboratory persons. All this has happened. And as has also been alluded to, the setting in place the legislative framework in which this can happen. Transplant can be very lucrative, can be very slippery. First of all, it makes for very exciting news. Bamukonye, Bamuinsigo, you know, those stories, they sell in the papers. They are very exciting. And unless you've got a very strict framework, legal framework, transplant can be abused. There is a hospital, whose name I will not mention, but one time they were offered to come and do Maiden transplants, and they were asked to look for donors. And while they were planning to get, I think they were asked to get 4 patients who were supposed to be transplanted. But then they were asked to look for 5 donors. You get 5 donors, but you're going to do 4. When they dissected through this, it looked like someone else was going to come and benefit from this kidney. So it can be very lucrative. And so one of the milestones, one of the things that have been done is the legal framework, which I must confess is fairly strict. Maybe we'll answer a few more questions regarding to that. A milestone that has been achieved. And as has been mentioned, 2023 we did our maiden transplant. in December, and now last year, November, we have done 4 more. Now Uganda can boast of having done 5 transplants. And maybe Dr. Peace will be telling you all our recipients and our donors are alive and well. Participating in the daily hassles of looking for jobs. There's one whose girlfriend chucked him because now he had 1 kidney, the donor. The routine hassles that we all go through. But transplant has happened, and our recipients and donors are doing well and integrated in life. Now, let me talk about collaborations. This could not have happened if we did not collaborate. And going forward, we must collaborate. On the international stage, interinstitutional level, and on individual clinician level. Very, very important. As Mulago, of course, which has done the Maiden and the few transplants has been done, we had a collaboration with Yashoda Hospital from India. They participated in training us. They participated in guiding us on the legal framework. They participated in putting together our infrastructure. We have collaborations with the UK team. We have had some input from Turkey, and so on and so forth. So, emphasis that I'm making is that there must be collaborations. There is no way this can be pulled off alone. The interinstitutional collaboration that I'm also emphasizing is even when we did our first transplant, right from the planning stage, we had the involvement of nephrologists from beyond Mulago. Dr. Sekasamp has been involved. Today you're going to hear from Dr. Atuheire, very much involved, not employed in Mulago, Dr. Javira, everyone, other nephrologists beyond Mulago have been involved in this effort. And that is the only way we can move forward. Of course, we must not forget to mention the role of government, which has pulled all the funds to do all these collaborations, has done the legislative work, and has paid for the first transplants we've done, and has committed to pay for these transplants going forward until we establish how much it requires, and then we can pass on the cost. So government must also be applauded for the effort they've done in this collaboration. What are our current challenges? The challenge is, 1, we need the organ plant council set in place. And Dr. Nyachi, I think you present government, we need a council to be put in place to accredit other centers that are ready to roll. Without mentioning name, people are ready. And also to guide this process. Right now, we're running between the committees in the hospital and the medical council, but there's a gap. So we need that in place. We must continue doing skills acquisition. The transplant surgeons. On my team, we have been 5 surgeons. Myself, Dr. Simwe, Dr. Masava, Dr. Sechitoleko, who will be presenting something here in the later session, Dr. Kutesa, Dr. Martha Namuga. All these urologists have been involved from the first case up to the current case, and we process of acquiring skills so that eventually we take over. And we must make that intention very clear, that eventually we must do this independently. The other challenge we've had, in order to maximize our success, we have been restricting our criteria. And maybe that will be talked about a little bit later. We don't let anyone in. In the other places where they're up and running, they can take on quite a number of cases. We have been a little restricted. On the first case, we're only doing males. The subsequent cases, we've at least done 2 ladies and 2 males. We are still cutting the age limit. We are confining to very minimal comorbidities. But of course, this must be understood and must be explained to the patients that in order for us to succeed going forward, we must have good outcome initially. So we must be very selective. But so one of the challenges we have is the overwhelming demand, the questions, Why? Why not me? Why the other one? And some people have been insinuating, looks like there's something that must be paid. No. We are trying to be strict with our criteria so that we maximize our success. Because mortality in the early part of the program can kill our program. And I want to thank the nephrology team because they've done a very good part. So going forward, a few things that we need to do. One, we appeal to government to set up the council to regulate, accredit new centers and regulate this activity. And we are leaving them. First of all, these people have not been involved in this care. For us, we have been. The people who want to do lucrative things have probably been doing these things. The council must be in place so that it has time to learn and catch up. Of course, new sites must be set up. The different teams must plan to have local skills set up. We cannot rely on our collaborators all the time. I want to say this again. If other hospitals are going to come on board, the plan must be local teams must be trained to be proficient to do this independently, so that we don't become a camping ground that we can only do this surgery if our team from abroad has come out. We need to widen our selection criteria so that all those who deserve transplant can have it. And finally, and I added this after Dr. Sekasamvu nudged me, we must increase the nephrology, urology collaboration. And I want to thank nephrology because you have led this drive extremely well. Kidney care is being talked about, at least remembered on a yearly basis. We must increase our collaboration between nephrology and urology. With those few words, that is how we have moved from paper to action, and that's how we want to move it forward. I thank you.
Thank you very much, Prof. He's a man that has no need for slides when it comes to this. He's speaking from the heart, like I mentioned. And we people of swag, I think I've picked something. You said kidney transplant in Uganda, for Uganda, by Ugandans. In Uganda. I got the other one and I called it Chitufubu. We shall talk about it. Yeah. Yes, we shall talk about that one. Thank you very much, Prof. Frank, for speaking to us about that and for delivering us to the promised land. We really appreciate. The next speaker is Dr. Grace Kansime. Dr. Grace Kansime is both a surgeon and general doctor, thanks to her MBCHB and the M.Med in internal medicine that she got from Makerere College of Health Sciences. She underwent training at McMaster, from where she obtained her fellowship of International Society of Nephrology. She's currently a Fogarty Global Health Fellow, and she's the head of the projects at Uganda Kidney Foundation. She also chairs the Uganda Kidneys Diseases Registry, which is work that she also speaks on from the heart, and I'm sure part of it is going to feature in her keynote address here. She's a lecturer and nephrologist at Mbara Regional Referral Hospital and Makerere University of Science and Technology. Yes, my apologies. I really can't misname my own alma mater. Yes, she chairs the internal medicine department. She's also a researcher with particular interest in non-communicable diseases, epidemiology, and implementation science, where she focuses on kidney health and kidney disease and its risk factors. As a Fogarty Global Health Fellow, she's currently studying kidney disease among people with HIV in Uganda, and she's engaged in mentoring graduate and undergraduate students, some of which work you have actually witnessed here. She has a vision, and that vision is to see Africans getting local solutions to African health problems. Join me in welcoming Dr. Grace Kansime.
Thank you very much, Mr. President. Our guests this morning, I welcome you, and as they put the slides up, I welcome you to World Kidney Day this morning, and it is my pleasure to talk to us about chronic kidney diseases in Uganda, in particular, the role of early detection. Looking at our theme for World Kidney Day today, which is, are your kidneys okay? Detect early and improve kidney health. Okay, as the slides come, so this presentation has been supported by AstraZeneca. However, there is a disclaimer that while they have supported this presentation, they do not advocate in any way for use of their products. And this presentation does not replace professional medical advice. And the information that I'm going to share with you is solely what I have prepared. It is not their responsibility, and they are not liable. This is a short outline, and we shall focus on screening for kidney disease. So what is the spectrum of kidney disease? Someone already asked a question about a GFR of 90 and 60. So we have acute kidney injury, we have acute kidney disease, and then chronic kidney disease, which we shall be focusing on in the next 30 minutes. So acute kidney injury is a sudden thing that happens. Your kidneys are injured for some reason, and it resolves within 7 days. If it does not resolve, and it goes on for up to 90 days, we call that acute kidney disease. That too can resolve. If it does not, if a maladaptive process happens, and usually it involves the structure of the kidney, it heals with scar formation, which we call fibrosis, then you get chronic kidney disease. So that is 90 days and above. So, what is chronic kidney disease? I'll mention the definition because someone had asked. So we have two ways to define chronic kidney disease. One, we look at how the kidney is functioning and how it looks like, what we call the structure. So, Dr. Sekasam just asked, are you sure you have two kidneys? If you have one, we classify you as chronic kidney disease because you're at risk of getting kidney disease. If the structure is not as it should be, you have cysts in there, you have chronic kidney disease. That is structure. Then we look at its functioning. Is it sieving the blood as it should? Is it removing the toxins and the wastes? If it is not, that is creatinine, which we look at, which we measure in blood. And we use that to calculate the GFR. We call it chronic kidney disease. If you are spilling protein or blood in urine, which you shouldn't, then we call that chronic kidney disease. So, is it a problem anyways? So worldwide, about 10% of the world's population has some form of kidney disease, and that is about 850 million people. Unfortunately, when we come to Africa, that prevalence is higher than the global average, almost 16%. Why? It's because of genetics, it's because of the environment. And 10 years ago, kidney disease was the 19th leading cause of death. As we stand today, it is about 12th or 10th, and it is projected that in the next 5 to 10 years, it will be the 5th. It is increasing at a rate as a cause of death that is powering HIV. So you can see where we are heading to. In terms of the economy, when we look at the states, the United States of America, they spent a lot of money as of 2018 when we look at their Medicare spending, which is insurance for older people that have retired. 22% of their budget went to CKD care. And if someone had diabetes and heart failure, which are usually comorbidities in patients with kidney disease, that percentage spending went to 70%. And when it came to end-stage kidney disease, which involves treatment with dialysis and transplant, that money rose. So when you look at these billions, when I tried to change them to Uganda shillings, these are in dollars, my calculator said error. So I do not know, you can try and then ask yourself, do we have that money? How about in Africa? So the prevalence varies. It is less in Northern Africa. The South is at the global prevalence. Eastern, where we belong, we are about at 16%, and the West is about almost 20%, and that's because of genetics. How about Uganda? So the prevalence still varies according to regions, but also according to the population standard, because we have not had a nationwide screening to say that in the whole of Uganda, this is the prevalence. But studies that have been done in the communities and the general population, it ranges between 2 to 7%. When we look at high-risk groups, hypertensives, diabetes, HIV, the prevalence goes higher, up to 15%. And also, some studies that have been done among patients that already have chronic kidney disease, it's been shown that we actually do not have a lot of risk, or the traditional risk factors as we call them, diabetes and hypertension. And we shall see what are those unique factors, risk factors in our setting. So this is the prevalence wherever it's been studied. In the West, in the general population, it is 3.9. In Central here where we are, it is almost 7. It goes to 12.5 in the East. People from Gulu or Riba, are you around? We are waiting for the prevalence in Gulu. We do not know. In northern Uganda, we don't know. Why do we have these different prevalences? It's, again, we think it's because maybe of genetics or environment. We shall find out. We are calling upon you to do research so that we get to know why. And when we look at costs, we do not have a study that has been done in Uganda to look at the costs. But when I asked my colleagues, this is what we think. When someone comes in for an OPD visit, even if it is at Mbarara Regional Referral Hospital, someone pays when a patient sees me. So this is the consultation. And we are comparing it between public and private. When we look at a urine dipstick, a serum creatinine test, these are the tests that we use for screening, which we are really going to talk about. You can look at the cost. But I want to draw your attention to when we get end-stage kidney disease, where we need renal replacement therapy. Dialysis is that expensive. Transplant, we shall ask Professor how much it costs. Even when they say it is free, someone pays for it to be done. So you can look at the cost, and you and I can answer deep down in our hearts if we could afford this. So there are also global disparities other than the prevalence. When we look at, allow me to call them poor and rich countries. When we look at the poor countries where we belong as Uganda, there are very many issues. Is kidney disease prioritized? The answer is no. And because it is not prioritized, it is not allocated funding. And because it has no funding and is not prioritized, we do not have guidelines to treat the disease. And also, because of that, we do not have programs that are specific for its detection. And we do not have dialysis registries, we do not have disease registries, and we do not have centers for research that are dedicated to kidney disease, all because it is not a priority. So my job in the next 20 minutes is to convince you that kidney health, not kidney disease, kidney health should be a priority. So this is how we stage kidney disease and how we stratify the risks. I've talked about calculating the glomerular filtration rate using creatinine, and that gives us 5 stages. But also, when we measure the protein in urine, then we can say if you have a lot of protein, and that helps us to know that you're at risk of progressing and getting worse and getting complications. And we encourage you who see patients to actually use both. And you who make policies to actually put both in the policies and fund both. So what are the risk factors? We have the traditional ones that we know: diabetes, hypertension, heart failure, but there are unique risk factors in women, pregnancy, and eclampsia, we've talked about that, puerperal sepsis, all those things, autoimmune diseases, which are also, unfortunately, more common in women. In children, hereditary issues, developmental issues. Then we have acute kidney injury. Every time one gets an episode of acute kidney injury, it puts them at risk of getting chronic kidney disease when it does not heal. We have infections, a multitude of them, tuberculosis, HIV, malaria. We have genetics, sickle cell, APOL1. And then we have the environment with lots of things that we do not understand. When we talk about pollution, is it affecting our kidneys? We have herbal medications, we have herbicides, we have pesticides. All these things affect kidneys, and these have been studied in Africa and in Uganda, and they increase the risk of kidney disease. Now to screening. The World Health Organization sets principles for diseases that should be screened for. Is it a public health problem? Does it have an early asymptomatic stage? Can it be detected by affordable means? Are treatments available and effective to slow the progression? Is disease progression understood? And the answer for kidney disease for all this is yes, yes, yes. So then if the answer is yes, it says we should screen, and screening should be ongoing, not a one-time thing. And then when we look at the budget for screening, it should really be affordable compared to the overall healthcare budget. So who should we screen? Everyone with a risk factor, diabetes, hypertension, kidney disease, but everything that I have mentioned. So if someone is pregnant and they've had eclampsia, if someone has SLE, rheumatoid arthritis, if someone has APOL1, sickle cell, all these people should be screened for kidney disease. When we screen them, do you have kidney disease? Yes. We risk stratify. We stage you and we intervene. No. We stratify when we shall screen you again, depending on your risk factors. So we cannot screen the whole population because, remember, it has to be cost effective. We got people who are at high risk. That helps us to maximize the yield. And once we have those that are positive for kidney disease, then we look at those who are likely to progress and we intervene. So how do we screen? I've already alluded to this. A urine dipstick, a blood test, and an ultrasound scan. We are looking at protein in urine or blood. We are measuring creatinine or cystatin if we are able to, and calculating the estimated glomerular filtration rate, or we are using a scan to look at the structure. So as you can see, you can never look at someone and suspect that they have kidney disease. We have to do a test, and this is where we need government, and this is where we need each of you. How should we screen? When we look at Uganda, putting it in our context, this slide from the Uganda Kidney Guidelines shows us if we did a dipstick and it is showing us +1, +2, +3, what does it mean in terms of quantities of protein in urine? And what are those things that we are able to do at a health center 1, 2, 3, up to Mulago National Referral Hospital? And when we do them, what should we do for the patient? A VHT, a community health worker, should be able to identify someone with hypertension and send them to a health center 2 for a urine dipstick. At a health center 3, once they find that you have protein in urine, they should be able to send you to a district hospital for more diagnostic tests. When should we screen? At diagnosis of the risk factor. The day you tell someone that you have hypertension, you should screen them for kidney disease and all those other risk factors that we have mentioned. At the first doctor-patient encounter, when a patient comes to you and says, I have been with hypertension for 10 years, but they are seeing you for the first time, check their kidneys if the previous person has not checked. And then as needed, depending on the risk factors, monthly, quarterly, yearly, wherever. But also when they get additional risk factors and exposures. If I have had diabetes and today I come in and I have HIV, screen me because that's an additional risk factor. And once we have screened, then we do further tests to look for complications and intervene. We know who to screen, when to screen, and how. Why should we screen? Let's look at the government. We are striving to achieve the sustainable development goals. And Kidney disease is one single disease that threatens achieving very many SDGs. And I have examples here. Let's start with one. We all don't want to be poor. But kidney disease, while it is a consequence of poverty, it is also a significant driver of poverty and economic hardship. Why? We have looked at the prices of the tests, of the consultations, of the treatments. You have to pay, you have to buy the drugs, you have to put in transport, you have to do all these things. 3, SDG 3, we all want to be healthy and well. Kidney disease contributes significantly to morbidity, mortality, years of life lost, disability adjusted years. When you have CKD and you're confined to a machine in hospital 3 days a week, you cannot get out and say, I am well, I am fine, I am okay. 5, gender equity. I am glad Professor has just said that the very, very first patients, they chose males. I will not ask about gender equity to him. I will ask him one-on-one. But females, as I have showed you, have unique risk factors, pregnancy-related, but also the autoimmune diseases. If you ask any nephrologist seated here who has been in a dialysis unit, when you go in a dialysis unit and you count the patients on dialysis, men and women, men are always the biggest number. Why? Because they have the money. So, gender equity. Even their problems maybe are coming because they were not educated, so they didn't take care of their pregnancies, they didn't attend antenatal, so they are ending here. Let's look at SDG 4, quality education, as well as 8, decent work and economic growth, both at an individual level but also at a country level. How will I be educated when instead of being in class with my colleagues, I am in a dialysis unit 3 days a week? How will I get quality education when my father and my mother, who are young, have CKD, and they are in a dialysis unit in Mlago instead of being with me in Kabong paying my school fees? Nephrologists seated here, and everyone that works in a dialysis unit, we know that most times patients have come, and when you ask, how come you missed your last 2 sessions? They look at you, they don't understand you, and then they tell you, doctor, children were going back to school. So they had to choose between taking the child to school and coming for a dialysis session. And then tell that person about decent work, economic growth, and quality education. Which employer is going to employ someone who is away from work 3 days a week? And that is at minimum. Also, when they come off the session, tomorrow they feel beat, they won't go. Then before they come for a session, they are vomiting and nauseated, they won't go. And when customers come in, instead of putting a smile, they are looking at them with a bad face because they are nauseated because of kidney disease. Which employer? Then we talk about economic growth. Lastly, climate action. We all want a green Uganda. A normal dialysis session, 4 hours, consumes 400, 500 liters of water. And we are not talking about the other wastes that are generated, including heat. And we are talking about, where I come from in Imbarara, it's River Rizi. We have had runs for it. It's drying. But we are consuming the water. So if we wait to reach the end stage kidney disease, we know what we are heading to. Why else, other than the SDGs, in case the SDGs have not touched you? When you have chronic kidney disease, it comes with complications. And the one single most feared one is cardiovascular disease. Actually, most patients with kidney disease die before they even reach stage 5 because of heart disease, hypertension, atherosclerosis, MIs, heart attacks, heart failure, because this accelerates the kidney failure. And we know, we have all seen that actually cardiovascular disease is the #1 cause of death globally, and so it is even among patients with CKD. And you may sit there and say, this is New England Journal of Medicine. These people were either from China, from the United States, or wherever. But studies have been done, even here in Uganda. This was among patients on dialysis. And as you can see, even patients who are 18 years old, 20 years old, they already have left ventricular hypertrophy as a complication of kidney disease. You can say these were on dialysis, and so they had been with kidney disease for long. But this here, which was also done at Mulago, was among patients who had not yet initiated on dialysis. Actually, these patients were just presenting for the first time in the renal clinic at Mulago. And as you can see, more than 50% of our patients present when they are already in end-stage kidney disease. And these are young people. 47 is the average year. And by the time they present, again, up to 60% already have complications, which are going to kill them, as we have seen. And this study was done in a general population. Between 2011 and 2015, about 5,000 people were screened in Chamulibwa. And among the tests that were done was a creatinine. Every year, they went back and collected a vital status, alive, dead. 6 years later, they analyzed the data. And the single most important factor, risk for mortality, was kidney disease. Having an estimated glomerular filtration rate less than 45 increased your chances of dying by 6 times. So, if that has not yet convinced you, why again should we screen? Because we have interventions that we can prevent the complications if we get you early. They are available, they are effective, but we must make a diagnosis. Dr. Bagasha here will not just look at a patient and start SGL2 inhibitors. No, we must make a diagnosis and then stage and intervene. So we get you out of the population, we look at your risk factors, we individualize the intervention, your preferences, the life expectancy, then we give you an intervention. So this is what interventions do. You're moving at a very fast rate, progressing, we give you an intervention, we slow the progression. And this is a reminder about the stages. But 2 weeks ago, I was talking to Dr. Rose, and this is what she said, that people think I am a dialysis doctor. So people, nephrologists are complaining. They are not dialysis doctors. They are not end-stage kidney disease doctors. When we get patients at that stage, they have nothing to do. Only start dialysis and pray that Dr. Frank will have someone who will come in to do a transplant. But when they get the patients early, they can intervene. So, I was reminding you of the stages because there are interventions for every stage. This is very important because sometimes patients are screened and they are told, your creatinine is slightly raised. That has never happened in any textbook. There is nothing like creatinine is slightly raised. You get a creatinine, you calculate the eGFR, and then you stage me. And then you intervene. And what are the interventions? Lifestyle modification. Can I do exercise, reduce the size, and maybe I will no longer be obese? Can I stop smoking and alcohol? Can I optimize my blood pressure medications and my anti-diabetics and control my sugars better? Which drugs can we give? Can we give some RAS blockade? We know that even among patients that are diabetic, if they are spilling protein, even if they don't have hypertension, we actually give them an SE inhibitor or an ARB, or now we have SGL2 inhibitors. We have the GLP-1 agonists, we have the MRAs, and then even at a later stage, we still need to test so that we treat the complications, but also prepare the patients early for replacement therapy if they are going to get it. So at every stage, we have an intervention. And this is proof, studies, evidence that these things work. And whether you're at stage 1, whether your eGFR is 90 and above, but you're just spilling protein, there is something that can help to reduce and improve the prognosis. Lastly, we screen for prevention. When I have diabetes or hypertension, and when you screen, you tell me your kidneys are still okay. I have been diabetic or hypertensive for 30 years. And you encourage me that I am doing well. I keep doing that so that my kidneys stay well. When you screen and you tell me, now you have started spilling protein in urine, I go and do better, take my insulin shots so that I do not get worse. So we screen for prevention, both primarily but also secondary. Okay. We know that we should screen. You may be seated there saying, but we know that we should screen. So why don't we? What are the challenges? One, sometimes we lack validated tools for our setting. The tools, we have unique risk factors, the environmental risk factors that we are talking about, the heat, the pesticides, the herbicides, they affect the tubules and not the glomerulus. And because of that, we don't spill protein. So when you do a urine dipstick, it's normal, but the eGFR is declining and you do not know. So we lack validated tools for screening for our setting because of the unique risk factors. We also lack point of care diagnostics. We know where majority of our population gets care from. And we know the infrastructure that is there. So we do not have point of care creatinine tests, for example. Lack of data on cost effectiveness. When we talk about money and policy and allocating funds for screening, we are talking about all these things with all the passion that I have. But when they ask me, what do we save? We want to listen to the dollars. I do not know. So the scientists seated in this room, as you advocate, as we look for the data, can we invite the economic people to do the cost-benefit analysis so that when we go to talk to the policymakers, we do have a full package? Lack of applicability for some of the existing risk prediction models. Most of the risk prediction models have in labs. You need a creatinine, but you do not have a creatinine. So in some middle-income countries, in India, in Asia, there are some risk prediction models that have been developed that do not include labs. So can we develop some for our own setting? Low literacy and awareness among the population. I have diabetes for 30 years, but I have never known that I should check my kidneys. Limited healthcare system capacity, both in terms of human resource, but also all the other infrastructure, political and financial challenges. Dependency on donor-driven programs. I think I don't have to mention that. We know what we are suffering right now because of the Trump card, as they are calling it. The donor-driven programs are very good, they help, but they come with their targets and everything. And they will not squeeze in kidney disease because it is not their priority. Dr. Bate was here telling us about the equations and how to diagnose and how to measure BIP, how difficult it is to measure just blood pressure in children. Then talk about how to test and calculate their eGFR. So sometimes there is diagnostic complexity. But as we are seated here now to the scientists, suboptimal communication between specialties. The nurse mentioned it. The patient has medications from here. Sometimes they go to Dr. Sekasam, they come to Dr. Kalyesubla, then they go to Dr. Bagasha, and they have the medications. Are people communicating as specialties? Are we telling the patient the same information? Is someone saying your creatinine is somehow, and someone is saying your creatinine is going to kill you? What are we telling the patient? What are they getting out of what we are telling them? So what are the solutions? We need to customize screening tools. We need to leverage existing programs. We've had the HIV program for years. We are currently doing a study where we are seeing that more than 60% of people living with HIV over a 10-year period have never been screened for kidney disease, yet we know they are getting older, they are on TDF, but we have never screened. These programs have run, but we have not leveraged, we have not ridden on them. Patients have come to us day after day, but we have not screened them for kidney disease. Incorporating new technology, point of care tests. Hubs have worked for TB, taking samples for Gene Expert. They have worked for HIV, taking samples for CD4 and viral load. They can work for NCD screening. You can take samples from a lower health facility to a regional facility for testing, but then you also need to incorporate digital health so that when you get results, you put them into a computer and someone accesses them without having to come back for paper-based results. Opportunistic screening, we are all here. Dr. Sekasam has asked her, your kidney is okay, I ask as well. If we used this chance and we are here, we have brought ourselves, we could only say no to a prick, but we have not used this opportunity. So for those that have not screened, it is yet another missed opportunity for screening. Then we need to strengthen the existing programs, private, public partnerships, education and awareness, advocacy like we are here doing. We need to strengthen these. And we need to remember the special categories, the children and the pregnant women. So while we know what to do, how do we do it? Screening is not for you alone as a nurse, as a doctor, as a healthcare worker, as a policymaker, as a nephrologist. It needs lots of stakeholders, and who are these? The first stakeholder is the patient, with their caregivers and the whole community. If we do not make them aware, we do not tell them why we are screening. If we do, they are active in their health, they access healthcare, they actually demand for it, and we can refer them timely to the nephrologist. Healthcare workers, the teams should be multidisciplinary. I cannot emphasize this, and we can say that we know. But also the interspecialties. When they see a cardiologist, when they see an endocrinologist, because we've seen that diabetes and hypertension and heart failure are risk factors, do they communicate? When we see them and increase that dose of, yes, do we communicate? If they come on a Lasix dose of 20 and we've increased it to 60, do we communicate? Policymakers, economists, and political leaders. Dr. Isa. Now I am going to talk to you. So the scientists, these equations mean a lot to us. We do all the things and come up with a p-value, and then we fly with it. Does the p-value mean anything to the economist? The answer is no. They want to see the graphs that when you give this, this will reduce from this to this. They want to see cost-benefit analysis. The political leaders, they want votes. 2026 is coming. But how do we talk to them? When we are saying kidney disease is a problem, are we maybe telling them that when your people die, you lose votes? Maybe they would listen to that. So we need to know how to package the information to turn the p-values into the dollars that we need to be invested for screening. Media. Dr. Sekasam just talked about it. Bad or good, it makes people know that there is something called a kidney. We have seen the comedians asking, what is a kidney? And I don't want to repeat the answers that I have had here. Both social media and mainstream. Right now we are streaming. While 100 of us are seated here, so many people are getting this information in real time, but there is also longer duration of exposure because this information will stay. It can be repeated, there is far reach, it is easy to retrieve. So let's make media our friend. Other many stakeholders, the pharmaceutical companies, if they weren't, we wouldn't be here today. But we should remember that we need drugs, we need supplies. These are the people that import. Are we advocating for them? And we have patient advocacy groups that are advocating reduced taxes, taxi holidays, all those things, so that eventually patients can get drugs at affordable prices. Researchers and funding agencies. Without data, evidence, we are just speaking air. Insurance companies and employers. We need to advocate for our patients to stay employed so they can afford the services, but also the insurance companies. So, what are we doing in Uganda as Uganda Kidney Foundation? We have lots of screening efforts ongoing. Unfortunately, most are individualized. We do not have a nationwide screening program that is ongoing. We have Uganda CKD management guidelines as of June 2024. So the Uganda Kidney Foundation, together with partners, yes, please clap. Uganda, Protestant Medical Bureau, Healthy Heart Africa, AstraZeneca. So with those partnerships, then the endocrinologists and the cardiologists and nephrologists came together and developed the CKD guidelines for Uganda. So now we can boast about that, but not yet operationalized. But we have them. We are doing a lot of advocacy, and that's why we are here today. We are also doing some economic impact modeling together still with Health Heart Africa, AstraZeneca, so that data will come out maybe sometime this year. There's a lot of training ongoing, both for doctors, for nurses, for technicians, and we are trying to develop the Uganda Kidney Disease Registry. We shall tell you more tomorrow. We have more dialysis centers. In 2022, there were 15, I think, and as of today, there are 27. Private, please clap. Private, public, they are still very, very few. It's just a drop in the ocean. But it's better than where we have been. And we thank government for, even when it is not putting the public, which have also increased, by the way, but it has put an enabling environment for the private ones to come up, and we advocate for more. And then we know the transplant story. So, what are the future plans? The CKD guidelines talk a lot about screening, but also management. We need this to be operationalized and implemented. We need the people going to use them to be trained. Universal health insurance scheme. We have looked at poverty, we have looked at economics. We need this, like yesterday, so that people can walk into hospital and get the right things done for them without saying, I cannot afford. We need continued support for advocacy and training. We need support to establish the Uganda Kidney Diseases Registry so we can get data that we can use for planning. If you ask today that how many patients we now have money for dialysis, how many machines should we bring that will be enough? Dr. Tuhe here will just look at you and say, give me a month, 2 months. And then to the government, through Ministry of Health, the International Society of Nephrology has a petition that is ongoing. And in this petition, we are requesting the World Health Organization to make kidney health a priority, so that its member states can make kidney health a priority. Because we make our policies as Uganda, usually from World Health Organization's policies, when kidney health is not a priority, then it is not a priority in Uganda. So we are requesting you, this is going to be presented at the World Health Assembly in May. We are requesting the Ministry of Health, we are requesting Uganda to support this petition. This petition has been initiated by Guatemala as a country, but we need many countries to support this so that it is taken up and accepted at the assembly. So, what is the take home? We know the risk factors. We have to screen for kidney disease. And once we have screened, we risk stratify by staging. And then we can intervene. Today, as each of us is seated here, you have a chance to cause a global change, make kidney health a priority. And I'm going to request us, the President, Dr. Gavu, already allowed me to do this. So I'm going to request each of us, if in the past 30 minutes I have convinced you that we need to make kidney health a priority, I'm going to request you to pull out your phone. Please pull out your phone. Each one, if the convinced ones, pull out your phone. Even if you don't know why, pull it out. You'll ask me when I finish presenting why we were doing this. So pull out your phone. Remember, I have told you about the petition. For this petition to be presented at the World Heart Assembly, as the International Society of Nephrology, we need 1 million signatures. Out of the so many billions of people in the world. And this does not matter whether you're a kidney doctor, whether you're a doctor, whether you're a bricklayer, as long as you're a human being with a name, a country, and an email address. So please pull out your phone. We have internet in case you don't have. So go to Google. I'm going to do this with you. So I'm going to get out of the slides and go to Google. And then type in ISN sign petition. ISN sign petition. So, okay, so if you are at Google with me, type in ISN in capital letters, sign petition. And it brings lots of things. Just click on the first one. It says make kidney diseases a global priority / sign a petition. So please click on that. Okay, so once you have clicked, mine is still loading, it brings you the petition. And they are requesting you that whoever you are, you may be a patient, a caretaker, whoever you are, put in your name, your first name. When you scroll down, it shows you where to sign the petition. It asks for your first name, your second name, your email address, and your country. And then you scroll down and you submit. I cannot do that because I have already submitted mine. So you cannot vote more than once. But when you scroll down here, please put in your first name and your last name. If you're having any challenges with internet, let us know. Dr. Namara will come and help you. For most of us here, our country is Uganda. And then you put in your email address. Okay, anyone having challenges? And then you scroll down. They are asking you to subscribe to a newsletter. You don't have to. But when you scroll down after you put that, it says sign petition. So you click on that. And as you can see, they are saying there is a problem, but it's because I've already voted, so I can't vote. But I can look at the signatures. We are only 180 and we need 1 million. So I am waiting to see these numbers change as you people sign. Oh, a Chase, Dan has made 79. We are waiting for 80. I refresh. Okay. Ah, we are doing well. People are signing. Thank you. All right, so I want to thank you very much for accepting to sign the petition, and please share that on all your social media platforms with the hashtag Kidney Health Matters, and encourage your friends, your family, even your enemies to sign the petition. So as I end this presentation, I want to ask you, are your kidneys okay? If they are not, please, by the end of this week, make sure that you know how your kidneys are. Thank you very much to you for listening to me, to the farmers, in particular AstraZeneca, for sponsoring and for supporting us. Thank you.
much, Grace, for a very eloquent and passionate keynote address. Can we have a second round of applause for her? That passion comes from the frustration of having a patient in front of you and they need dialysis the first time you see them. So thank you so much, Grace. We shall have a brief note from Dr. Onyach to just give us a few comments and remarks. We thank you so much for coming. I really want to see and to hear your opinion and your views.
Thank you so much. The president of the Uganda Kidney Foundation, I think that's Dr. Gavu, is that so? And all the professionals here in kidney service, I'm happy to see you. And I want to thank you for inviting me here again to be with you. My name is Dr. Nathan Walufu Onyachi, not Warid. I think that was, this phone can mislead you. And you type Warid, but it's Walufu. And I recognize all of you here. And I really want to thank you for the work that you are doing in uplifting kidney care. And I particularly want to thank you because you came last year when I was hospital director of Lira to mark the World Kidney Day at Lira Regional Referral Hospital in Lira City. So I was excited to have been again invited to be here as one of the guests, to be with you here, and of course to inform you that I've left Lira, where I've been hospital director, and I'm now a member of the Health Service Commission. And we just reported on duty on Tuesday this week. That was my first day at the commission. And I'm planning to go and hand over in Lira because I hadn't retired. I was supposed to retire in November. But I'm now a member of the Health Service Commission, and I'm sure probably we shall be interacting with many of you when you come for interviews. Since I'm involved in appointments, promotions, but of course the other not so light side, disciplinary action as well, especially for those of you who are in government. We take out disciplinary action, and we have had our first task as Health Service Commission to review the standing orders. You remember in October, there was a directive by His Excellency the President that he wants the standing orders for health workers reviewed. You know, we've been having common public service standing orders that apply to everybody. We are now going to have standing orders specifically for health workers. And it is the mandate of the Health Service Commission draft or to make these standing orders. So at an appropriate time, we shall be consulting all of you to get your views on the changes that we need to input to the new standing orders. I want to recognize Dr. Sekasamvu. You know, Dr. Sekasamvu, your Jaja, was with me in the medical school. So I'm also a Jaja. And Sekasamvu was just 1 year behind me. And that's the time we moved together in the medical school. And I want to appreciate the work you have been doing in the area of nephrology. Thank you so much. And many other people have come in. I know Dr. Frank, I've known him for some time. He's involved in kidney transplant and other areas. I want to thank you so much for that development. You know, we started some time back, and I remember I told you this when I was in Lira. we started under a lot more difficult conditions, I think. And I remember telling you that for us, when we would be operating, we didn't even have a pulse oximeter. We would use the color of blood to know whether the patient is deoxygenated. And when the color was dark, then you'd say, can you position the neck properly so that oxygen can flow into the patient? That was the situation. But now you have pulse oximeters, monitors everywhere. I think you are in a good era. But we studied medicine during that time, and we moved on. And we lost quite a number of patients with acute kidney injury. And I remember one clinical officer in one of my hospitals just had a renal shutdown after delivery. And I think that one would have benefited from dialysis. But we just watched her die. That was the situation at that time. I'm happy to see that we are now saving many more of such people. In Lira, we started dialysis in the Lira hospital where I've been. We started dialysis about 2 years ago, just I think about 2 years ago. And I actually want to thank Kirudu Hospital for training my team in Lira. Is Kirudu here? Yes, Kirudu Hospital trained my people, and we started that dialysis center, and I think so many women, because the pregnant women, many who get eclampsia and renal shutdown, have been getting these services free of charge. And I think very many of them have benefited. And we have also had a lot of chronic kidney disease patients on dialysis. Although the number keeps fluctuating, and that has been my worry. We have now 27 centers, you've said so, for dialysis in the country, and many regional referral hospitals have come on. But I don't know on average how long each of these patients stays on dialysis. How many months or how many years? Because the few people I've seen, when you ask again the nurse in the dialysis unit, says that one died, that one stopped. So I actually got worried. I said, Dr. Frank, can you accelerate and maybe carry out more transplants? Because out there where I practice also, I find people who have given up on dialysis. We gave up. We could not sustain. And they are just there waiting to die. But I'm not saying this to discourage you from carrying on the dialysis. I think it is still important as a first step. And I understand Frank when he says we must succeed with the first patients. Otherwise, everybody will get discouraged. So I think we remain on course. We shall reach there. And I just want to encourage you for the good work that you are doing in setting up these dialysis centers, but also in starting the kidney transplants. But of course, the care, the prevention, I think, is quite important, as the previous speaker has mentioned. Managing those comorbidities well, diabetes, hypertension, and so on, so that we prevent this end-stage kidney disease. That many people can meet their maker when at least the kidneys are still functioning well. I think that's very, very, very important. And we, as Health Service Commission, will support you in any way possible. To see that you get the right cadres. I think somebody was telling me there are no specialists in nephrology. You can only end at medical officer, special grade, or physician. And now you want those specialists also to be recognized, officially appointed. I think that's what you are talking about. Well, we shall go, and this is just my first week. And I'm not alone. We have to sit and discuss and understand why it did not happen before. But I think it's a good proposal that we consider those professionals, that we consider specialized nurses that are working in dialysis units. I'm sure when Frank is doing the transplant, it doesn't work alone. I'm sure there are some specialized nurses as well who need to be recognized through appointment. And I think this is something that I'm going to share with my chairman and the members of the commission so that we consider. But if you can have some kind of write-up also to this effect, then it will guide us better. We can also receive a write-up on exactly how you want it to go and the different cadres that you envisage to work with. At this juncture, I think that's what I have to say. I just wish you the best in your deliberations today and tomorrow, and wish you a nice afternoon. Thank you so much.
Thank you very much, Dr. Onyachi. As he mentioned, he's only 2 days or 3 into the new office of member of Health Service Commission. It helps that you have a friend in a position like that. So give him another round of applause. We are well on schedule. We are in touch with our guest of honor who has indicated that they will be here anytime soon, and we are taking them for their word. We know they will be here. So in the meantime, as we prepare for lunch, we are going to have Dr. Atuhe to come and make his presentation, and I have the honor to introduce him. Many times it becomes easy when you're introducing a friend. When you're introducing a friend, it's very easy, and forgive me for personalizing this, but I've seen Dr. Atuhe from as early as 2000 and, should we mention the years? It gets scary. 21 years ago, we met Dr. Atuhe at campus, so I'm so sure that he went to school. Yes, so he has an MBCHB from Barrier University of Science and Technology, and he graduated with Masters of Medicine in Internal Medicine at Mother Kevin Postgraduate Medical School, the same school as yours truly and many in the audience. Here, he pursued his fellowship international in nephrology with the International Society of Nephrology, courtesy of the East African Kidney Institute. He's a renowned physician and nephrologist in town. He's also a businessman. It helps to introduce these things because life is in many ways beyond what we do in medicine. He supplies medical equipment, I must tell you. Yes, so please get to him for that. He's very passionate about AKI, and he's also very passionate about the transplant, and it's no wonder that he's coming here to talk to us about the Maiden Uganda transplants, our experience. Join me in welcoming Dr. Atuhe.
Just a second, please.
Good afternoon, ladies and gentlemen. My teachers, my colleagues, policymakers, students, businessmen, others, and my mentors. I'm happy to be here as always. It's always a pleasure to talk in front of you. My role today is very simple because I'm just telling a story. Something quite similar to what Professor normally likes to talk about. Professor Simwe, I'm happy that you could join us. It's always a pleasure to have someone who loves to see blood amongst ourselves as well. We have been part of a journey since time immemorial, whereby people have been dying of all kinds of diseases, and one of those diseases used to be kidney diseases. So sometimes in the past, patients or people, even our colleagues and our parents, they would swell up. They'd swell, they swell, they swell, they swell. And actually, there's evidence. The doctors at that time used to poke what? Needles in the skin. And interestingly, the water would come out because it would be so much. But of course, they would die. But so right now, what we are doing and what we are trying to show you is where we've gone and how far we've gone above the normal. I am speaking on behalf of every clinician in this area, in this Uganda of ours, and more especially in Mulago National Referral Hospital. I attribute some of my slides to Dr. Peace Pagasha. Thank you very much. And your MOs. And of course, my name is He, and I'll take you through the next maybe few about kidney transplantation and the Maiden transplants. As you well know, our first transplant within Uganda, on Ugandan soil, was a Christmas gift from the Ministry of Uganda, from Mulago National Referral Hospital. Specialists involved, nurses, cleaners, and our partners. It was a Christmas gift to Uganda. It was done on the 23rd? 20th there, right next to Christmas. So we spent Christmas in the ICU, but we enjoyed it because Jesus found us there. We were happy because if Mary had got an AKI, we would be there, very ready. Either transplant her or to do what? Or to dialyze. So I'll tell you about this collaboration that has been going on. I hope you can see the pictures. For those where there's a lot of light, maybe a bit of a problem. There's collaboration between Uganda and India. It's been a capacity building task from 2015. Remember, group of people who went for capacity building. Cadres, nephrologists, surgeons, nurses, etc. And I'm sure Professor has gone through this. But this is what it took to start the journey. Let me use that. Okay. They tell me this one works better. To start the journey to the Maiden transplant. As you can imagine, teaching ensued, skills were learned, and through that time up to now, many more people have been going for training on transplantation and other related services, ICU care, anesthesiology, etc. We attribute this to a hospital called Yashoda Hospital, which I'm sure Professor has told you about. We want to thank the Republic of Uganda, the Minister of Health, for making this possible, because some of this was actually sponsored by them. Mulago Hospital took up the mandate to make it possible for this transplant to happen, both through human resource, infrastructure, stakeholder engagement, etc. And indeed, some of the meetings we were having in 2023, some of them almost involved punches, but we made it through as victorious as you can imagine. We had, and I keep saying we because I jumped onto the group as soon as I came back from Nairobi, because it was a personal thing I wanted to do. So we jumped onto this, and I found the team very ready to start transplantation. Bagasha is laughing at me, I don't know why. There was back-to-back meetings. We used to meet every Wednesday, Mlago 6A. I don't think I've ever been to Mlago that much in my entire life combined than in 2023. And I almost felt like I was part of it. It felt very nice. So there was all kinds of stakeholders meetings. And what I noticed in that area, that the political will was very, very amazing. We had ministers calling in, we had permanent secretaries calling in, why have you reached to this? We had the medical director acting by then of the hospital calling in, see if we have had the meeting, wow, what have you done, where is the carpet? I didn't even know what carpets were all about, but serious things were happening. And I was very encouraged, and I knew this time it was happening. We had backup from our mentors. Dr. Kale Subula always used to ask, Motu sewa? Was it Tutu sewa? No. And it was always encouraging. It was always encouraging. We had meetings that were checking readiness of this. Do you have this? The Indians asking us about this and about that. And they were very passionate as well because they wanted to be a part of it. And this is what has pushed and what pushed it to where we have reached. We borrowed SOPs and brought them to our environment. Infrastructure was put in place to the best of the ability of Uganda. Of course, we had to have some memorandum of understandings because some capacity was not possible in some areas. And even these that joined us, public partnership that you're talking about, it is actually real. It is happening. I could mention some, but maybe I'll be breaching what? Things. So we had all this in place, and we were able to do some serious laboratory diagnostics and therapeutics. Some of the drugs we needed had to be shipped in as emergency, and this was done. And we want to thank the Ministry of Health for doing this for us and Manago National Referral Hospital. From that time up to now, there's been a change of, you feel a wave of positivity from both the patients, the caregivers, and actually even the health workers. Now they were asking, when is the next transplant? But the first one was like, when are you doing the other one? They're looking from the back, looking from the sides. But now there's a lot of enthusiasm from everywhere. And of course, the media does not leave people alone. They always keep poking you, when is the next, is there an Easter gift? Is there a Christmas gift? When is your birthday? There are gifts. So we are excited about the program. And one of the other things that helped, of course, was a huge open channels of communication between the partners that were involved in this. I can assure you, if Dr. Bagasha now picks up a video call and calls Dr. Sashi, he'll pick, because he'll be imagining maybe she's in a bladder somewhere, trying to remove a stain to the doctor who is Dr. Simwe. And indeed, this has been very, very helpful for us. This has been done and is being done. So what have we seen? This is a synopsis of what has happened. Due to, of course, ethics and stuff, we could not put up some of the things. This is as much as we can tell you for now. For those who are complaining about male and female, the balance has been reached. Well, there are more males than females in the world. Isn't there something like that anyway? Yeah, so there's a shortage of females. You saw that thing in the monitor. Shortage of females in the central and Uganda. So no wonder we have 2 females since 2023 up to now, out of 5 patients. In 2023, we were cautious, the team was cautious, and we did one transplant. And of course, it had, like Professor said, it had to be successful. The key word was had to be successful. And when it was, it opened the gates for other things to happen. So we had 4 more last year. As you can see, they are all below 50. So this thing you are hearing about young parents getting sick, young people, this is what we are talking about. The youngest is 21 years of age that was transplanted last year, and it's a female. So you can imagine the things that she has missed in her 6 years of dialysis. So that means she started dialysis at the age of 15, only to be transplanted 6 years later. The stories that this slide tells sometimes make you a bit emotional. So I'm going to ask Dr. Bagasha to bring some water so that we don't see tears. Most of the patients, the lucky one who was on dialysis for only 1 year, that is the one of the 29-year-old female, had lupus nephritis. Of course, lupus, as you can imagine, is an issue to think about during transplant and also after transplantation. We've had mainly first-degree relatives being donors. We have brothers, so boys are donating. There was an issue in Nairobi, there were not many boys donating, but here we are seeing many boys donating. And they're also young, of course. Okay? We have the youngest donor being 19. So at 19, you have 1 kidney. One of the key performance indicators that we are looking at in the African guidelines for transplant is how you follow up the donors. So these are people that we do not forget because they've donated. Say, Uganda, Gendo Some, pass exams, you be a good boy, come back in 20 years. We follow them up monthly, quarterly, 6 monthly, annually, 5 yearly, like that, depending on the risk of the patient or of the donor who has now become CKD but not correct. We have good results. As you can see in the last current status, I chose to put alive because there are some details that you would want to ask. What is the creatinine level? What is the tacrolimus mass level? I can assure you that so far, each of the patients has an eGFR of above 60. So they are doing very well. I was about to say the creatinine value, then I remembered what Dr. Gray, Dr. Kansime said. So the only issue that we had in the last cohort was that thing that is in red, the one that's called DGF. Now, DGF is delayed graft function. You could say it is an AKI state after transplantation, where the patient gets AKI that needs dialysis. So you can imagine what that does to the psychology of the patient. Yesterday they told you tomorrow you're getting a kidney. And you're happy, you're excited, hey, you're going to see urine, you even plan to take a video of urine and send it to your people in the village. Now, so he got DGF and he needed dialysis about on the 2nd day. It happens, and it's not a safety issue. Because of the several complications that happen during the transplantation process, that ischemia and reperfusion injury can actually cause an AKI. And patients must know this. Doctors must know this. As we do capacity building, and even as you do consent, one of the things you can expect is this, and that. When this happens, we shall do this, and we are hoping for this and that. Just like when you're going to do a herniorrhaphy. You tell the person, I'm going to remove, but I can poke your inguinal, you can poke your what. Do they remove testicles during? Okay. So all those things you tell them, because it can happen. And it's good that actually this happened, because it even opened our eyes further into the consent process of the patients. Anyway, after 3 days of dialysis, the urine came, and the man is now good. His creatinine is 110. Yes. So that can happen. But in some instances, a patient can be on dialysis right after transplantation, and they don't go back on dialysis because something. Reperfusion is not a simple injury, unfortunately. So the other one we are watching is the lupus nephritis, because there are issues of recurrence. She is female and she's young, so we are keeping our eyes very, very close to see what happens. Unfortunately, renal lupus in such patients usually is diagnosed by biopsy. It's possible that we might have to do maybe protocol biopsies every year or something like that, or look out for proteinuria urine. But these are things that the team is aware of, and we shall see how it goes over time. So it's been a good run so far, and we want to thank the team. We want to thank God for making this happen. Only one DGF, and all have EGFR above 60 as per the last review, which is not very, very far long ago. And so we thank the Lord. Some challenges, of course, are there, like they've been mentioned, mostly around therapeutics and diagnostics. The long time for tacrolimus levels is a general thing. Even in the East, it takes about maybe 5 days, 7 days. Here it takes about 9 days. But something you get to learn to work around until Health Service Commission comes in. So look, we are looking to increase the numbers to aid capacity building for all the cadres that are involved, and that is something that we are very excited about. Of course, with all those things, the therapeutics and the diagnostics taking a bit of time, the pre-transplant becomes a bit lengthy. So the patients, you see, sometimes even see them getting tired. So you have to continue, don't worry. I can assure you, peace is now more of a counselor than a dialysis doctor. The woman can speak words. So of course, I wouldn't go without giving a gallery. I do not have to tell you whose head that is, you can see, you've seen. Then, yeah, we had a rota for that week, and we had several drop-in. For those who could take pictures, you see those who are flexing their muscles, they are ready to, I don't know what he wanted to do. What had the camera person done to you? Yeah, Dr. Esther, I was seen around somewhere, and Wagasha. That was a team, I think this was last year, yes. It's a team of nurses, doctors, the anesthesiologist, the surgeon with their residents, and the theater nurses. Good stuff. This was a picture from 2023, then this is 2024. And that is Dr. Sashi Kiran, the nephrologist, with Dr. Peace Wagasha. I'm sure you remember this picture. We're delighted to have the minister join us in 2023 and the team at Mlago for a joint picture with the deputy. And of course, the professor was there as well. So in conclusion, it's been an adventure. Benefiting the team, it's benefiting the country at large, and of course the patients are enjoying this without a doubt. Oh, so early this year, 2025, Uganda was recognized as a transplanting country. Oh yes, it was. Yeah, so it was recognized, and we were hailed for doing a good job. We were given a post in the committee for transplantation, and we took it. So we shall undertake more and more procedures, of course, and like Professor Frank likes to say, the umbilical cord shall be cut very soon. Did you say it this time around today? Yeah, so the umbilical cord is the one from the other picture I showed you of the India joining Uganda. Once that is cut, we are on our own and we shall enjoy it even more. Of course, stakeholder meetings are ongoing to rectify some challenges, and we are hopeful for the best. Thank you very much.
Elaborate presentation. It's actually 2 years ago since Professor, let me call him Professor, Dr. Sekasanvo stood here and said that he can now get kidney disease. He's the happiest person in the room. God forbid. And this is exactly how I feel. There's so much happening in kidney disease in Uganda. The future looks very, very bright. Last year we were in Lira talking about our 1 kidney transplant. This year we are here talking about 5. Imagine what will happen next year. So as we end this advocacy session and allow people to go for lunch, we're going to have a short lunch so that we come back. But as we end this advocacy session, I just want to say that I'm really privileged to be part of the kidney disease community, and I'm really privileged to have all of you who have come to join us. And I hope that this is a sign that you're going to stay with us forever. So I'd like to invite all of you to have lunch. We are still waiting for our guest of honor who will come for the afternoon session. And as soon as he arrives, we're going to call you back so that we start the afternoon session. So lunch will be a quick affair. But thank you all so much for coming, and please enjoy your lunch. So we'll get lunch coupons from the registration desk, and then the lunch is going to be at the pool side on the other side.
Well done.
Ladies, please, let's rush for lunch. We need to save time for another session. Please, let's rush for lunch. Let's go for lunch. We have a few minutes to start another session. Thank you. Let's rush for lunch. We have a few minutes to start another session. Thank you.
Statistically significant because includes observations and resting observation, but those patients who are on TDF medication had higher odds of developing kidney disease. Unfortunately, we are not statistically significant, but the p-value which was more than 0.05. I think those are the questions which I have.
Thank you so much.
So we unfortunately we were not participating in the treatment of these patients. So we just gave back the feedback to the health workers who were manning the hepatitis clinic, and we advised them to check expensive to a common person, and very sure in Malala they are not there. However, in Kampala they are available on private pharmacies. So we advised the health workers. I had a question, Doctor, about it. Yes.
Actually, we are running out of time. We are already into the time of the next session. I think you would have a one-on-one discussion with him, I would advise.
Thank you so much for your question. I think the question
expensive to a common person, and very sure in Malala they are not there. However, in Kampala they are available on private pharmacies. So we advised the health workers. I had a question, Doctor, about it. Yes.
Actually, we are running out of time. We are already into the time of the next session. I think you would have a one-on-one discussion with him, I would advise.
Thank you so much for your question. I think the question is about you have to make sure that you have removed all medicines which might be teratogenic to the baby. And then the final thing you have to do is refer her for observation that the baby is delivered in a healthy manner. Thank you.
We are into the time for break. This is the World Kidney Day, and we are
statistically significant because includes observations and resting observation, but those patients who are on TDF medication had higher odds of developing kidney disease. Unfortunately, we are not statistically significant, but the p-value which was more than 0.05. I think those are the questions which I have. So we unfortunately we did not participating in the treatment of these patients. So we just gave back the feedback to the health workers who were manning the hepatitis clinic, and we advised them to check expensive common person, and very sure in Malala they are not there. However, in Kampala they are available on private pharmacies. So we advised the health workers. I had a question, Doctor, about it. Yes.
Actually, we are running out of time. We are already into the time of the next session. I think you would have a one-on-one discussion with him, I would advise.
Thank you so much for your question. I think the question is about medicines which might be teratogenic to the baby. And then the final thing you have to do is refer her for observation that the baby is delivered in a healthy manner. Thank you.
We are into the time for break. This is the World Kidney Day, and we are
statistically significant, includes observations and aggressive observation, but those patients who are on TDF medication had higher odds of developing kidney disease. Unfortunately, we are not statistically significant, but the p-value ratio was more than 0.05. I think those are the questions which I have.
Thank you so much.
So we unfortunately we were not participating in the treatment of these patients. So we just gave back the feedback to the health workers who were manning the hepatitis clinic, and we advised them to check expensive to the common person, and very sure in Malala they are not there. However, in Kampala they are available on private pharmacies. So the health workers. I had a question, Dr. Wati. Yes.
We are running out of time. We are already into the time of the next session. I think you would have a one-on-one discussion with him. I would advise.
So transplant will also always offer an ability to return to normal life. I'm putting normal life in quotes because there are also other factors that have to be fulfilled for a patient to get back his normal life. But also there is improved quality of life with transplant, and also there is increased life expectancy. It is estimated that a graft from a live donor can last for about 15 to 20 years, whereas that from a cadaveric donor can take you 8 to 12 years. There's also cost-effective with transplant for the patients, the family, and the healthcare system. As we have how Dr. Kasime presented, there's a lot of cost associated with dialysis. Much as the initial cost with transplant is expensive, but the overall, the long-run cost is cut with transplant. So we always encourage all patients who are transplantable to seek for transplant as soon as they can. So there is the multidisciplinary transplant team, and when you look at the center, there is a nurse. So the nurse is the only person who is going to come into contact with all these multidisciplinary people. Down there is a patient. Some of the multidisciplinary team members, they may not come into contact with patients, like the laboratory, like histopathologists, but it's the nurse who is going to be in contact with all this. Like a saying goes that behind every successful man, there is always a woman, but also behind the downfall of a successful man, there can be a woman still. So here, so when we come back to our hospital setting, you know, nurses are the backbone of the hospital. You might have a very good doctor, nephrologist, like our own doctors, very good, brilliant. You might have a very best surgeon in the country or in the world. You might have the best lab. But if you have a very bad nurse, your efforts are always futile. So a nurse is the backbone of all care in the hospital. So let's go to the nursing care management of a transplant patient. Kidney transplanting nursing management involves comprehensive pre- and post-operative care, focusing mainly on maintaining fluid balance, monitoring complications, and kidney rejection, signs of rejection, infection, and educating patients on medication adherence and self-care. So when you look at the picture on the side, those are some of our nurses taking care of one of our transplant recipients in the previous transplant cohort. And as you know, the journey of transplant, most of our patients come from dialysis. We always have a few who go direct for transplant without passing through dialysis. So all our patients, almost 99% of patients who receive transplant, they must have passed through dialysis. So a proper dialysis management is a very key in the outcomes of transplant. So for patients on dialysis, nurses provide dialysis care and educate patients and families on self-management of dialysis. Nurses ensure that patients get adequate dialysis. Because if you don't have adequate dialysis, your post-transplant management will be problematic. So always encourage that our patients who are being prepared for transplant, they should pass through comprehensive series of dialysis, and the orders must be good and adequate. So also nurses encourage patients to adhere to dialysis treatment as to minimize complications. Also adherence to medication regimen, especially the antihypertensives. Good antihypertensive control will ensure that there is minimal cardiovascular events, and also make sure that the patient is stable and our transplant outcome will be good. We also encourage our patients to take their medication, especially the ESAs, these are therapeutic stimulating agents, to make sure that they have a good HB. Because with the experience, we note that if patients are transfused routinely, that always affects our transplant outcomes. So nurses are always on the forefront to educate patients to avoid transfusions so that we can have the best transplant outcome. Optimizing patient care status through management of fluid balance, electrolytes, identification of anemia, and infections. So always encourage our patients to make sure that they minimize or prevent infections as much as possible. And it is the role of the nurse to always encourage patients to have fistulas, because we have realized patients who have fistula, they do well on dialysis, and therefore they have good post-transplant outcome. So a picture there is one of our giants in nursing. Those three people, they have done tremendous work in dialysis in Mulago, and they're always there to encourage patients to have the best out of dialysis. So nurses are also involved in assessment and evaluation of both donors and recipients for transplant suitability. Yes, we may be aware that transplant is the best treatment for end-stage renal care, but much as all patients may want transplant, but not all are suitable. When you pass through the corridors of nurses there or in the RT rooms, they will always have discussions that, nayo yanamalako, or your taina rugendo. So because nurses always are in close contact with patients, so they will always advise doctors on what to do and which patient needs more reviews or more attention. So patient education, nurses are involved in educating patients, families, donors about the entire process of transplant, answering all the questions, allaying all the anxieties associated with the transplant, and also dispelling all the myths associated with kidney transplant. Some of the myths are, we keep getting donors asking, will I produce, will I give birth after donating my one kidney? So it's the role of the nurse to always clear this information and always tell patients or donors that it is not the kidney which gives birth. So also coordinating all the diagnostic and investigative tests. Nurses are always on the forefront of running up and down here and there, making sure that all the tests are available and reporting to the multidisciplinary team. In this case, our immediate person is the nephrologist, to make sure that all these tests are reviewed. And also nurses are involved in proper record keeping, so that all the forms, all the documentations are there available for reviews. So on the admission of recipient or donor, that's when we are approaching now the transplant period. Nurses are on the forefront of admitting these recipients or donors before the transplant. So we are responsible for finding patients' medical records, finding previously prepared forms, verifying all the consents, all the legal documents, as you're aware that transplant is associated with so many legal implications. So it is the role of the nurse to make sure that all these documents are available and they are ready for review by the doctor. Blood samples for routine tests including viral markers, blood grouping and cross-matching, and booking blood for the transplant period. And here we encourage all our patients to maybe at least have 2 units of blood. Those who are going for transplant, always book blood ready for them and make sure that the blood is irradiated. The purpose of irradiating this blood is make sure that we deplete all the lymphocytes so that we can minimize the risk of rejection. Also have to make sure that the weight monitoring and height are taken, and also ongoing psychosocial support is paramount for the nurse. Because these patients and donors, they are always worried, so nurses are more of counselors. We educate these patients, we allay their anxieties to make sure that they are stable and their minds are ready for the procedures. We make sure that patient has been reviewed by the nephrologist and all the multidisciplinary team members. Pre-medications have to be given as prescribed. So during intraoperative period, you can see that picture there. The surgeons are busy on table, not minding about the surrounding. So it is the role of the nurse, one, to make sure that the right patient is the one in theater. So we verify patient identification, we verify that all the consent forms are signed, and all allergies are well documented as the patient goes to theater. So also inside the theater, the nurses maintain a sterile environment to prevent surgical site infections. Also during the procedure, nurses monitor vital signs, including that is blood pressure, hemodynamic stability, oxygenation, and urine output. As you can see, the surgeons are there on table, so the nurse's role is to watch out, to make sure that our environment is safe for the surgeons. And as it is said, that if the surgeon does not see urine coming out of the patient, then the surgeon has to urinate. So it's also important that the nurse keeps watching out for all those. In the immediate post-operative nursing care, the nurse's roles are frequent assessment of vitals, monitoring fluid and electrolyte balance, administering intravenous fluid as prescribed, and monitoring the electrolyte levels. You also administer analgesic as prescribed and assess the pain levels. We monitor urine output closely and report any sudden drop or sudden increase on cessation of urine production, because that can be an early sign of acute kidney rejection. So you see the picture there, the nurses are talking to our patient, there's also a doctor trying to assess pain, finding out any concerns from the recipient. Then also in the first hours of post-transplant, we strictly observe barrier nursing, and barrier nursing will isolate our patient in ICU, and there has to be one-on-one nursing care, not forgetting PPEs and hand hygiene to prevent infections. So when you look at that nurse, it's all well equipped, PPEs are on, hand gloves are on, and reassuring our patient and is on one-on-one nursing care so that you don't miss out anything. So that is a flow chart of events of nursing after kidney transplant. The daily events, of course, are blood samples, which are always taken early morning, preferably at 6 a.m., so that when the doctors come for round, you always have baselines. Then body weight monitoring every day to assess if there's any fluid irritation, measurement of fluid and urine production, vital signs, wound inspection, then also hygiene and medication. These are the daily routines that a nurse has to do post-transplant. So on the day one after surgery, we have to arrange for ultrasonography to make sure that our kidney is working well. Wound drains, if there are any, they have to be removed unless indicated by the surgeon. But usually on day one after our operation, we plan to remove the drain. So the nurse's role is always to remind the surgeon or to ask the surgeon about the next plan for wound removal. Mobilization and breathing exercises with the physiotherapist. So we always link up with the physiotherapist to make sure that these exercises are started as early as possible. Then also you encourage the patient to start taking oral drinks and foods. Because after transplant, most of these people are stable. We keep them in ICU just for isolation purposes to make sure that there are no infections, and also to keep them away from the community to allay other anxieties and the rest. So on day 2, we have central venous catheters, which we prepare to remove the central venous catheters. This is on assumption that our patient is doing well, the urine output is okay, and there is no need for dialysis. But if there is no need, if there is need for dialysis, so it's the role of the nurse to liaise with the dialysis team to make sure that the patient is having his dialysis. Then also nurses have to teach patient about which medication is which tablet is which, and also maybe warn them on the likely side effects of these medications. For the donor, there also admission by the nurse, review, just a minute. So if I may go back on this post-transplant, we usually keep our patients in ICU for the first hours, and we practice one-on-one nursing so that the patient gets the optimal care, because we are always anxious, both the patient, the family, the multidisciplinary team, to make sure that our patient has the best outcome. So this is incumbent upon the nurse to make sure that all these parameters are followed so that our patient can get the best out of it. Then for the donor, of course the donor is not always sick, is not a sick person, so we manage as any other post-operative patient, where we admit the patient and make sure that the donor has reviews by the multidisciplinary team, and also there is evaluation by the anesthesiologist, the cardiologist. Then make sure that the donor is shaved and all nails cleaned, then showered and clean well twice in the evening of the transplant. And usually we encourage them to bathe twice, 4 hours apart in the evening. Then if there is any pre-medication prescribed, then it's given. Then on the day of operation, pre-medication as prescribed, showering and painting, plus or minus painting with iodine. So we usually paint these patients from the upper abdomen up to upper knee, both front and back. Try to minimize any infections and make sure that they are ready and they are okay for theater. Then checking of vitals, reassurance is ongoing. Then we return from the operating room in the afternoon mostly. Then we go to the post-operative ward, and all post-operative care continues. So in the long-term follow-up and education, 1, we follow up, nurses reassure the importance of lifelong follow-up with the transplant team. And usually post-transplant, in the first 1 month, we encourage this patient to always come back for reviews twice in a week. And also in the next month, tell them to come every weekly for reviews. And during these reviews, we do investigations and make sure that they are reviewed by the nephrologist and the surgeon. And also we encourage these patients to adhere to their medications. And usually the most important medications we tell them never to miss is prednisolone, MMF, tacrolimus. Then for infection prophylaxis, that is Septrin and valgacyclovir, to make sure that they are not exposed to infections. Then also encourage these patients to always watch out for complications and acute early signs of infections. Then we link them up to support organizations. As in Uganda, we've just started transplant, so sometimes medications might not be available, but there are other groups of patients who usually arrange and get these drugs from India. So we encourage them, we link them up to those groups, and also we link them the psychosocial support, because they are always challenged with a lot of anxieties. So in Uganda, we have the Uganda Kidney Psychosocial Support Organization, which keeps talking to these patients, reassuring them so that they always have a good life after transplant. Thank you.
Thank you very much, Mr. Masereka. All protocol observed. We are going to change a little bit to do the ceremony. Our guest of honor has come, so we will interrupt the academic sessions to make sure that we give him time to come and talk to us. So our guest of honor today is supposed to be the Director General, Dr. Oraro, but he has sent us a representative, Dr. Balugahari Hirare. Dr. Bakatuingire, yes. Bakatuingire Richard. Okay. He's the commissioner for health. He's actually my boss. So if you didn't see me in the morning, he was the one who had called me to the medical board to make sure I was there. So I'm happy that he's made it to come here. And we would like him to come and address us and tell us the plans he has for kidney disease. Maybe we'll make our ask after his presentation. We have two big asks of you, guest of honor. Very welcome.
Thank you so much, Prof. Kaliesubla. Maybe just for correction purposes, my name is Ronnie Bahatunjide, and I'm very delighted to be here. I will stand on the protocol that has already been pronounced, and I will deliver this speech on behalf of the Director General of Health Services, who has not been able to make it. He was engaged in another meeting, and as the Commissioner in charge of clinical services, I fell in the docket directly. I'm very delighted to be here to meet my colleagues. Yeah. So, distinguished speakers, the leadership of the Uganda Kidney Foundation, ladies and gentlemen, on behalf of the Minister of Health, I join you and the rest of the world to commemorate the World Kidney Day 2025. As you have heard from previous speakers, the global kidney community has dedicated every second Thursday of March as the official day to remember kidneys and the vital role they play to keep us healthy as human beings. The theme for this year is, are your kidneys okay? Maybe I could pause at this point in time to ask the nephrologists that are in here, how many of us are aware of the status of our kidneys? How many are aware of the status of our kidneys? We know the health of our kidneys. Well, that's very good. This theme seeks to emphasize the critical need for screening activities at all levels of healthcare, and this will lead us into early identification of kidney disease and timely initiation of treatment to ensure better patient outcomes. As has already been highlighted, if we delay to intervene, we also are at risk of getting poor outcomes from those that we seek to intervene with. And therefore, looking at the burden of kidney disease in the country, in Uganda, kidney disease is alarmingly on the rise. And right now, we stand among the top, it stands among the top 10 causes of adult death in the country, with a case fatality rate of 21% amongst patients that are admitted with chronic kidney disease. The prevalence of chronic kidney disease, I believe these statistics have already been shared with us here, but looking at the statistics that have been documented, the prevalence currently stands at 2 to 7%, and up to about 15% amongst the patients that are living positively with HIV/AIDS or those that are having hypertension. And the most common causes of kidney disease in our settings are not yet well established. However, for most patients, kidney disease is a complication of traditional risk factors, and these have been listed amongst many of us as diabetes,
We all are aware that hypertension is a risk factor. HIV infection is a risk factor, especially amongst those that fail to initiate treatment early enough, as well as others. And amongst the children, we see infections as one of those leading causes of kidney injury and kidney disease, especially malaria and diarrhea diseases that tend to rid our children of sufficient hydration and end up risking our kidneys. A story is told of the poor practices amongst us as Africans, where we know we are in dry environments, and yet our water intake behavior is also very low, which continually exposes our kidneys to failure or to injury. And I do not know what we as nephrologists are doing to help address this challenge. Peace. How many times have you encouraged your patients to drink sufficient water so that they can remain hydrated? Every single day. So this is one of the things that possibly that we could try and explore and see to it that we try as much as possible to prevent kidney disease. And currently looking at the dialysis centers that we have available in the country, limited to only Kampala, Mbarara, Mbale, and Lira. Out of the 130 districts that we have in the country, this is a paltry, very low number to address the concerns that we have across the country. And that means that we need to be seen to invest more in prevention rather than curative. We need to invest more in making sure that we prevent kidney disease, because the repercussions of treatment are not very easy for us to deal with, and therefore we need to invest in preventing these concerns from arising. As a country, we need to make sure that we need to address the concerns over long distances that patients have to make to access care. And as the Minister of Health, there is a commitment to make sure that these dialysis centers are brought to each and every regional referral hospital in attempting. Yeah, it's important to clap. Yes, it's important to clap. We are working with Chirudu National Referral Hospital that is seeking to support establishment of dialysis centers across the whole entire country, where we have 16 regional referral hospitals. And we believe when this is done, we will be able to reduce the distances that patients have to trek to access dialysis services. But before patients are requiring of dialysis, what have we done to prevent these events from occurring? That's the key question that as nephrologists that we should be asking ourselves. Because kidney transplant services are only being developed, which is a rare occurrence. Professor Simwe, how many cases have we done to date? 5. Oh. Well, that's very good. And we need to be seen to develop this service as well, just to make sure that we reduce the cost of services that are requiring of this particular intervention, because it can only be accessed when people travel abroad to access these services. We are currently facing a challenge of inadequate human resources with only 15 formally trained nephrologists, 12 adult and 3 pediatrics, serving a population of 44.7 million people. And this is not sufficient, looking at the patient healthcare worker ratios. And this calls on government to ensure that we are able to support this undertaking. And I take this opportunity, colleagues, to inform us that it is a drive and the intention of the Minister of Health to develop super specialized services in this country, and we are getting intentional about this. So we hope that in the near future, we are going to have an opportunity where we will be reaching out to colleagues to make sure that they are directed and pointed toward super specialization. And I believe if this call comes out, we as nephrologists, physicians will opt to come and train in nephrology, because that is where we're still having a very big gap, as well as other specialized services. Ministry of Health plans to improve kidney care in Uganda, and this is one of the things that we've already talked about. One of the things that we hope that we will be able to deliver is through prevention, screening, and surveillance, and we believe this can only be achieved if all of us work together as a team. I've seen so many papers in the booklet that have been presented here, and this is a question that I've always put before our colleagues that are in academia. We write so many good papers, but these papers remain on the shelves. How often do these papers translate into policy? How often do these papers translate into policy? We have a paper that is speaking about the burden of, I think it's predictors, the predictors of chronic disease on prostate cancer, something like that. Yes, that is a very good paper that I believe if we were able to expound on it, it would be able to inform policy on how we care for those people that present with cancer of the prostate. But this is not information that is available to us. No, I can attest to this. This information is not available to us. I pretend over clinical services where we make work plans that are aiming at improving care in this country, and nothing like this has come to us so that we can inform how best we can improve practice in this country. So colleagues, I want to encourage us to not only seek to develop or to write papers so that we can get accolades as professors and the like, but rather let us be seen to translate our research into informing practice. Only then are we going to impact our practice environment. And only then are we going to be able to contribute to this environment that we call our motherland, Uganda. Clinical care for chronic kidney disease. The Ministry of Health is keen on supporting the proposed Kidney Disease Institute as a center. Yes, it's important to clap for this. The Ministry of Health is keen on supporting the proposed Kidney Disease Institute as a center of excellence, and this will be used as a platform to coordinate prevention campaigns, training programs, research, and the expansion of quality kidney care for all Ugandans. And colleagues, I want to call upon all of us to invest our efforts in making sure that this constituency is developed. Dr. Makanga, I'll challenge you because you're my teacher. You and Professor Bruce were on the same wards when you were doing your internal medicine physician postgraduate. Right now, Professor Bruce has lifted up, and his team, the Makerere Lung Institute, and we all are seeing the works that the Makerere Lung Institute is doing, both in research, but then also informing policy. Currently, there is a lot of work that the Ministry of Health is implementing through the Lung Institute when it comes to management of public health emergencies. We have so many vaccine trials that are running through that institute, and I believe this is an opportunity for us as a constituency to come up and create a similar or a semblance of the like. No one stops you from creating this platform and therefore using it as a platform for advocacy. It's only then that your voices can be heard. So I believe with these challenges, we will be able to achieve these landmark objectives that we're seeking out for. And therefore, as I conclude my remarks on behalf of the Director General, I want to once again thank the Uganda Kidney Foundation and the different stakeholders for commemorating this day, and also reaffirm the commitment of the Ministry of Health to improve kidney care services for all. And I will propose that we organize a stakeholder workshop to discuss in full detail the proposed National Kidney Institute. On behalf of the Ministry of Health, I wish to thank you so very much for convening, and we believe that when we deliberate at that stakeholder engagement, these ideas will come to life for God and my country. Thank you so very much. I'm sorry, colleagues, I'd wish to point us all to page 10 of this booklet. Whoever wrote this paper, I'm kindly challenging you to come and interface with me and let us pursue this, please. Thank you.
Another round of applause for our guest of honor, please. Probably for me, my take-home message from this speech is the excitement from government, because you're government, about the drive for the Kidney Institute. Yes, we've been lagging behind, but it has been small steps. Like my teacher, Professor Frank, says, one step at a time. About 4 or 5 years ago, he was telling us we shall start transplant. And people were laughing at him. Now we have done so many. 5. So thank you so much. I know you also tasked people here. While you were away, the initial presenters talked about most of the things you've highlighted. Prevention, prevention, prevention. You talked about people drinking water here. And I want to report that a few minutes ago, we had a very mouth-watering lunch upstairs. And some colleagues here galloped like 3 Coke bottles with no water. And yet it's very hot. Now it's cool. So prevention and prevention. But we thank you so much for the commitment from government. And we look forward for the invitation for the stakeholders' engagement towards the Kidney Institute. I know it has also been a dream for Professor Kaliesula, who I think had one time engaged the late, I think, former Prime Minister, Professor Apollon Sibambi, who also had a dream that we should start a Kidney Institute. And now that you mention it, maybe we will reactivate the whole idea. So thank you so much, and we look forward to engaging with you. I hope your security will not chase us away when we come to your office. So colleagues, going forward, so we shall continue with our program. Sorry. Oh, sorry. We would like to have a brief photo moment with our guest of honor. Yeah, I think probably here. I know all of us may not be able to fit. Maybe I'll ask the presenters. Dr. Peace. Sorry? Here. So what about here? Some stand up, others down. That's okay? Okay. Whoever is in charge of lights, please, we could switch off the bright ones. So may I ask the high table? Our high table is there. Maybe they will stand right in front. And then the rest, especially the presenters for today. And some colleagues will stand behind. Stand behind the chairs, and then others. Okay. Oh, so that we get a few chairs for the front row, then other people stand behind, then others go. May we move this?
It's also part of the depot.
Colleagues, please don't fear photographs. Oh, they need. Please switch on the lights. Please switch on the lights. Please, all of you, some people can go up. Hey. But for me, I'm now tall. I will. They bring a chair.
Anita, no, timekeeper, I don't know who.
Thank you all for the photo moment. Ladies and gentlemen, let me hand over to my co-chair, but we are making a slight change and you'll bear with us. So let me hand over to Professor.
Thank you very much. So we are going to have a slight change. We have Dr. Sechitoleko, who has just run out of a surgery. So you'd bear with us, Dr. Nyende, so that we let him present first. We need some help to change to Dr. Sechitoleko's talk. So Dr. Sechitoleko is a doctor with MBCHB. He also has a master's of surgery. I was privileged to work with him as part of his master's. He went ahead to do a specialization in neuro-onc and is currently actually finalizing his PhD, again focused on onco-urology and nephrology. We work with him in several places, and he was very instrumental, along with Professor Simwe, in conducting the first transplant. I know surgeons are usually very busy, but we are very, very privileged to have you. I know he's a very charismatic young man. He does laparoscopic surgeries. I've worked with him, removing those big stones and explaining to a lot of patients. He's very passionate, so we really appreciate you. Dr. Sechitoleko, you are very welcome to share with us. I know you are fasting, so I hope you are able to deliver.
Thank you, Prof. Colleagues, protocol observed. I'm Badru. I'm privileged to present this team again. I was once here 5 or 6 years back, and we are in Parliament, remember, Dr. Rose and Peace. Still is that 2018? Yeah. 19. You had invited me to talk about stones. The nephrologists are fewer than us, but they are organized than us, Dr. Frank. We need to pick a tree because we are supposed to be twins. Because when we hear that you're making an institute, Prof. Kalyesubola, and you are forgetting us, it's a very big disservice. Because ideally it should be the Nephrology and Urology Institute. That should be the right thing, right? Thank you very much. So, today I was invited to talk about kidney transplant, the surgeon's perspective. I'm going to be a little bit brief because in the interest of time, I'll be brief. I understand that Dr. Frank would have mentioned a few aspects about transplant. I missed his session. Was yours political? Oh, well, good. So, it is a big team when we are talking about transplants. It's not a one-man show. We work with the cleaners, the guys who give us food, the nurses, the lab techs, the pathologists. But the most important person on that team is the nephrologist. If you're having a poor nephrologist, then the work is going to be botched up. Days back, if you are to look at the tradition of transplant, before the nephrologists came in, because you know, with the surgeons, they get pick then put it in someone and they go away. But you need someone to take care of that kidney or the graft. If you don't have a thorough nephrologist, if you have to look at the history, why actually there were failures before, the issue wasn't the surgeons. It was the nephrologists and the drugs that were on market then. So we applaud our nephrologists, and we believe that the 5 patients we've worked on with us, we did our job. If you hear that those patients have failed, do not be us. It will be the nephrologist. So, I'm sure that the nephrologists have talked about the baseline labs and everything we are supposed to do. When you are working up these patients, we work with them. Okay? There is a special part they do. Likewise, as the surgeons, there is a special part that we do. The pathologists also do a special part. The radiologists also do a part. Everyone does a part. Even the legal team does a part. We do not have a council yet, but even the council does a part. That is the journey, all right? It doesn't start from theater, but it starts from the day actually the nephrologist says, yes, you need a kidney. Okay. So everything is done, okay? The nephrologist has okayed. Everyone is ready. The donor is there. The recipient is there. And it is our show, okay? Many times we want the nephrologist to be in theater. They are timid. They don't want to see blood. But at least for the transplants that we did, Peace was in, he was in, and I'll tell you that when they are in, they do a special job, okay? And that job is taking care of the kidney immediately. We get it out, okay? So there are a number of ways we can get a kidney from the patient. Either we can do laparoscopic, which we haven't started for some reasons, okay? Knowing that we do not have the laparoscopic skills, we have deliberately decided to start with open, then we transit to laparoscopic when we are harvesting it from the patient. So we've normally, for the patients we've worked on, they've all been alive. Our transplant theater is world class. If you get any time, visit it. It is state of the art. I would say that where I trained from in India, that theater is better than my training center. So just find time, visit that theater. It is world class. We've not started the deceased donor. I'm sure Dr. Frank would have talked about it. Even robotic, maybe not near. Okay. We have basically done the open donor nephrectomies. And in case you're to do about removing a normal kidney is easier than removing a kidney that has cancer. So this takes us about 40 minutes to around 1 hour, okay? Taking out this kidney because it's not diseased. And normally there are 2 teams. You can decide to be 1 or 2 surgeons to do the job, but with us we divide. Maybe 2 surgeons for transfer of skills, 2 surgeons to do the donor nephrectomy, then as other 2 surgeons are preparing the recipient side. So if it is laparoscopic, maybe for any other laparoscopic kidney disease, we still do the same. We put pots here. Okay, just a pot here, here, you put a pot, then you deliver the kidney from here. For example, if the kidney had cancer, I would still do the same thing. You would put a pot here. These are the keyholes. Put a pot here, then the camera goes through this, and your working channels, this and that. And when it comes to retrieval, if an still incision, just like that incision they give mothers. Okay, this is better. And the donors would actually want this because the pain is less, all right? And the scars are not as ugly as this. So when we are done with taking out the kidney, okay, peace comes in, and Atuhe, Prof. Kayesubala, Dr. Rose, they come in. Okay, we work with them. And they do a lot of work. We call it benching, okay, or bench work. So basically here, what they do is perfusion. Okay, you perfuse this kidney. And there are special fluids that we use to clean out this blood that has clotted within that kidney. And as the surgeons, we defat, we remove this fat that is around, we prepare these vessels, and all throughout this time, this kidney is in ice. Okay? Towards the end, I'm going to talk about how to prevent ischemia. You do not have a lot of time at this point, okay? Because we know that cells need oxygen, and at this point, this kidney or these cells are no longer receiving oxygen and blood. So this cold ischemic time needs to be respected highly. And that's the job of the nephrologists, making sure that the surgeons actually are doing their job. Because if you fail at this level, then either you're going to get issues with graft failure, delayed graft activity, and issues like that. So the moment we take out the kidney, you see that the entire theater is on tenterhooks, all right? Because you need to prepare this kidney, remove all the fat, prepare the ureter, remove all the accessory vessels, and the team that is in the opposite theater by that time is also waiting, okay, for that kidney. This is the way the kidney looks like this, all right? For some of us who have never seen the kidney. So, if Dr. Frank maybe is on the other side, would have made a Gibson incision. A Gibson incision around here, right iliac fossa. Okay, we prefer this area. It is spacious. Though we can also put on the right, but the vessels are better on the right. So this would be the normal. We clean this area, remove the muscles, and all that we are interested in is expose the iliac vessels. The right iliac vessels, the internal iliac artery, vein, and in this case, it depends on the expertise of the surgeon. What you want is you can use the iliac artery to connect to the renal, okay? Or you can use the external iliac artery. Okay, it depends. You can use the internal iliac artery or external iliac artery. Any that you want will do the job. Okay, though there are specific points where you may decide to use only the internal iliac, especially if I harvested the stalk of the renal artery. If it is short, then you may need to use the internal iliac artery because it is mobile. The external iliac is a bit fixed. You'll not be able to move it around. And the external iliac vein here exposed. So this is bed preparation. As one team is harvesting the kidney, the other side is preparing this. Okay? So patients have entered at the same time. One team is preparing where the donor is going to be, where the graft is going to be placed, and the other team is preparing the graft. And this is what we've been talking about, how to anastomose, where, what to what. So this is it. This is just a schematic presentation. This is the kidney, and you can connect it here to the external iliac artery. Then the vein, you connect to the external iliac vein. All right? Likewise, B, if you have to look at B, you can connect it here. Or it can as well be here. All right? Directly to the aorta. Or you can use the internal iliac artery. Okay? You connect it direct to the renal artery. It is hard, it is not easy to connect the internal iliac vein. So we basically use the external iliac vein only. Yeah, so now when it comes to placement, the graft has been brought, okay? And now this is the job that we do. And within all this time, we are preserving the the ischemic times, and we anastomose. It's basically anastomosing. Okay, get these vessels to the recipient vessels and connect the ureter to the bladder. But before we connect the ureter to the bladder, we have to first see the urine actually. The moment you connect the artery to the renal artery to the internal iliac or the external iliac artery and the vein as well, we wait for a few minutes, okay, if we see urine. And the moment we see urine, we celebrate in theater. Okay? Because urine is supposed to be spontaneous. If it is late, then it means there are issues. Because you can have failure immediately, especially if the nephrologist has not done a good work. Okay. You can have failure and the kidney fails to form urine. So when we do not see urine, then we look at the nephrologist. Okay. So this is it. This is the way how we anastomose. Now, let me just talk about the key aspects of ischemia in kidney transplant. And this maybe puts to rest the rumors that we hear that kidneys can, that you can steal a kidney and put it in someone. This warm ischemia time, you have less than 30 minutes, okay, to have the job done. Just imagine someone giving me caliform from here, then you take my kidney to India. It is not easy, okay? It's not as easy as it is said in the news, okay? And this warm ischemia time is that time when we clamp, okay? You've clamped. We tell the anesthesiologist that we are going to clamp, all right? In other words, clamp the renal artery and the vein of the donor. That's when we start calculating the warm ischemia time. In other words, the time when these kidney, these cells are not receiving oxygen. So the cold ischemia time starts at that point when we submerge that kidney into ice, all right? And there we have some time, okay? The earlier you do it, the better, okay? So there are several techniques of preserving this function, and this is where we need the nephrologists in theater to work with us. Because if you don't do it well, there is going to be reperfusion injury. The complications are quite many, but in the early phases, you can have bleeding or a hematoma, because remember, we are giving heparin to these patients. We are putting them on anticoagulants, and bleeding is real. Urine can correct around the kidney, we call it a urinoma, or you can have a rejection that can be acute, okay? Immediately you've put the kidney and you do not see urine. And that is the work of the nephrologist. There are these late complications when they come up, still the nephrologists are supposed to inform us, okay, because they are following up these patients. Because of these immunosuppressive drugs that they give, because a kidney can stay for as long as 20 plus years if managed well. If not managed well, for one reason or the other, within a year or two, you may need another kidney. Okay, so it is quite a long journey. So if this patient has received the kidney and has been on immunosuppressive drug for 10 years, you expect that malignancies may set in because of immunosuppression. The contraindications are quite many. These patients who we may not be able to give kidneys, and we have the relative and the absolute ones. Our key points for today is that we should take is teamwork for kidney transplant. It's not a one-man show. Adequate preparation, medical legal aspects are real, and many times actually it is the surgeon that is castigated first, not the nephrologist, because it's you plucked out the kidney. Yet the nephrologist would have done a good job of making sure that actually these are the real people. Because the laws, Dr. Fred, what does it say in case, how many years in prison? And the money in case, how many billions? So poor me, where will I get the 2 billions if please you don't do a good job? And then follow up. Thank you for listening.
Thank you very much. You've turned the the heat to the nephrologist, as should be. If we have any questions, because he's going to be leaving soon, would like the audience on this, only this particular occasion, to ask him a question or two. Dr. Bagasha, you want to stomach everything. You are taking the whole responsibility. Thought you'd have a question. Dr. Rose, you have let the surgeon with an MPH turn everything to you. Yes, please. Do we have another mic? I think we do. I hope it works. Such Toreko, please come and answer a few questions. Thank you very much for taking time to present this.
Professor Kayasubra wanted me to be a nephrologist. Remember I said that the other time.
But I think this is why you are where you are. I treated his dad, you know. I think that's when he had a transplant, yes. You should tell that story sometime.
Yeah.
Please ask the question.
Thank you so much, Dr. Secretary, for your presentation. Mine is more of a concern, not to the urologist team. We have so many patients undergoing dialysis throughout the country. And when you read, one of the recommendations is that the urologist should be able to do AVF, arteriovenous fistulas. There was one camp that was done at Mulago at the beginning of preparation of transplant, and you did not come back again. So I would encourage the urologists to join together with the team and maybe continue with these camps in the transplant theater the other days when you're not doing transplant, so that we can help these patients who are undergoing dialysis and getting a lot of infection burden from dialysis catheters. Thank you.
Thank you very much. That is not a question, it is...
I have a question. Thank you, Dr. Sechitoleko. I'm requesting to know or to be informed how many chances one has to be transplanted. Thank you.
How many chances? But you mean if you've gotten one kidney? Then, no, you can get as many kidneys as possible for as long as no contraindication are set in. You get it? You can get today, though, if it is a failure, the chances of failure actually, another kidney failing are higher. So the nephrologists actually, before they push to us, they'll have to first screen why the other kidney failed. Okay? And the question would be, is that a modifiable risk factor that led to the other kidney failing or not? In case it's not modifiable, then it means the transplant will not go on. That patient will be on dialysis instead.
Thank you so much, Doctor, for the presentation. I have a question. Does a femoral dialysis catheter on the right side in the recipient affect the success of a kidney transplant? Thank you.
Femoral? We do not use the femorals. We use the iliacs. Though, maybe I can try to extrapolate your worries because from the iliacs you go to the femorals. Okay? No, it does not. When for patients where we change from using the external iliac artery, especially for patients that have diabetes, they have atherosclerosis, and that vessel is quite hard, okay, to anastomose the renal artery to the external iliac artery. In case it is quite thick, you know, they can be thick if it is atherosclerosed, and then you'll have to use the internal iliac in that case, okay, but may not be an absolute contraindication why you wouldn't use it.
Dr. Sechitoleko is right. If as a dialysis provider, you are out of options, if you don't use the patient dies, they'll never have a chance at transplant anyway. So if you must save a life, then yes, use it. But if you can explore other vessels, as much as possible, spare the right, moral, and therefore iliac, because the possibility that it was going to stenose and be unsuitable for transplant are high. But if you've run out of options, you can use it. Person will live to have to see another day, or you could use the left. Then also, if one side has been, try to keep on the side which has been used and try to spare the one which has not been used. So as much as possible, have the big picture that this is what we're going to use, but if you must save a life, then use it.
The other thing we need to remember, the other picture I showed you, we have the aorta. Okay, it never fails. In case these peripheral vessels fail, the aorta is there. Okay, we can just put the aorta and the IVC. That's it.
Thank you. I have a question. What is the lifespan? What is the life expectancy of the donor?
Actually, the donors live a better life than any of us. You know why? Because the nephrologists take care of them. Yes, even if it is any small infection, we take care of it. There is a patient who is going to donate a kidney, maybe this month, and had a few lower urinary tract symptoms. But even he had to do TRP as prophylactic, okay, because he's going to give up one kidney and you want the natural kidney to be okay. So the way how these patients are going to take care of their lives, they are going to be so cautious. Even flu, they will come to hospital, and it has not actually affected their life or lifespan. When you read the papers, they are staying longer. They are healthy cautious more than anyone. That's it. Thank you.
Thank you so much, Dr. Sechtoreko, for the presentation and the Q&A. And thank you for also dispelling the myths that are going around, especially the social media. You all saw that slide that he put about the cold and warm ischemic time. Please remember that slide, because this is now advocacy. At one point, there was someone, I can't remember who said they found a container full of kidneys at Malaba going into Kenya. I don't know if you read that story, that they had harvested kidneys from so many people. But now you can see that it's actually impossible to just steal and take. Okay? So thank you so much, Professor Frank and Dr. Sechtoreko, for that. So we are running short of time, so now we are going to go backwards because you've had the surgery. Surgery has been done, but we're supposed to have started with how do we prepare the donor and the recipient. And that talk is going to be given by the new kid on the block, Dr. Louis Nyende. Dr. Louis Nyende is a consultant physician, not yet, but in the making, at Hoima Regional Referral Hospital. And he's going to give us that talk on how to prepare the donor and recipient on the nephrology side, not the surgeon side. You're very welcome, Dr. Louis.
Thank you very much. Thank you very much, Dr. Javi, my OB, all my lecturers, mentors, colleagues. I'm happy to present this session on recipient and donor workup, international and local protocols. I came back in January. There were so many myths that I would present online, but I'm here in person and I'm grateful for that. So the outline, I'll just briefly talk about the benefits of transplant, just a sneak peek on the types of renal transplant, and a brief global picture of renal transplant versus Africa. And then I'll try to talk about the workup for a recipient and a donor. This is just a reminder, during our training, there is this prayer that is in Hutchison's textbook of clinical methods. From inability to let well alone, new and contempt for what is old, treating patients as cases, and making the cure of the disease more grievous than the endurance of the same. There are so many things to a nephrologist and to other doctors once you're treating your patients that you reflect on this. Throughout this talk, there are issues that will be mentioned. That picture is the World Health Organization building blocks, which are 6. And in service delivery for renal care or in renal transplant, all these have to be coordinated. You have good leadership and governance. You have the people. We've mentioned the different peoples, the nurses, the cleaners, the urologists, the nephrologists. And you have the financing. You must have the money. And then service delivery looks at access, affordability, availability, and then the medicines and the technologies. You can be a very good doctor, a good nephrologist, a good urologist, but if you don't have the medicines and you don't have the technologies, you cannot work well. And the link that is coordinating all this are the people that's coordinating all this. There's no area where you'll say, we can use robots or we can use machine in that area. This is just trying to show you the income, the income of different countries. And you see the high income countries are in green, dark green. You have Canada, US, Australia, and some parts in Europe. If you look in Africa, we are considered low income. The only rich countries in Africa are the southern parts, South Africa, around Namibia, Seychelles, Gabon. I was shocked that Gabon is high up there in the income countries, and Cairo. If you look at transplant in the whole world, the area that does most transplant, kidney transplant, are the high income countries. And it's not a surprise because of the resources and the coordination that's needed. Canada, US, Australia. And in Africa, we have South Africa and Cairo that are leading the graph. The other areas are not showing anything, but I'm happy that Uganda very soon will have some color change from nothing to something. A paper that I looked at by the ISN in 2023 looked at the availability of renal transplant services in Africa. And in addition to looking at the dialysis, you want to also look at the adequacy of the dialysis. You're giving dialysis, but is it adequate? They found that about 21 countries are doing dialysis, but the adequacy of the dialysis is just 50%. It's not adequate. And those that are offering peritoneal dialysis are 19. That is even less. And the adequacy of that is just 48%. The PD availability, sorry. And the adequacy is even much less. And countries that are offering kidney transplant, 13, and that's about 33%. We are still at a very small percentage as Africa. This is a very old paper that transplant nephrologists and most of the nephrologists have come across, that was published in 1999, that was talking about the outcomes for patients who are on dialysis versus those that are transplanted. It had about 230,000 participants. And from this paper, we realized that kidney transplant is best treatment for patients with end-stage renal disease. It improves quality of life. You can live up to 10 to 17 years with a transplanted kidney, or even longer. And you're free of dialysis. You don't have to come to the hospital every 3 times a week or 4 times a week. And the best effects for transplant start to be seen maybe 6 months to 1 year later. The first period, the first months, when you compare the patients on dialysis and those on the transplant, the patients on transplant seem to be a bit more sicker than the patients who are on dialysis, and they tend to come more frequent in the hospitals, and they are monitored because it's a very key time in monitoring these patients. Everyone has mentioned that donor and recipient workup has to be rigorous. You have to be thorough to the detail with the recipient and the donor. The surgeon earlier said that if things go wrong, then the nephrologist. The types of transplant, there's deceased donor and there are living donors. You can have related or unrelated. Right now, Uganda did living donation, whereas in developed countries and other countries, you're able to have deceased donor donation. And for deceased donor, they wait for cardiac death or neurological death. And in some of those countries, as long as you enter those countries, they give you a leaflet that encourages you to be an organ donor. So you write a form, you write your address, and you say, in event that I pass on, some of my kidneys, some of my corneas, some of maybe the pancreas can be given out or donated. So there's an active drive in the developed countries to encourage people to do kidney donation. So looking at some recent developments, comparing living donor, there are some potential benefits and risks that have been mentioned by the previous speakers, and there are risks to the donor as well, like some morbidity and mortality, renal dysfunction in the long term, and then financial penalties from loss of time for the donor. So how do we select? I'll walk you through how we were choosing recipients and assessing donors where I trained from. So patients have a waiting list. There's a waiting list that is put out, but before you access that waiting list, you have to be assessed by your nephrologists. In the developed countries, you have general nephrologists, you have specialist nephrologists, and then you have the transplant nephrologists, and all have their specific clinics. So once the nephrologist identifies or sees this patient and says, you know, you're a good candidate for kidney transplantation, they refer them to the transplant clinic. And some of these patients may have end-stage renal disease, they're on dialysis, and some are not on dialysis. And in that event, if we do a transplant for someone who's not on dialysis, we call it preemptive transplant, and we usually want that transplant because it has the best outcome. And usually the patients are attending a multi-clinic kidney care clinic, and once they reach like stage 4, stage 5, the workup starts happening or referral for transplantation. Blood group, very key, because it affects your listing on the list. The duration you've been on dialysis is also important. It will give you add you points, and also certain blood groups. For example, if you're B, it is you will delay for the waiting list. And then they assess availability of your social support. For example, do you stay alone? Where do you stay? And who supports you? Who does your activities of daily, who supports you with the activities of daily living? Are you able to exercise? Are you able to go on a staircase or move up and down? And sometimes the patients may be asked to shift. For example, if a patient stays in Tororo and the transplantation is going to be in Kampala, they will be asked to first come and shift and be within Kampala, so that during that time of maybe 6 months to 12 months, they are assessed and they are coming for their appointments. For patients, in the developed countries, you have family doctors that take care of the patients. And once the kidney function of those patients deteriorates, there is a calculation that they do. It is called the kidney failure risk equation. And you're able to calculate it using your phone. If you have the Medscape app on your phone, you can put in some values and you calculate. And this will help you predict the need for the patient needing dialysis in 2 years or in 5 years. And once the risk goes to about more than 5%, then the family doctors will refer to the nephrologists. And when the patients are in the clinic, they are taught about, they are given modality education about hemodialysis, peritoneal dialysis, and they also refer to the vascular team to do vascular access. So that is the KFRE. You can access it on Medscape. In the transplant clinic, we take a thorough history of the recipient. We do physical exam, we do investigation, and then we put the patient on the waiting list. We note the referring nephrologist because in event that the patient eventually, after they've been transplanted, they need to be monitored, just as the surgeon has said. They follow up the medication and all that. And once they go back on dialysis, then we refer them to the nephrologists. The cause of chronic kidney disease is mentioned. They get the biodata and then the medication history. I use the acronym ABCDFGH to stand for something. A for anemia, B for blood pressure, calcium, vitamin D, erythropoietin, ferrous, glucose, hyperphosphatemia. It's very simple to remember for those who are the postgraduates who want to manage chronic kidney disease. And they also ascertain if you've had blood transfusions and you've had pregnancies, because once you have sensitization, it means even the medication we are going to give this patient will have to be adjusted because of the sensitization. And whether they are on dialysis or not, duration of dialysis, and any ongoing active issues. You assess the family social support, assessment for exercise, and relevant labs that were sent from the nephrologist. And you educate the patient about the benefits and risks of renal transplant, walking the patient through the journey from start, what it will be like in surgery, after, and what to expect. And they will only skip the queue if they're able to have a living donor. You do the exam, you do a thorough exam because you want to make sure this patient is healthy. And then the investigations that you want to do, the blood grouping, the complete blood counts, the electrolytes and the extended lights, HLA typing, very important. CPRA is cumulative plasma region antibody. Usually for this, for example, in an area like Kampala, they would know that if there are organs that are donated in that particular region, they will know that if someone comes out on the waiting list and they have a certain score, that if they are given that particular kidney, it will not fail. So they are able to determine that. And then infectious screen, hepatitis, HIV, CMV, tuberculosis, and then malignancy workup, colon cancer, cervical cancer screen, breast cancer screen, because when you start the patients on immune suppression, some of these may manifest and or may become worse. So it's important that you do a thorough assessment. And for the heart, you do the ECG, the echo, the stress test, and it's important that the cardiologist evaluates the patient. And you do imaging of the abdomen with note of the iliac vessels that the surgeon mentioned about, and then you give an appointment for the patient to return to the pre-transplant clinic. The referrals that are made during this time, you make sure the patient sees a cardiologist and also sees a urologist for cystoscopy and also writing a clearance for the patient to undergo transplant. The oncologist, for example, if they have some active malignancies, they may need a clearance letter from the oncologist to say that much as this patient has a malignancy, maybe wait for 5 years, or there will not be a risk to this patient. And then as the patient is nearing surgery, the anesthesiologist will assess them as well. Some reasons for deferring transplant have been mentioned: severe disease, active infection, active malignancy. And if you're to look at the donor workup, they are trying to minimize the time the donor comes because the workup is extensive. So if you want them to be able to donate, you want to save and minimize their time. So you take a detailed history just for the recipient, and you do a head-to-foot examination, and you discuss the long-term risks for kidney donors, including the small risk from surgery, the development of end-stage renal disease later on, increased cardiovascular risk, especially some of these patients may get hypertension. So you have to monitor them. And then the investigations for this patient, you screen for cancers as well. You do a CT scan from head to toe to assess and see if there are any abnormal findings. I remember a healthy man who came for donation. He wanted to donate to a cousin sister. He was very healthy. We did a CT scan on him, and we found that he had pancreatic cancer with metastases even to other organs, right? Just from coming for wanting to donate. Nuclear medicine is important. They want to calculate the GFR for each kidney, so that if they are to remove the kidney, they want the donor to remain with the best kidney. Okay? Then you give feedback to the donor. You allow them to ask questions, sign forms, and advise on health living, and they wait for a call. Pre-op assessment. Usually once they're on the waiting list, they are told to fast, and once they're admitted, you take again a detailed history. You repeat what you are doing in the pre-assessment, and you want to make sure this patient has not got blood transfusions, has not have active infections, and if they have obstructive sleep apnea, you ask them whether they are on a machine. Of course here, some patients, I don't know if we have CPAP machines, but it is important for the anesthesiologists to know when they are going to give general anesthesia. If this patient is going to recover from surgery, they will need to be on their machine. And then the medications I will not talk about, but there are side effects of the medications and the type you are to give depending on the sensitization and also the other factors, the age of the patient, and also if they've had previous transplants. Most likely, they are very exposed. You'd want to give them good immune suppression. The scan has been mentioned by other previous speakers, and once they are discharged, they are seen every week until when they are stable, including labs. After 1 year, they do bone mineral density. They look out for new onset diabetes after transplant, and they continue screening for infections, CMV, EBV, and the likes. The donor has been mentioned previously by previous speakers, and you check for other things like mismatches, clearance letters, until when you do the transplant. For the local experience, I think we've already had some presentations from Dr. Tuhe. I will not dwell on that, but we need a multidisciplinary team, and we should be able to do some basic initial evaluation, the blood group, the infectious screen workup, the imaging, and look at some of the challenges with the World Health Organization building blocks that I shared. And then we have a high burden of infectious disease. So we have to talk to the patient and advise them that you have to, in case you get anything, any flu, fever, please come to hospital. Thank you very much. Appreciation to all the people who have supported me through this journey. And may God bless you.
Thank you, Dr. Lewis. I think we shall have his Q&A at the end. And please drink water. There is probably just a small addition to his presentation. The donors, we also usually want to do a psychiatric assessment. So that I know some of my colleagues have been in court because they have been taken to court because of, I think you've heard these stories in the media, that the doctor forced me or they ate my money and all that. So a psychiatric assessment is also very important for the donor. And many times, especially for our patients, whatever we do that Dr. Lewis has mentioned is repeated at the transplant center if we refer. But now that we have capacity, now we can do everything here. So without wasting time, I know we are running short of time. I would love to call the next speaker, who is our president. I may not go through his entire bio, but please allow me, Mr. President, to call you Mr. President today. So, Mr. President, Dr. Joseph Ogavo is going to talk to us about the new drugs, the SGLT2 inhibitors. I think we'll also have a similar talk tomorrow, but from the cardiology side. This is going to be from the nephrology side. You're very welcome, Mr. President.
Thank you very much, Dr. Javila, my teacher and my mentor. Ladies and gentlemen, protocol observed. Good afternoon. So I came out of school in 2008, and clearly there was nothing like this. Now you don't go to a conference where they don't go to a conference and they don't talk about it. Perhaps the surgeons may even find some role for this drug. Yes, I told you how I didn't know that it would help in malaria until Bate proved so in recovery. So it can probably do anything. Yes, so I'm here to present on Dapagliflozin, which is quite a common molecule of late in chronic kidney disease. This pharma has been prepared and sponsored by Mega Life Sciences. I have a big disclosure to make that I will receive honorarium. I will receive from Mega for presenting this content, much of which is prepared by them. So this is what you shall look at, and since the drug that we know, I will really not take so long. But just to drum home the figures that are now commonplace for us, that you have over 500 million people that are living with diabetes. Painfully, many of them do not know that they are living with it, and some are managing it, but not to target, and they are a CKD case or dialysis case waiting. And you can see that the numbers are growing. As early as 2045, there will be about 783 million people living with diabetes. So 1 in 2, or about 44% of those remain undiagnosed, and that's a very big number. No wonder we must screen. And more than 3 in 4 of people with diabetes live in low and middle income countries where there's no health insurance, they are not screening, they earn money that only buys 1 or 2 doses of erythropoietin. Yeah, so it becomes a very big problem. And diabetes on its own causes about 6.7 million deaths as of now. So it's quite a big problem that we must appreciate. We are fairly well represented on the global map for diabetes. 1 in 22 adults have diabetes. And that's a very, very big figure. And our numbers are growing faster than in any other population. And you know, we always say lifestyle, lifestyle. Sadly, as we have drummed it many times, some of these patients do not have diabetes and hypertension. They are not obese. They are not anything that you know. It is something that we need to study. No wonder people like Grace and Dr. Muhindo are doing work on this to have African answers to our own problems. And 1 in 8 live births are affected by hyperglycemia. And that's quite a big value, and these are people that need to be followed up. So in Uganda, about 3.6% prevalence of diabetes, and that's a very big one, a total of about 716,000. What is surprising, if you total up all the people that are being seen in the clinics, they don't add up to this number. Some are going somewhere, and overnight, or drinking some soil, some water from a sacred place, or taking hibiscus, and many other things. Please take more of it. I know that it helps. So many are not diagnosed, okay? So this is something that we want every doctor to know about. So you get patients come to you and they were told that my doctor told me that the creatinine is still okay. But you see the figure is 2 point something or 200 something. So that creatinine is useless until you convert it into a GFR, okay? And you can even make things better by grading the severity basing on the urine albumin creatinine ratio, because it is an indicator of how much fire is going on at the glomerulus. So it tells you that manage your pressure and sugar and what have you better. All right, so diabetic kidney disease, which is very much an entity of its own, but you can't conclude from it with the patients that you see. So it would become a diagnosis of exclusion because you're not going to biopsy all your patients. But it is a long-term complication of diabetes, and globally it is the leading cause of CKD, and people in the dialysis centers will tell you how many of their patients actually have diabetes as one of their comorbidities. And it develops nearly in half of the patients that have type 2 diabetes. Lucky enough, not all of them get into end stage, but that small number of 5 or 10% that do bear the brunt of the disease. And about a third of those with type 1 develop kidney disease. And the numbers are probably better in type 1 because a good number of them don't live to see many years. Whereas type 2 diabetes, they may live longer. About 20% of adults with type 2 would develop a GFR below 60, and about close to 50% will have albuminuria, which, as we've said, is an indication of damage that is continuously happening at the glomerulus. So in Uganda, we have a lot of kidney disease, and research done by many of us here has shown that. So this slide just tells you that we are not spared, and we always have to look out for it. So the commissioner was saying he's not seeing the data, and I was telling him because it's not being asked for. And one of the things we are going to push for, you know what they asked for? How many children had diarrhea? Sorry, the PIDS. It's a very important topic. Yeah, but I think they asked for 5 things: malaria, something, maternal mortality. Very important, please, very, very important. But there's nothing like CKD, albuminuria, and so on. So they are not getting that information, and that's a big challenge that we are having, and we want to push them to include that in the HMIs. Like I emphasized, albuminuria is very important. In fact, you have to grade. You have to tell us what has caused this kidney disease, okay, to the best of your ability. The problem is if you're in a center hidden somewhere, the best of your ability might be there's no brucella, so I think someone is bewitching you. Okay? But you must push as much as possible. Tell us what has caused it, how much of this damage has happened, so you grade, give us the grades, and also be careful to find out whether they are leaking protein. And it's just a surrogate marker of how much injury is happening to the glomerulus, no matter what is causing it, whether it is heart failure, diabetes, or hypertension, anything, lupus. If it's actively hitting the glomerulus, you will leak more protein than normal. Now, there are many causes of diabetes, rather of kidney disease, diabetes being one of them, but your patient is not spared the other risk factors. So when patients come to you and they're diabetic, okay, don't just say this is diabetic kidney disease. The man might just be there sitting on a prostate that is big, and they don't usually want to report until you ask the wife, and the woman will open up. I've always been telling you, you keep waking up. Some woman told me the man, she has to empty. The man cannot go to the bathroom, so she has to keep emptying a bucket of urine every time he's passing at night. And he has never reported it because he fears people will touch the engine and his life might change. So your patients are not immune from all these things: high blood pressure, heart problems, obesity, family history, tobacco use. And when all these combine, then the chances of your patient having CKD are actually raised. So you need to always look out for those. Now, diagnosis of CKD, those that work with me, I don't know if someone has an answer, but the best way you can diagnose CKD is the time, because they tell you the duration is, yes. So you get in and the whole team, the clinical team is asking you, is this acute or chronic? And the patient wants to know whether they are going to get okay or not, and you're on gun point. Yeah? So it's very difficult for you to actually make that diagnosis with one contact. Time is the best, but perhaps some of these things can give you indicators of where the patient may be, but it's not cast in stone. So if someone has had this for a long time, one reading and another, and the GFR is below 60, then you can be sure that they are CKD. But still, you're obliged to find out what else is happening. And remember, every acute or CKD patient that comes to you, Dr. Javira told me, make sure you do an abdominal ultrasound. Yes, so that you rule out structural. You might be there struggling when all that you need is to pass a catheter and your patient gets okay, or send them to proper way and they get rid of the prostate and life gets back to normal. So this imaging is there to support you. The management of diabetes, as we know, is not just drugs, and it actually helps. There are patients that actually come and they can't be managed without drugs. It's the best thing, everyone wishes for it. They put us on pressure for it. We don't deliver on it. We are not obliged, but some of your patients will be able to get away without drugs through appropriate lifestyle modifications. Nonetheless, you need to set good goals and do dietary and exercise modifications. I always tell a story of a lady who came to me. She had proteinuria, about 300. She had an HbA1c of about 7.1. She was nicely endowed. She lived in a storied building. She had a maid for the upper floor and the one for the lower one, because she couldn't clean under the table and what. So she came and we agreed to put her on diet. Sorry, the maids lost their jobs. She went back to her wardrobe and was able to put back her old clothes. HbA1 settled, proteinuria settled, pressure is good. So for some people, that is all that you need. Medications, appropriate self-monitoring, which is key. You've had, I was running a clinic somewhere and someone just had index random blood sugar for diagnosis. For 2 years, they are swallowing metformin and glibenclamide. So monitoring is very key. And your patients might tell you that they cannot afford. It is your duty to convince them that they either afford this or afford dialysis. Sometimes they have to be very, very blunt. Regular monitoring for complications as well as assessment is key. Now, over time, we always aimed at chasing the glucose. Bring it down, and most of the drugs were aimed at insulin, reduce resistance, squeeze, basically put a pump on the pancreas so that it squeezes out the insulin more. Most of the drugs were working that way, coming with risks, weight, beta cell fatigue, GI side effects, and risks of hypoglycemia. When people like me were coming out of medical school, those are the options that we had. It's only along the way that we had some other molecules coming in, some of which include the now popular SGLT2Is, whose actions are not only aimed at lowering glucose. GLA is glucose lowering agents, but also improving other outcomes that we know now are very important. Cardiovascular outcomes and renal outcomes are very important. So, and that's where these drugs are coming in. So, as we know, it's the SGLT2 sodium glucose co-transporter 2 molecule is a protein that's responsible for reabsorbing sugar back into the body from urine. And blocking this protein will prevent the kidney from reabsorbing glucose from that urine, and so it causes the glucose to be removed as urine. And that will reduce the total glucose in the blood. And by so doing, these molecules block the action of that molecule. So when they were introduced, they came mainly for obesity until they were found to actually have some other benefits, as we are saying. And their action is independent of beta cell function, as well as insulin resistance, and they contribute to the reduction of HbA1c with a reduced risk of hypoglycemia, even when they are causing the loss of glucose in the urine. Yes. And so they lose calories, and with that comes other benefits like weight loss. They are fairly well tolerated in the GI. So, like we said, care for these patients is comprehensive, and do your best to always make sure that you're not giving these patients drugs only, but discuss other things like diet, physical activity, stopping other risk factors that are going on. I am personally in favor of someone living a good life even when they're having diabetes. I tell them you have a lifetime to monitor yourself, and you will know even within a week or two. So I tell them, you know what, just don't have mululu, don't be gluttonous. Take something, whatever you want, monitor your sugar, you come and tell me which food is good for you, then we can discuss the other things. I'm against patients being prepared different meals with no salt, no curry powder. People are locked up at homes. I spent, I think, some 2 hours, patient crying for me. Someone measures how much rice, it should be exactly white, nothing brown. Oh, yeah, so we should look at our patients holistically. It helps, and we know why lipid lowering is very important, and we know why we even give statins in diabetics, even when they may not have elevated lipids. So SGLT2 inhibitors are known to reduce the risk of the decline of GFR and ending up in end-stage kidney disease, while also reducing cardiovascular deaths as well as hospitalization. This is something that we all know. It's been sung over and over again. It's a drug that has gained confidence of many of the clinicians, and we've seen this in our practice. So this is just to show you the renal protection and the cardio protection that actually happen, and you want your patients to benefit from this. But just know that every time you lose glucose and reduce hyperfiltration and reduce albuminuria and increase some delivery of oxygen to the kidneys while reducing the inflammation, you're giving those people a better chance to avoid getting into end stage. This is very much a repetition of what I was saying. So one key thing that you always want to monitor is albumin, because like I said, it shows you just how much of the fight is going on. And it's becoming commonplace in many facilities. Get used to asking for it, and always grade where your patient is. When your patient has minimal albuminuria, they'll have better vessels, they'll have a better heart, their eyes will be saved better. It's basically good that that does not happen. All right, I think this is very much a repetition, but the benefits for the kidney are as follows. Because they are losing water along the sugar, so their volume goes down. That might help you to manage your blood pressures better. There's a reduction in uric acid, which, as we know, has been shown to contribute to an inflammatory state, and that inflammation is what makes the vessels very bad for Prof. And he may find it very difficult to transplant the patient. Leaving the transplant alone, the heart, the brain, and the eyes are all supplied by blood vessels. A reduction in proteinuria, as I've emphasized, and stabilizing the GFR is key. In addition to losing salt, which is definitely very good for you to manage your blood pressures. There's a genuine risk of UTIs in these patients, and so you should always look out for bacteriuria in them, and even pyuria. And you should not allow your patient to suffer more than 2-3 of these episodes, because what could happen, they may get a bad UTI that turns out into a pyelonephritis that would actually take them before. But your goal is to screen these patients and see those that are at risk. Who is more at risk? If they have been having more recent UTIs, persisting pyuria, or they have obstructive problems. So someone with a prostate having stasis is at higher risk of getting the UTIs. And so you must screen these patients very well and make sure that does not happen. But also, don't just switch off SGLT2s because you've seen pus in the urine go through the same. That person might have a tumor, they might be having TB, and they're just having septic pyuria, and you're seeing pus cells, and you're saying this is a UTI. It helps to do a culture and see what antibiotic they respond to, and only if they don't respond or it keeps recurring, will you choose to take them off. There's also a risk of dehydration, as we've seen, and so you must warn your patient and objectively assess for dehydration every time that the patient visits you. So the pros are about 2 to 4-fold increase, and you want to look out for that. The same happens with candidiasis, which can be very discomforting for your ladies. And so if you give them SGLT2Is, then you must discuss things like hygiene so that they can see how to minimize that risk. I think the evidence is, I would say, convincing at this stage for us to use this molecule, as it's been shown to reduce end stage. It's definitely better than placebo, but also there's been evidence of a reduction in cardiovascular deaths as well as mortality, probably arising from the combined benefits as we have seen. And so, in patients that have kidney disease, with and without diabetes, Dapagliflozin reduces the risk of kidney failure and also reduces cardiovascular deaths or heart failure hospitalizations and results in prolonged survival. These graphs, we've been used to them so many times. A reduction in GFR, creatinine not rising, as well as the HbA1c. A few comparisons I wanted to show you between, it seemed not to find it. But compared to molecules like, I think it took me a lot of time finding that one. But compared it to molecules like Dapagliflozin, it still does fairly well, especially regarding the reduction in the GFR, as well as preventing end-stage kidney disease. So it is something that you must get used to. So perhaps differing from how things looked like when I was finishing school to now, I had to write, for the obese person, I would write metformin. Then for the small one, I would write glibenclamide. And now I'm here telling you that glibenclamide, when it crosses this level and so on, please avoid as much as possible. So we are having this coming in, and now we are stratifying how is the heart failure risk, how is cardiovascular risk for this patient, where do they lie in CKD, and then you choose a drug very well, and then you see SGLT2Is coming in. The worry is the stage of CKD, not to initiate below 25, okay, and then continue until dialysis. When you discuss with the cardiologist, they may want to keep that drug on because your patient has lost a kidney, but they have a heart. So don't be selfish. Continue serving the heart as well. That's a debate that keeps going on. The dose is quite common to us, 10 milligrams. In some cases, you may be forced to reduce it to 5 milligrams. Contraindicated in dialysis, Prof. and Dr. Javil and Dr. Sekasav may give you the recommendations about when to not use it. Like I mentioned, please, even after we've eaten food and I've received my envelope for talking about Dapagliflozin, always remember that your patient is not just a sugar reading, okay? Yes, they come from a home, they live with a family, always think about them. And when you're managing them, think about them holistically, discuss their diet and their lifestyle, ask them what they can do. Don't just tell them, be active. Will they like Myotrenzol or Sosrenaria or which one? So for some, getting from bed to the gate is good enough, and they'll come and rejoice. Doctor was able to walk, okay? So look at them holistically. The first line is increasingly including SGLT2Is, especially when you have stratified your patient very well, and always work to target. I think I should thank you at this point. Thank you.
Thank you so much, Dr. Ogavu, our president, for reminding some of us about this molecule. But probably just one take-home message for the young doctors. This is a very good drug, very good molecule, like you've seen, heart, kidney, diabetes, and probably many more things. But please be cautious when you're using it, especially when the patient is also on a diuretic. He described to you that it's a diuretic on its own. And us nephrologists love diuretics because we love to see urine. So be cautious because you might actually send the person into AKI on top of the CKD. But having said that, because we are running short of time, I'm suggesting we have 3 more talks. And there was actually a talk, then we have a tea break, then we have 2 last talks. But I think, so we have 3 talks, and what we will do is to run through those 3 talks, then we go for the tea break. Agreed? Okay. So one of our sponsors is Mega Life Sciences, and they've always been there for us. And they're always with us. So I want to welcome Mega Life Sciences. First of all, thank you so much for supporting the Uganda Kidney Foundation. Thank you for supporting the individual nephrologists and many other doctors, and for the work you do. So we want to hand over this other session to you.
Thank you, Dr. Javira. Thank you, Dr. Ogavu. We really appreciate your time and efforts for enlightening us for the role of SGLT2 inhibitors for the management of chronic kidney disease. Good afternoon, all. Che Chiriya. My name is Vivek Chandra. I am the country manager for Mega Life Sciences Uganda. Just to brief you about Mega Life Sciences, Mega is present in Uganda for last more than 20 years. The company is known for products like Natbi, Ligaba, Meditrol, Leske, Limzer, and many more. We have been partners to the to the Uganda Kidney Foundation for last 7 years. And I hope this partnership continues for many more years further. Today, on the occasion of World Kidney Day, the theme for the year 2025 is the early detection and the early prevention of kidney disease. And you all will agree, as we have been discussing since morning, that the major cause of kidney disease is uncontrolled diabetes, uncontrolled blood sugar levels, or hypertension. So related to this cause, we from Mega Life Sciences, we decided to bring a novel insulin-independent approach to lower down the blood glucose levels. So we decided to bring Dapagliflozin with a brand name Dapagliflozin in the Ugandan market. Today we introduce to you Dapagliflozin 10 mg. That is a brand of Dapagliflozin 10 milligram. And we also have Dapagliflozin M, which is an entry-coated tablet containing Dapagliflozin 10 mg and metformin 1000 mg in extended release tablets. But before I move forward, Dr. Javira, drink more water. Dapagliflozin is an adjunct to the diet and exercise to improve the glycemic controls in type 2 diabetes. In patients with type 2 diabetes, either with established cardiovascular disease or with multiple cardiovascular risk factors, Dapagliflozin is known to reduce the cardiovascular risk and the risk of hospitalization, as well as in the patients with heart failure with classification of class 2 or to class 4. It is known that Dapagliflozin, it reduces the risk of cardiovascular death. Similarly, in chronic kidney disease, as well as the end-stage kidney disease, Dapagliflozin has shown its renal benefits also. Going to the dosage and administration of Dapagliflozin or Dapagliflozin, for the initiation dose in the treatment of diabetes, type 2 diabetes, the recommended starting dose is 5 milligram. With the additional HbA1c control, it can be extended to 10 milligram also. Similarly, for the patients with CKD at the risk of progression, the recommended dose is 10 milligram. And in the patients with heart failure, to reduce the risk of CV death and hospitalization, again the dose is 10 milligram. And the patients with type 2 diabetes, either with multiple cardiovascular risk factors or established cardiovascular disease, again the recommended dose is 10 milligram once a day. As Dr. Ogavu rightly pointed out, the drug is not recommended for dialysis patients, and it is also not recommended to initiate the therapy for patients who have GFR less than 25. Though the initiation is not recommended for patients with less than the GFR less than 25, however, patients who are already on the drug may continue 10 mg orally once daily to reduce the risk of eGFR decline. For renal impairment, Dapagliflozin for glycemic control without established CV disease or CV risk factors, it is not recommended if the GFR level is less than 45. And for mild to moderate or severe hepatic impairment, no dosage adjustment is required. We all know that Dapagliflozin is an SGLT2 inhibitor, and that lowers the plasma glucose levels in patients with type 2 diabetes by inhibiting the renal glucose reabsorption. Thus, it increases the glucose excretion. So what is the advantage of Dapagliflozin? First of all, Dapagliflozin or Dapagliflozin is a once daily regimen. Thus, it offers compliance to your patients. Dapagliflozin can also be used as a monotherapy or in combination with other hypoglycemic agents and with insulin, and its role is independent of insulin action. It is known that dapagliflozin helps in the reduction of weight as well as in the reduction of blood pressure. So it has cardioprotective as well as renoprotective properties. Though it comes with a limitation, it is associated with a significant increase in renal and genital tract infections. So what can be an ideal patient profile for the patient for dapagliflozin? Patients who are not achieving their targeted HbA1c levels. The overweight and obese patients can be given dapagliflozin. The CVD and CKD patients with GFR more than 45 can be easily given dapagliflozin. And the patients who are on the high risk of hypoglycemia due to insulin or due to the usage of sulfonylureas are the patients to whom you can easily give dapagliflozin. So in the recent trial reports, we have seen that dapagliflozin is a promising therapeutic option for the management of a broad patient population. Especially, it has shown that it helps in diabetes prevention. It has a very favorable tolerability profile. Even for the heart disease patients, it is cardioprotective. So it has cardiorenal outcome benefits. Similarly, for CKD and stage kidney disease, and to stabilize the GFR levels, again, dapagliflozin or dapiflozin shows renal protection. So dapagliflozin or dapiflozin for us, the brand name is called dapiflozin, is an anti-hyperglycemic, it's cardioprotective as well as renoprotective. Our brand Dapagliflozin is available at all the major retail counters of the country. It's available as Dapagliflozin 10 milligram in a pack of 3x10. Moreover, we also have Dapagliflozin M tablets. That's a combination of Dapagliflozin 10 milligram and metformin 1000 milligram extended release tablets. I request the Uganda Kidney Foundation, we have been partners for long. This is a newborn baby in the kitty of Mega Life Sciences. We sincerely request your valuable support for those patients who really require dapagliflozin. Please consider dapagliflozin. We will be highly obliged. Thank you all. We bale neo, we bale munonga, ya lama noi, apoyo matek, whatever is applicable. Thank you. I hand over to Varun for a briefing.
Thank you very much, sir. Very, very good evening. I don't have any presentation. I just would like to say thank you very much to all of you. I have only one request, the way you people supported us in Maxcal, Meritrol, Leske, Natp. Okay, same way we need your blessings for this newborn baby as well. Just born in month of January and today is official birthday. Okay, so we just need your support for Dapagliflozin 10 or M10. Both is available. With this, thank you very much. Thank you.
Drink more water.
Sorry for that lapse. Our next speaker. Our next speaker is Dr. Chaze. Dr. Peter Chaze Andrew is a budding nephrologist. We are trying to catch him early, like we caught all the rest. They can see me, we catch them like this. I know some of them are running away, but we are always competing with cardiology, neurology, in a competition, and HIV. But of course, we always catch at least 80%. I know Reagan wants to go away, but he still has time to reconsider to come to nephrology. So Dr. Chaze is a very brilliant young man. He actually supports us a lot in the field of nephrology, and we are very happy today that he's going to be representing the SHOs. And of course, we know that the Uganda Kidney Foundation was born out of the spirit of unity. I don't know whether they talked about it, but it was actually founded largely by SHOs, and part of the founders we are medical students. So we are very good at nurturing young individuals to come and grow our capacity. So Dr. Chaze is going to tell us about his experiences from the World Congress of Nephrology. Of course, again, this was courtesy of our sponsor, Mega, who made it possible to include young scientists. So Mega Life Sciences, we are very, very proud of you for walking this journey with us. Dr. Chaze.
Thank you very much, Prof. Today I'm the guy who gives Lugambo, no science. And yeah, I'm happy for this opportunity to share my experiences at the WCN 2025. And I would just like to tell you about the WCN. I'm not sure that all of us in the room know what the WCN is. And it's just a biannual scientific education and networking global meeting. So this is, in terms of nephrology, this is the highest level in terms of networking that you can go to. And it was hosted in New Delhi this year from 6th to 9th Feb. There were over 250 kidney experts speaking at this event, more than 100 scientific sessions and presentations, more than 1,000 posters that were presented. There were about 4,000 people that attended, and more than 130 countries represented. And of course, Uganda was among all these. We had experts, we had attendees, and of course, we were among the countries that were represented. Like every global stage, you know, a young man like me goes with objectives. You don't just go to look at the malls, foire, you know. So I went with a few objectives, and my objectives were simple. I really wanted to know this field that you want to join, where are we going? So what are the advances? Where are people going in terms of nephrology? And that would help me to keep up with the future, because like Professor said, you know, people like us are the future of nephrology. So we need to pull some of these things that people are thinking about or are starting to do and bring them home. So that way, by knowing these things, I would pick up lessons for Uganda. And of course, like every global event, you need to make connections, you need to network, and at an event where more than 130 countries are represented, it's a perfect opportunity to create a borderless network of kidney specialists. So there were 4 themes this year, and the first theme was about better kidney health. So we were talking about prevention, both at a population level, but also in the clinic. There was a lot of policy and advocacy. There was the interconnected kidney, so we all know how it's now very big to know that the kidney is just not seated in the body alone. So we have this connection with the heart and with so many other organs. So there was the cardiorenal syndrome, CKM, and so many others. The kidney losing function, which was probably the most applicable thing for us in Uganda. So we covered things like dialysis, how to increase dialysis access, how to improve dialysis experience for our patients, and how to manage complications among dialysis patients. And of course, there was a theme that was so catchy for people like me, you know, and Dan, the smart kidney, the future. Things like artificial intelligence, precision medicine, and this was really, really a catchy theme, I must say. And I'll just go to summarize what I picked, because I attended at least a few of the presentations from all the themes. So innovations in nephrology is one. I will speak, and these are really mine, personal. And I think the bridge or the gap that AI is able to bridge for us in nephrology is still immense. Things like risk prediction for patients who we diagnose with kidney disease, improving patient outcomes, but also even in the management of kidney disease. There are advancements in transplantation. I know we are still at the level of allotransplantation, but I must say that the world has moved and people are now looking at xenotransplantation. So I think also as we draft our policy and guidelines for transplantation, it's probably not too early to include and think about things like xenotransplantation, because they will come here one day. Kidney care in low resource settings. So equitable access. So of course there's still a global drive to make sure that kidney care is accessible globally. And in the conference, the major stress was how to make the care tailored for low resource settings. So we know not every patient of ours is able to afford, the hemodialysis. So there was a push to things like peritoneal dialysis and how can it be done in low resource settings using locally available materials. And of course, community engagement. For this one, I must say that the story of access, which is something born from Dr. Kalyesubula's innovation, how access is helping to screen and combat NCDs at a community level was something that was also highlighted. And the model story was really the access story. Preventive care and policy development. So, we've talked the whole day that the focus has now shifted from just trying to have dialysis accessible to everyone, but rather to try to identify even before the patients need dialysis. So at this event, among others, was the point of care diagnosis. So people out there have developed and studied and validated point of care diagnostics for CKD. Within maybe 2 minutes, was it a minute? Maybe a minute, I knew my creatinine, I knew my GFR, So, and I think this is where we need to move to if we want to cover that gap of the 90% that do not know. And of course, global collaboration. It was stressed over and over. You really cannot build kidney care alone. We can't do it as Uganda. We need to collaborate with other countries, both for capacity building, for training. The story of the transplantation is probably the perfect model to teach you how far collaboration can take us. But also we need to collaborate in areas like research. So I'll go to my personal experiences, away from the science. Like I said, I went with objectives. So some of my most memorable experiences were meeting global and regional leaders in nephrology. I think this is an experience you cannot pay any amount, to have. And I was so privileged to meet, these very distinguished nephrologists from all over the world. And of course, not so many things beat seeing your mentors on a world stage. Here you see Dr. Bagasha presenting, on the far right you see Professor Kalyesubula. Those are things that really inspire you when you see, and I must say it was really a memorable thing for me. And of course, seeing our own African stories also on a global stage shows you that things we do here do not only remain here, and one day we shall be counted. Of course, there were some personal experiences, and I just got reminded of one by Dr. Kazime that's not on the slide. But, you know, the downtown Delhi experience, you know, you think you've been downtown Kampala until you go downtown Delhi. You know, the shopping experience was also so immense. I think we left with some sort of addiction to shopping. And the jokes. Who knew that Professor Kalyesubla was one of the funniest people? I mean, who knew that Dr. Sekasambu was one of the funniest people you could ever meet? Storytellers, 101. And of course, the food. Probably the only person that will say the food was great, but I must say it was great. And all the water on the table was not really to protect our kidneys, but to probably reduce the spices in the mouth. And there were some insights for me as well on a very personal level. And I think if there was any pinch of doubt about nephrology, I think the future is bright. I think the science has grown or is growing. You know, they highlighted that KDIGO 2024 was the most evidence-based guideline of CKD, which really highlighted the fact that the science has grown and continues to grow. Another key insight for me was that, you know, when we were probably in undergraduate, we wanted to be nephrologists, but I think it's not enough anymore. Super specialization in nephrology, I think, is inevitable. We need transplant nephrologists, we need interventional nephrologists, we need onco-nephrologists, you know, we need cardiovascular nephrologists. So it's the future and it's inevitable. And of course, the bench to clinic aspect that I think the people in HIV have really done very nicely. The computer science, the AI, and how we can use that in our everyday, patient care. It's the future, and the earlier we embrace it, the more we fit into the global picture. And I kept thinking, are we really ready for xenotransplantation? I mean, we have people who have farms of, pigs, and I kept thinking, if these guys are doing it, how will it be when it comes here? And of course, this was a building stone for me, able to meet potential mentors for nephrology fellowships, listening and meeting past ISN fellows, knowing how training in nephrology changed their life, and also thinking about the strategic direction for nephrology in Uganda, the super specialization I talked about. I mean, people are now have moved to begging surgeons to do AV fistulas, and nephrologists are doing endovascular fistula themselves. So I think we need to really find a way of going towards that direction. And of course, there were quite a number of talks on how to set up what seems like complex systems in low resource settings. So sometimes when we think about things like interventional nephrology, you say, oh, where are you going to get the gadgets? And there was a very good success story on how one of the centers in India started it with very minimal resources. And of course, this is not coming out nicely, but I had some lessons for Uganda as well. Early detection programs, using computer-based programs to bridge gaps like shortage of renal pathologists, and as we think of the Kidney Disease Institute, how to build capacity for some of these super specialized services like POCUS, interventional nephrology, etc. And of course, there are opportunities for collaboration. You can see up there now we have people in high places. So you see Professor Kalyesubla is now a regional board member. So we have people in high places. These are now possible for us. A few reflections for us. So this is the unfinished tower. So it is called in India. And this was built was trying to be built to mirror the structure on the right, which is probably the longest brick structure in the world. So one emperor was trying to build a structure to double the one on the right. And unfortunately, he died while just at the first step. Now, this is probably one of the most beautiful things you will see in the world. This is the Taj Mahal, very beautiful. And this was also built by an emperor. You know, he had a vision. He went and got an architect from Turkey, builders from South India, and it was built over time, very many years, and in memory of one of his wives that had passed on. Now, when you compare this and this, so one very ambitious man trying to build a tower alone, when he died, no one picked up. Okay? Another ambitious man collected people from so many places, an architect from Turkey, builders from South India. By the way, the Taj Mahal, if what I didn't say, has specific people that keep maintaining it to look the way it looks. So these are descendants of the original builders. And when you go there, you will actually see some of them. So it's a generational thing. People are still maintaining it. And just if you reflect these two things, I don't know if there is any message that you pick, but probably my message was that, you know, collaboration, patience, and knowing why, having the right reason as to why you're doing something will probably take you further than doing things alone in a hurry and just trying to beat the competition. Thank you very much. Just before I finish, one day, anyone thinks one day? We've already designed the logo. And a big thank you, of course, to Mega Life Sciences, all my mentors and teachers. Thank you.
Thank you, Dr. Chaze. Thank you so much. So, ladies and gentlemen, we have just one more talk. But is a nephrology suite? People travel to New Delhi. Others are on the regional board of the world. Others are former Bosco. So the young people, you're very welcome to nephrology. Actually, when I was many moons back, when I was a postgraduate student, fortunately, Professor Kaliesula was also a postgraduate student, but he was my boss. So on one day, I think on a ward round, a certain gentleman walks in and speaks nephrology, and also walks nephrology. And from that day, I think in our minds, separately, we decided nephrology is the best discipline to do. That gentleman is Dr. Emmanuel Sekasamvu. I think the story will be told by Professor Kaliesula tomorrow. So, and like they say, the best physicians are actually nephrologists. So the young people, please join. So I want to take this opportunity to invite our last speaker for the day. Then we break off for tea. I think for those who have been fasting, you can now unfast and drink water. So I want to call back Dr. Louis Nyende. I'm told he has no slides, but he's going to speak. Dr. Louis, you're welcome.
Thank you very much. Dr. Javida. It's experience, so I will not use slides. I'll begin my journey from starting to pursue nephrology. When I was a postgraduate student, there was an application for a research grant sent out by Dr. Kalye-Subula, and that was Rashots. So I applied with Dr. Grace Kansime, my classmate, and Dr. Iraguha Daniel and Dr. Chigundu. So on the panel, there was Dr. Kalye-Subula and Dr. Rebecca. So I got the grant, I got the money and wrote the article. And the other incentive was to publish and get another. So I indeed published. There's an article for TDF, renal dysfunction in Uganda. If you look out for it, it is me who was the first author. Yeah. So from that, I got interest in nephrology, and I joined the Uganda Kidney Foundation, which is one of the first steps you have to do. Get interested, get involved. Become a member of the Uganda Kidney Foundation. There's a lot to do, and there's a lot of mentorship to do, which I did. And once you join the Uganda Kidney Foundation, you learn about the International Society of Nephrology, the ISN. And using that, you also enroll. You become a member. There are many options where you don't have to pay money, and there are those that you're able to pay money. You become a member for ISN, which will continue to train you and also give you opportunities. So through ISN, I learned of an opportunity to be able to study nephrology in South Africa, Cape Town. And then I remembered I have some alumni and OGs who studied from there. So I reached out to Dr. Aujo, Caroline. And I said, how is South Africa? Is it a possibility? Can I be able to go and do nephrology there? And she said, it is okay. I have a mentor, I have someone there who can help you write a recommendation letter. So she introduced me to Professor Nicola Venn. So I started my journey through ISN. I wrote the application, but along the way you need a recommendation letter. So the people they know in nephrology is Professor Sekasanvu, Professor Kalye-Subula, and I needed a letter from the Uganda Kidney Foundation. So if I wasn't a member, I would start showing myself. So I got those letters from Professor Sekasanvu, Professor Kalye-Subula. I got the letter from the Uganda Kidney Foundation, Dr. Ogavu, a very good letter. All the letters were excellent. So I sent in my application, and they returned after a while, and they said, you are not successful based on your age, because you're over 30 years of age. And as I speak, I think that age has been removed, because they realized that in Africa we study late and all that, and I think that age bracket has been removed. So for the young budding nephrologists, start early. Don't keep postponing, because time waits for no man. So I got the reason. They told me, you are above 30. This is for younger people. I did not give up. I said, fine. So I informed another alumni, Dr. Kansime Grace, about it, because she had previously gone to McMaster University and she had had the experience. And she went there and COVID met her there. But also before that, I found out another alumni, Dr. Rose, and then Dr. Peace Bagasha. So I reached out to Dr. Peace Bagasha and I said, I really want to do nephrology. It's my passion. It's my passion. So Dr. Bagasha wrote a letter, wrote an email actually, and copied me in, wrote an email to the program director of the nephrology program in McMaster. She wrote the email introducing me. I filled the application. And after that introduction letter, they stopped copying her in and they started talking to me direct, emailing me. They said, you're interested? Okay, we'll do the interview in 2 weeks. So they called me at around 10 a.m. From Canada, the program director, and the interview was on Zoom for about 30 minutes. And they asked me, why do you want to do nephrology? What have you done? So I had to say, I've been moving along with the gurus of nephrology in the country, and I'm really interested. And they said, yeah, you will learn, but what will you put in practice? So I told them what I'll put in practice. 2 weeks later, they tell me you're successful. And I was happy. So they did not consider age or what, but they looked at the possibility and the future and the vision and the commitment to come back to Uganda. So based on that, they gave me the go-through, and I thought it would be a bed of roses. Unfortunately, it wasn't, because application for a Canadian visa, my God. The first application I did, I filled so many forms and waited for a year to get feedback. After a year, they tell me that the form I apparently used was wrong. After a year. So I sit down and say, now, let me look for someone who helps people go to Canada. I looked for an agent. We went and sat in his office at around 10 p.m. and filled the form. Because in that letter they wrote, you filled the wrong form, please fill the other forms. But meanwhile, the McMaster University had sent me everything to apply. So we filled the form again, and within 2 weeks, they give me a report and say, you are successful, and please bring your passport. And I was happy. So eventually I went to Canada, but the vaccinations, all those procedures are tedious. Please don't give up. At one point you feel like giving up. The other thing is the institution that was determined to have me did not give up. They waited for me for 2 years. And they kept emailing, what is happening, Louis? What is happening? And I kept telling them, visa, visa. They said, no, we are waiting for you, we're waiting for you, we're waiting for you. And they kept the place. And eventually I landed 29th December 2023, never experienced winter. I landed in winter. It was very cold. And you had to process police letters, Canadian letter, for registration in the service, so that you're able to touch patients. Actually, Canada is different from the US in that you actually touch and interface with patients. You take the first step of assessing and seeing the patient, examining them, and then the lecturer or the professor comes and listens to what you have to say, and you have a plan together. So the other shock was the electronic medical records. There is nothing like documentation. Everything is electronic. So you see a patient, and everything is electronic. There's no paperwork. You just open the system, and every information about Louis Nyende comes out, and you see all the doctors that they've seen, all the tests and all that. So that was another shock. I took another 2 weeks or 3 weeks to get used to that. And after all that, they give you their residents and SHOs and the fellows to teach you how to do that. And then the areas, you rotate through about 4 or 5 hospitals, and each hospital has unique things. There are hospitals where you'll have a specialty and it's only acute kidney injury. You'll go to another hospital that has only dialysis patients, hemodialysis and peritoneal dialysis, and then you'll also have wards that have renal transplant. Okay? So you rotate through these 2 weeks, 3 weeks, 1 month, and there you're working like you're part of the team. There's no saying I'm a foreigner, I'm what. You are part of the team. You're bearing the pain, you're bearing everything. And you're having, the other issue was the pager. The pager, you had to move with the pager, which was like a mobile phone, and it kept ringing, and you could get tachycardic and all that. And then you have to respond. The calls, you work from 5 p.m. until 8 a.m. in the morning. The weekend calls were terrible because you had to work from Friday 5 p.m. up to Monday at 8 a.m. 72 hours? 72 hours. And while there you're on the electronic call, you're receiving calls from the city center about dialysis patients, this one, and you're entering the records and filling in the forms and all that. So it was rather hectic, hands-on, and time. You'd always look forward to the weekend because it was really tedious. The culture, the food, initially, I said, I don't eat this type of food, the burgers and the likes, but I realized 3 weeks, 4 weeks, I was starving. So I just started eating and saying, you have to survive. Covering yourself with 3 blankets and all that, and later on things went on well. Initially, the first 3 months, they assess you to see whether you are really an internal medicine specialist, as you say. So they access you on internal medicine before even you get a certificate and an allowance to go ahead. And during the assessment, what I learned from them, their SHOs don't do like end of semester, rotation exams or what. They do a continuous assessment, like what we are seeing now in the secondary curriculum. They do a continuous assessment. You meet some cases this week, you write up and you send to the professor and you say, I saw a case of glomerulonephritis, this is what I did, this is the plan, and they give you. So they do a continuous assessment every week for the students and what. And then the other thing is the privacy of the patients is very key. Sometimes here you come and do the ward round and one patient is here and the other is here. One time we did a ward round and we were mentioning that this gentleman has syphilis, and later on the gentleman came, I was in internship, and he said, Musa, oh, Mwanswaziza, you said I had kabotongo and all that. So in the developed countries, there's privacy, and what they usually do is they don't discuss cases in front. They sit somewhere, and then you talk about the patient and all that somewhere else, and then you go to the patient bed. And then landing into a land of availability where everything is there. I showed you the WHO building block, and I assure you, everything was there in Canada. Everything coordinated. There is no excuse for saying I don't have. If you want an MRI, today you request it, have it, and then they give you the results there and then. You want a CRP, you'll have it. You want a kidney biopsy, you'll have it. And then there's lots of super specialization. You have the interventional radiologists, you have the vascular surgeons, you have lots of super specialization. So from all, actually one time, one of the nephrologists asked me, but you're learning all these things, how are you going to apply them? I did a presentation on nephrology in Africa with a focus on Uganda. I did the presentation, I told them how far we have done. By then we had only 1 kidney transplant, but I'm happy now we have 5. I showed them the picture and they were happy and excited. They said, please, whoever is willing to come for nephrology, I'll just do what Dr. Bagasha did, recommend someone, and then they are willing to take you on. Thank you very much.
Congratulations once again, Dr. Lewis. Without wasting time, may I ask the previous speakers to kindly go up here, and we have a brief Q&A session before we break off. So, Lewis, I know we had one from Dr. Sechitoreko, so for him he left. Yes, Dr. Chaze. Our president, and so any burning questions, please? Oh.
Thank you very much, Dr. Javira, and thank you so much, the presenters. It was such a lovely array of information. My question is to Dr. Atuhe, who is not there.
Anyone will answer.
Okay. Maybe Dr. Oga will answer. I wanted to ask about the... Dr. Atuhe, my question is to you. I was interested in the xenotransplant because if xenotransplant actually works, Uganda has a lot of and for sure, I think it would give a lot of opportunities to Ugandans. So what is your comment on the xenotransplant and what are the chances for a country like Uganda to do this?
Thank you.
Thank you very much. I also have a question for Dr. Trey and maybe Peace. And Professor Frank has left. So I know that the current people that are doing transplant are free of charge, but like we agreed, someone is paying bill. So for Ugandans now who may have their money to do a transplant, would you take them? I know you've told us about the safety and why you wanted this to be successful, but if India wants 100 million, would Uganda take 60, 70? When are you opening this up to those that have the money above 60 but have the money and can transplant?
Thank you.
Yeah, thank you so much. My question goes to Dr. Lewis. In his presentation about the selection criteria for the transplant patients. My question is, when you're presenting, you said patients with blood group B may take a longer time to wait. So I wanted you to explain why is it that those patients may end up taking a longer time to wait than patients with other blood groups. Thank you.
Thank you.
I think mine goes to the president. I have been taking evaluation of the whole thing. I'm not a doctor myself. Everybody's calling me a doctor, but I'm sitting with a doctor. I'm not a doctor. Let me stand up. I have been carrying out evaluation since morning, and I'm realizing that kidney disease is a big killer in the country, and I'm a victim of a kidney. Dr. Grace said it is the 5th killer that lady, that doctor there in the country. Then this gentleman who came last, who was not in the program, he said it was the 10th. Big as it is. But also little is known about this killer disease to the population. And we are keeping quiet about this. Many people are dying of this disease when they are not even aware. Someone gets a problem, he swears in the legs, they say he's bewitched, he goes on herbs, they bury. Now, so many people could be dying of kidney diseases. That is the bad news part of it. But also the good news I'm realizing that there is too much information in the country. Many doctors who are here, all of you, I didn't know we had such a massive elite doctors in the country, the way we are. You are rather, I'm not part of you. But also the good thing, it is preventable. Once you prevent diabetes, once you control pressure, once you control HIV, you can live longer even if you have it, or you can decide not to have it anymore. So it is preventable. But also it is manageable. If you have it, you can manage it. Like the way I'm managing it, I have it, but you don't think I'm a patient. And I'm managing it. But also, government has given support in funding and policy. I have been wondering as I'm seated here, why are we keeping quiet over these things? Now this function here is just a World Kidney Day, but on a scientific conference. That means scientific conference is too technical. I could be the only lay person in this room maybe. We didn't introduce ourselves. I don't know how many of you are lay like me, but most of you are doctors and nurses and the rest. Now, if you are celebrating a World Kidney Day, why don't we have it like we do for Women's Day, we do for Labor Day, we do for HIV Day? We just go to Mbarara, we go to Guru, we go in a playground, we put tents, people come, they give testimonies. We want to see people we give people testimonies, people who have had transplant and they are living for 10 years. There are people who are on dialysis, they have lived for 10 years, they are there when you Google. But someone said people in dialysis, they have given up and dying, but others have lived for 10 years. Why can't we have those testimonies? Why can't we have testimonies of people who have donated and they are living very well so that people don't fear donation? So I would think, why don't we separate the two? Why you can have your scientific, like a day for this, for you, the gurus in medicine, but also we go to the public and we tell them what we are doing. We are doing very many good things, but talking about ourselves. Now, who is benefiting from all this in terms of the communities? You are enriching your own selves, but the communities are not aware of what you are doing. Is this thing even live coverage? Is this live coverage? Is it on TVs and whatever? Maybe that. So me, I think, President, can we change the approach and go to the population and create awareness? We make drums. When the government drummed against HIV, everything reduced. Now that one has stopped, it has again gone up. So if you also made a similar drum against kidney things, I can assure you can be able to contain it and control it. Thank you.
Thank you so much for that. I think it was fully loaded. So many questions, so many concerns, and it's, I think, touching all of us. Actually, just to supplement, one testimony, in one of the centers where I trained at, there is a lady who had a transplant in 1971. When I went to train in 2012, she was coming back for review on the same kidney. And that hospital was using her as advocacy, that you can live longer. Unfortunately, she died recently because of COVID. Those are over 40 years. I think not 40 or 50 years of a kidney. So thank you so much. And President and maybe the former presidents will address the concern. Any other burning questions before we take? Maybe we could first get answers from those. I'll leave one mic there, one here.
Thank you very much. I've been advised to address this while it is still very hot. Thank you, our friend. We are also glad that you said you're a patient. Yeah. We are glad that you're painting another image of what a patient is like. Someone would, I think they would lose if they betted on you having kidney disease. You don't look like it. So we thank you for taking care of yourself and whoever is taking care of you. Thank you very much. I'm going to call it anger. I like your anger, sir. And we actually, we want to burn people's hands and fingers, and we want to annoy people. So I'm glad that even this is annoying you. We want to annoy more people so that we get space in their minds. Because as it is, like I mentioned, they don't gather information about kidney health from Health Center 2, 3. They gather about other things which are very good. Perhaps they were not gathering them in the beginning, but they made good noise, and now they became important. So we are pushing for policy changes so that they can include gathering kidney disease in the health management information health management information system, HMIS. So why are we quiet about such a big problem? We were even quieter. We were sleeping before, and we are talking more. And we would like to talk with you. So I invite you, any ideas like the ones you've given us are very welcome. We are not always here because we have to balance the science and the community. So we're in Mbarara 2020, just before COVID. I think after us, the shutdown. So in Mbarara, we went to Mbale. Last year, we were in Lira. So how we do it, we do science, then community. Science and community. And so this year, we've come back here. Next year, we shall be somewhere else. We would appreciate someone participating in us choosing where we go. It definitely takes resources, but sometimes along the way you get those resources. So we are not only always here, but any chance to sensitize is certainly very good. You've urged us to play the kidney drum. Yes, and we are looking for patrons. Prof. Kalius will always tells us how they convinced to start dialysis, to cover dialysis. I think one of the senators got sick, and he actually had to transfer the whole dialysis machine to the Senate and get their eyes there, and then their eyes got opened and it got onto the NHIs, as they call it. So we need a patron. Many times we thought, by the way, that we have gotten. I can tell you we've treated ministers and big people. They are not close enough. I'll tell you, I've almost selfishly asked, who needs to get sick in this country for people to understand that the kidneys are serious? So without going that route, which is quite ominous, we need patrons to hold our hands. I'm glad that in this meeting, we've had a commissioner commit to holding our hand in this. That's a big step. So anyone you have, we shall be glad. So we need champions like you to go on media, advocate, and participate and prevent people getting sick. So perhaps we are still doing baby steps, but we welcome any idea that makes us go further.
Dr. Peace, you asked about xenotransplantation. Okay, so for members, you've heard us talking about kidney allograft. You've heard us talking about autograft. Now there is xenograft. So autograft, yeah. So you have tissues. You have tissue from the same person going to the same person. Say, for example, skin grafting, right? So from the thigh to the face, you know, from the areas that you know to the head, which have hair. So that's autograft. Allograft is between similar species. So related, cousins, brothers, non-cousins, no problem. But similar species, Homo sapien to Homo sapien, for example, or a pig to a pig, cockroach to cockroach. Then now, xenograft, you have with different species. What we've seen so far in the last 5 years, what has happened in the US and the UK, is pigs have taken center stage. Unlike in Uganda, where they are taking center stage on top of charcoal, these things are taking center stage in saving lives, right? So we had a cardiac transplant from a pig. We had a kidney transplant from a pig. Some of pigs have been our friends for a while, because remember, even insulin, we had Then even the ones for these surgeons, which they use for catgut, they use sheep and then pigs. But you can imagine, so they've been our friends. No wonder when it came to looking for someone who can, something which can give us another organ, we turned to the pig. So little piggy is actually, it is changed. The mRNA is changed to be able to accept or to be able to be seen by your body as your own or something close to human. And that, of course, as you can imagine, is not a very cheap feat. Then the patient is prepared in a way like any other transplant, and the transplant takes place as if a deceased donor transplantation. Because you can't put the pig there and you cut and open from here. What that means is that the resources involved in that particular process are not cheap. It's not your usual transplantation. There's a lot of modernization in it. The resources, of course, the human resource, the money, I'm sure the theater is even different. I have not gone to a xenotransplant center, but I can imagine how it would look. So when I think about the potential barriers to xenotransplantation in Africa or in Uganda for that matter, resources would be the first thing. And I'm thinking about human resource. We do not, the pigs we have, that's why I've said human resource. Pig sources we have, but we have to change them. And then monetary resources are not available for that. Already we are having only 5 in 2 years. They've done only 3 in 5 years. You see? So even them, they are doing what we did in 2023. It must work, it must work. The other one died. Now we have one living one. I don't remember the duration, but one made it up to 2 months. So I think there are baby steps in that area. There's still a lot to learn on their part, and of course, inevitably on our part as well. Then, for those who can pay, can Mulago National Referral Hospital accept them for transplantation? I think that was a question that Peace might be in a better position to answer. I would invite one of my seniors to also comment about xenotransplantation in that particular area.
I can make a brief comment about xenotransplant, but maybe my colleagues will add on. Like my colleague has said, it's a highly complicated procedure, and I think it is way far away from us. They use, because you have to change the genetics of the pig structure. And what they do, for those of you I think who have been reading the latest molecular techniques, there's what they call CRISPR-Cas, which is a kind of gene editing tool. So remember the genome project, I don't know if some of you know the genome, where they mapped out our genome, the human genome. So they also mapped out Mr. Piggy's genome. So you know where you're going to cut what is different from the pig and then insert what the human has into there. So that is the CRISPR-Cas in summary. And in so doing, you're basically preventing what is talking about, the rejection. But it's not as easy as said. So it's a whole complicated procedure. Now, on the other end, as they are doing that, the animal enthusiasts are also fighting the battle. Because there are people who take those animals as their pets. You've even had stories of people who have given their wealth to a pig or a dog. So there's that war, that why are you interfering with animal rights? The third one is probably transfer of infections, the zoonotic infections, that we do not know. Remember, you're going to put these patients on immunosuppressive, so you don't know what kind of infections you're going to create in the humans. So there are all those aspects, and then of course the legal aspects. But before I ask my colleagues to take over the other questions, we needed a comment about our colleague's concern from our past president, Dr. Sekasamu.
Sorry, colleagues, for delaying you, but I think it's for a good cause. You heard it loud and clear from our delegate here that we are not doing a good enough job in sensitizing the public, probably as well as the policymakers, about kidney disease. To cut the long story short, a couple of years ago we were not here. When we introspect and look at ourselves, we have made giant steps. Although they look baby steps, but they are giant steps. And first of all, the target was to sensitize ourselves as care providers and interest ourselves in the field of nephrology. A couple of decades ago, internal medicine or medicine was hijacked by an infection called HIV. And everything in medicine therefore became HIV. All the funding went into HIV. And if you didn't have HIV in your terminology, you wouldn't get funding. I know that has become a little bit less. Nowadays, people are recognizing specialties like cardiology, neurology, oncology, and others. So in sensitizing ourselves, what we say and what I tell you today is that each of us who is here as a nephro care provider, the duty is yours to reproduce yourself, to make other people passionate and follow your practice so that we can multiply our numbers. 2, we have gone huge steps in sensitizing the policy providers. Like if you were here in the morning, we said we have presented in Parliament about kidney disease. Fortunately or unfortunately, we have had some members in there who have fallen sick and have been our patients. So they have been part of the advocacy tools that we are using. We have an organ transplant bill or act. And that organ transplant is not only about kidneys, it is about other organs as well, corneas, hearts, and others. But it was spearheaded by us, the kidney people, because we were at the leading edge of this practice of organ transplant as one of our therapeutic tools. We have done medical camps, and we have called the media to attend the medical camps. If you look at us here now, we have one camera, which is probably going to give the news. But if I request you to go and switch on your television this morning, or this evening, I know you are going to see more about elections in Kawempe than World Kidney Day. So even in our effort to sensitize the public, we find a lot of obstacles, or people who choose to listen to their kind of stories that entertain them other than listen to us. Otherwise, what you have said, medical camps, sensitizing people, we have done it. We are going small steps, but we know we are making positive steps. What I must say is that there's a lot of nephrology out there, which is more than nephrologists, which is more than dialysis, which is more than the nephro nurse, which is more than transplant. Transplant will make a lot of noise in the kidney care. But actually a lot of our patients need preventive care in kidney disease. They need conservative management for patients who have chronic kidney disease so that they don't go onto dialysis, and you've told us that you are one of those. So we are making small but baby steps. And then the other thing we have faced is that a lot of times we have appeared in the news. I don't know what the news people are up to. Maybe they want to make money. They always publish very negative stories about our services. A doctor who stole an organ from so-and-so, a patient who was trafficked to India or Saudi Arabia by so-and-so. And this is a very unfortunate aspect of our public. But those are the kind of people we have to live with. But I think we are trying within a difficult circumstance. Thank you very much.
Thank you, Dr. Sekasamvu, for inviting. I hope you get... yes, we can continue with our...
So, blood group question. It's good the gentleman is just walking in. About the blood group, I mentioned that in Canada they have an electronic medical records, and they almost know entirely everyone's blood group. And the notice, from the research and the findings, they found that patients who are blood group B, when transplanted, they tend to have other issues, other autoantibodies that may cause rejection. And so if a patient was on dialysis and they have blood group B, there would be their waiting time on the list would wait. And then to answer that again, the second question, the second way of answering it, I myself am blood group B, And one of my daughters got hemolytic jaundice, and during the time to try and rectify and give her exchange transfusion, I had to donate my blood. But unfortunately, when we gave the blood, the reaction, the jaundice tripled. So people with blood group B, in addition to these other antigens that are not known, because of all those risk factors, giving them immune suppression and desensitization, you'll have issues. So that's why when you have blood group B and you're on the waiting list, you take longer, because they have to make sure that there is no reaction. We want to transplant someone. If someone is blood group A, we want them to be transplanted with a person with blood group A. Thank you.
Was there another question for them? Actually, just in addition to what he's saying, in some centers now, they are even doing what they call transplant across blood groups. So for example, blood group A might receive from blood group B, and vice versa. But that's a lot more complicated procedure. So any other burning questions before we break off? So yeah, I'll take maybe 3 and then we close, because it's late. So 1 and then 2 and now I see, okay. Very brief ones, please.
Thank you. To the transplant team, I suppose that after death, there is ischemia to all organs. So when do you start counting time of ischemia if the donor is deceased?
Okay. Thank you.
Good afternoon, everyone. I'm asking, can someone get 2 kidneys at once when he has compatible donors?
Very interesting question. I think it goes to Dr. Atuhe, right? Oh, no, he has unfortunately left. Professor Kaliasubula? Dr. Atuhe, that's your question.
Thank you very much. Mine will go to Dr. Peace and also maybe Professor Kaliasubula in the bid, maybe in the bid to elevate as we are seeing that we are fighting for the nephrologists, how about the future of nursing? We have in the nursing nephrologists, because I think we need that specialization to move along with, because we are seeing more private sectors that are coming up, but they're just having people that they're just giving dialysis and they even don't have the knowledge behind it. What are we doing to see that also the nursing part is enhanced in nephrology, to see that these 2 teams move along properly, so that the patient outcome is enhanced in the country?
Thank you for that question, and I think I'll start with Dr. Peace to answer that question. She has an answer for you.
Good evening, everyone. My name is Collins Katshabe. I'm an intern nurse. My question goes to Dr. Sekasamvu. I would like to ask if there are any mentorship programs for people that are interested in the nephrology field, because as you presented, you said there are gaps of personnel and there are people who could be interested. So how are you planning on mentoring them into the field? Then also, how do you plan on inspiring them? Because some of the inspiring platforms are like these ones, and usually they are attended by the people who are already there, and there are few students or people that are still this side in the profession. So how do you intend to inspire them and mentor them into the field? Thank you very much.
Thank you so much. Now, I beg for forgiveness. There is a burning question here from my brother.
Okay.
It's the last.
Thank you, Dr. Javira, for giving me the. All protocol observed. My question is one. As a pluripotent cell, my question is to Dr. Lewis. What is the financial implication of the training post-MMed? Thank you.
Okay, thank you for the questions. I want to, before the high table answers, let me start with Dr. Peace.
Thank you very much, Dr. Javira. So I have two questions. The first was about the cost for transplant for the Ugandan who wants to pay. So the plan is that initially when we started the program, because no one had ever done it, everything was new, it was kind of difficult to ask people to come and do transplant when they didn't know what the outcome would be like. So now that we've had success, we have more confidence to get people who are willing to pay involved, and actually people are actually showing that they are willing to pay. So with time, we are going to develop a structure for what people would pay if they would come and do transplant. We don't know what the price would be. We think maybe it would be somewhere between 50 and 100 million, which is cheaper than going outside countries. But that information is not yet out because we don't have a cost analysis, like you said, having an economic perspective of the program and to see what to charge people. So that one is not yet ready. We don't have a final answer for that. And then the question about nursing. So we are actively engaging the nursing field to acknowledge specialization. Because as you well know, we train nurses, they get a certificate in dialysis, and then they transfer them to Mwana Mujimu. It's not that Mwana Mujimu is bad, but it's just you lose your experience, you lose your zeal, you lose you're de-energized, essentially. So we really want the government in its structures to acknowledge and to recognize specialist nurses so that if you're hired as a specialist dialysis nurse, they cannot transfer you to a different area. So that's where it would actually start from.
I think now, Dr. David Atohe, you had a question.
Two, actually. Someone asked if it's possible to get 2 kidneys at the same time. I think you meant as a recipient, correct? Okay, so in living donation, that is wasteful because the science behind when we do that nuclear scan for the donor's kidneys, normally the donor's kidneys are split near halfway, okay? Not the kidneys work about 50% of their abilities. So you find one doing 58, the other one doing 40, 42, or some 63, or 55, 45. Now, when you transplant a patient, this new kidney actually goes up to towards 90%. I'm using percent meaning EGFR, okay? So it actually does the work of 2 kidneys. So if you give someone 2 kidneys, you're wasting. You're wasting someone else's potential what? Potential kidney. But in deceased donor, however, it has happened before, as much as it is normally in places where it is not regulated. So in places where it is regulated, when you have a patient have a cardiac death or a brain death and they harvest both kidneys, there are 2 patients on the waiting list that should benefit from those 2 kidneys, not 1 patient. Normally, the institution that has harvested keeps 1 and then gives out the other to another one who is on the waiting list. Okay? Or if it is a national waiting list, they both go to the waiting, people who are on the wait. That means that you can't just waste 2 kidneys. Someone will always be there waiting for the second kidney. But in areas where it is dysregulated, it can happen. And that's acceptable, but ethically not correct, because there's equitable access, there's access to the transplantation, equity, those things that govern the ethics of transplantation. Called ischemic time in transplantation, person who's deceased. So I am assuming you're looking at this patient who has died and the blood has stopped, right? They haven't clamped yet. Eh? And you're thinking now, is that deceased time? Is it cold time, warm time? What time is that? It is no time at all. If someone dies, they've died. Remember, the donors in a deceased donor program are brain dead or cardiac dead. Circulation must be seen to continue, either by an external circuit or by medication in brain death. You see, if someone is brain dead, do they have a pulse? Yes? They have a pulse. So the kidney is receiving cardiac output. Sindio? Yeah, so the eyes are, the corneal reflexes are gone, everything is gone, but the heart rate is still going on. The kidney is still receiving cardiac output, regardless of. That's when you hear, but the machine was saying, tweet, tweet, tweet. Then they've said the patient is dead, they are lying to us. It's because we have not done enough what? Enough teaching. People think when the machine is saying tit, 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 then you say the patient is brain dead, you have killed the patient. You see? So brain death, it is still ongoing. The kidney is still receiving cardiac output. So the idea there is a quick response team. If the patient had said they are going to become donors, the quick response kicks in and they come and they harvest. It is called harvesting, as much as that sounds as like it's millet. They harvest kidney, pancreas, liver, lobe, cornea. They take. For cardiac death, it's even worse. That's why you see, if you compare brain death and cardiac death outcomes, there's a bit of a difference. It could be because of that perfusion issue, it could be because of that sluggish flow, because it depends on how fast the team comes in at that point. So, the cold ischemic time still remains the time when they clamp the renal vessels by the harvesting team, up to the time when the kidney is put in what? The cold ice, and is flushed with the Wisconsin what? Solution. Okay?
Thank you, Dr. Tuhe. I think we have one last response from Dr. Lewis.
Okay, thank you very much. Financial implications. First of all, these networks help us meet different people. I would like to acknowledge the farmer that supported me during the training. I'll mention Mega, Life, Alan, eminent farmer. Thank you very much. And so those are people that you'll meet here. You need about 10 to 15 million before you go to cater for the visa, the medical issue, vaccinations, to pay for the 10 to 15 million. But you may need more based on the financial issues. And you go and have, maybe you're not on government, it means you're going to be a student for 1 year. You don't have any income whatsoever. So you'll be a student 311. But if you're on government, you apply for study leave and hopefully you get some allowance. Yeah, thank you very much.
Okay, thank you so much, Dr. Lewis, and thank you so much, the panelists. We've come to the end of today's session.
Mentoring you into nephrology. In nephrology, I think the only specialty where we don't believe in one bull on the hill. It is where we are very generous with our knowledge, with our contacts, with our money, And we want to build the expertise, and we also want to build the service in this country. All you have to do is be interested. Contact any of us, and for sure you'll get there. We can't force people to be interested.
Thank you so much for that. So, ladies and gentlemen, on behalf of our president, Dr. Ogavu, allow me, I don't know if you have any closing remarks. No. I want to take this opportunity to thank all of you, first of all, for sticking around up to 6 p.m. I think we overshot by time, but I think it was worth it, isn't it? Mm-hmm. We shall have a lot more interesting talks by interesting speakers. One request, I think, is to let's try and keep time. The first talk, according to the program, is at 8. And for the speakers, let's try and keep time. I think the time is 15 minutes. So if you know 15 minutes means roughly between 15 and 20 slides. So please try and keep time for us to arrive on time, but also the speakers. So with those few words, thank you so much for having attended today's session. Let's go out and advocate like what we've been advised. And there is tea before you go. Thank you so much. And thank you, panelists.